Okay, good evening, everyone, or good afternoon, everyone, or good morning, wherever we might be. Um, my name is Dr. Babali, and this is the Concept Academy, and we are starting the dermatology rapid review. And this is a list of the topics you are going to be covering. So the first thing is to start by talking about the layers of the skin, and this is already what we are familiar with. We have the stratum corneum, which is the topmost part, the stratum lucidium, the stratum granulosum, the stratum spinosum, and the stratum basale, which is the last part. The skin is the largest organ in the body, and it provides a barrier and immunological protection. Because it's a barrier because it covers the body, you know, protecting the external environment from the innermost layer, blood and the other tissues. And it also confers immunologic support because it contains some particular cells like the Langerhans cells, that helps us to fight infection. It helps to regulate temperature because it can allow for evaporation and cooling, and at the same time, fluid and electrolyte regulation. So, if an individual suffers burn injury, the person can suffer hypothermia because of dissemination of heat, and at the same time, the person can have fluid loss and electrolyte loss, leading to fluid and electrolyte derangement. So, the skin is very important to protect us from this imbalance. It also allows for touch and sensation because it contains some sensory nerve endings, the Langerhans, the personal capsule, the Messner capsule, the free nerve endings that we are familiar with, which helps in the sensation for touch, pressure, vibration, and the likes. So, moving on to the lesions in dermatology, depending on the appearance, we can classify these lesions into different types, how they look like. So we have the flat ones, which includes the patch rather, and the macule. The flat ones, the macule and the patch. The macule is flat but less than 1 cm. The patch is flat but more than 1 cm. The papule and the plaque. The papule and the plaque, both of them are elevated. The papule is less than 1 cm. The plaque is more than 1 cm. I know we already know this. I'm just going to glance through it. The vesicle and the bullae, they both contain fluid, right? But the vesicle is smaller than the bullae. The vesicle is less than 1 cm. The bullae is more than 1 cm, just like we have here. We can have some of those lesions containing pus, and that's what we call the pustules, right? Pustules containing pus. Um, we can have a cyst. We don't have a picture here, but a cyst is just more like a swelling that contains it can contain different things. It can contain keratin, can contain granulation tissue, depending on the type of cyst. But the major important thing is that it is lined by an epithelium. So, example of that is a follicular cyst. We are going to talk about epidermal inclusion cyst, and the likes. The wheal, the wheal is just a transient edematous papule or plaque. Transient is a word for the wheal, and this is what they look like. So if you see a picture looking like this, you don't even need to be waiting for the time. This is how the wheal looks like. So you want to think about, does this person has a drug reaction, or the person has a bee sting or something causing this urticaria or wheal. The next one is the scale. Scale is just like flaking off of the stratum corneum. So you have this scaly deposit. Once you see scale, it changes your diagnosis entirely. And we are going to talk about that. Crusting. Crusting is just drying off of exudate. The exudate could be pus, it could be blood, it could be serous fluid, it could be different thing. But once you have rupture of a collection and the content, maybe pus, maybe blood, maybe serum, dries off on the surface of the skin, you call that crusting. And when you say crust, the first thing that should come to your mind is impetigo, particularly in young children. So this guy here now has impetigo. So let us look at the hypersensitivity reactions. We are very familiar with them. We have about four: type 1, type 2, type 3, type 4. They are just exaggerated immune response to normal innocuous stimulus. Antigens that are not supposed to drive immune response, they are now driving immune response. That is hypersensitivity. Let us ignore this table. We don't need it. So moving on to the hypersensitivity, the type 1 is the anaphylactic and the atopic reactions. So we have to be familiar with the mechanism. This is just like a reminder. We know it. So it's mediated by antibody. Which antibody? IgE. So type 1, type 2, type 3, they are all mediated by antibodies. Type 4 is the only one that is not mediated by an antibody. It is mediated by the T cells. So we can say that type 1, type 2, type 3, they are humoral driven, while type 4 is cellular driven. The type 1, which includes the atopic disease, atopic dermatitis, asthma, atopic conjunctivitis, and anaphylactic reactions. All of them come under the umbrella of type 1, and what is causing them is IgE stimulation. So the individual is already sensitized, to that particular antigen, probably dust, drug, anything, and you have IgE produced against that antigen in the serum. The next time the person gets exposed to that antigen, you are going to be having like a cross-linking of the IgE attached to the mast cells, because the IgE have receptors on the mast cells, so they can attach to the mast cells. So they are waiting there for the antigen to come again. So once the antigen comes again, it's going to bring about cross-linking of two IgE on the surface of the mast cell. We can see the mast cell here. We can see the IgE. So the antigen comes the second time, cross-links the IgE receptors, the IgE molecule, and brings about eventual degranulation of the mast cells or the basophils. When they degranulate, they are going to release histamine, they release prostaglandin, they release leukotriene. That is going to stimulate the corresponding lesions or the responses. But we are not stopping there, because you have to remember that it can be early or late. In the early one, mediated by mast cell or basophilic degranulation. In the late, you talk about the eosinophilic response. So the eosinophils will now be stimulated, and they will release their own chemokines that's going to cause eventual tissue damage and inflammation. So don't forget, anaphylactic or atopic reactions driven by both the mast cell degranulation, the basophilic degranulation, and your eosinophilic response. And the eosinophilic response comes later. We've talked about the different types: anaphylaxis, asthma, urticaria drug reaction, which is going to present as a local wheal and flare. Anaphylaxis, you cannot go to your exam and you don't know anaphylaxis, or you don't remember anaphylaxis. You see the patient after taking a drug, having a bee sting, suddenly develops edema because of the histamine. Histamine is a vasodilator, allows fluid to go into the body from the vasodilation and the increased vascular permeability. So you have swelling mouth, swelling neck, causing difficulty in breathing. The person becomes dyspneic, starts presenting with wheezing. You see somebody that is wheezing, that is edematous, that is having hypotension. You think about anaphylactic shock. And the next thing you want to pick in the question is what? I am epinephrine. I am epinephrine. If the person is having asthma, urticaria, you can think of the other anti-histaminergic agents. You want to give dihydrophenadine, you want to give, loratadine, you want to give hydroxyzine. You give antihistamine if it's the other ones, but if it's anaphylaxis, I am epinephrine. The type 2 is also antibody mediated, but it's solely your IgM and your IgG, not IgE. So you have some disease condition that is mediated by this type 2 hypersensitivity. It's just happening for no reason. We are not doing anything to ourselves. They're just happening like that, spontaneously, but they are mediated by IgM and IgG. And what are these disease conditions? I don't think we have time to be classifying them, but if we go back to our step 1, remember that it's classified into the inflammatory ones, the ones that affect downstream response, and the ones that are destructive. So for the inflammatory ones, think about things like rheumatic fever, right? Because of the cardiitis, arthritis, there's inflammation. So you are producing IgM and IgG towards the cardiac antigen, towards the joint antigen. Rheumatic fever. You could have the some of the disruptive ones like IgM and IgG being produced against red blood cell antigen, like in people with autoimmune hemolytic anemia, in people with erythroblastosis fetalis, right? In people with hemolytic anemia of the newborn, that's erythroblastosis fetalis. It can also occur in people with blood transfusion reaction. That is also a type of type 2 hypersensitivity. The ones that affect the downstream receptor action, your IgM and your IgG is affecting downstream receptor action, includes your I don't what's the word I'm going to use now, like some autoimmune disease like Graves' disease, in which you have excessive production, right, of your thyroid hormones. So that's like driving that reaction mechanism in the forward direction. Graves' disease. Sometimes they can drive them backwards. You are causing like a backward reaction. You are not allowing it to go forward, so you are not going to get a positive response. If you are driving it backward, you are not going to get a positive response, and you are going to get a negative response. So that can occur in a disease like your pemphigoid vulgaris. So your desmoglein are being destroyed. You are not producing the desmoglein again, and the person will start having epidermal separation. So your pemphigoid vulgaris is a type 2 hypersensitivity. Your bullous pemphigoid is a type 2 hypersensitivity. Your Graves' disease is a type 2 hypersensitivity. Type 3, just think about immune complex. The antibody and the antigen, they are now coming together and they are depositing, in the tissue, causing damage. So it involves the interplay of your complement, your neutrophils, all of them come together and they mediate that inflammatory damage. So think about diseases like your rheumatoid arthritis, your SLE, your polyarthritis nodosa. You can't forget that. Antibody against hepatitis B and hepatitis B antigen themselves, they are coming together, depositing in blood vessels, causing polyarthritis nodosa, which spares the lungs. Don't forget about that. Spares the lungs. Your immune complex glomerulonephritis, I know we know this. It's type 3 mediated. Your SLE, your rheumatoid arthritis, your reactive arthritis, Athos reaction, serum sickness, all of them immune complex. Then your type 4 is the one that is mediated by your T cells only, your T lymphocytes. And tuberculosis skin test is an example. You introduce tuberculosis antigen and you wait for the T cells to come and respond to that antigen to cause an induration. That's a delayed cell-mediated type 4 hypersensitivity. Your transplant rejection, but you have to be careful here. If an individual has hyperacute transplant rejection, that's going to be under type 2. Because if you remember the mechanism of hyperacute, it says presence of preformed antibodies, type 2. But if it's graft versus host, that's going to be under your delayed, because it involves your T cells majorly, so don't forget about that. Your contact dermatitis, particularly the allergic contact dermatitis, not irritant, the allergic contact dermatitis is under your type 4. So enough of all those boring talks. Let us move down to the lesions. So the first one we are going to be discussing is atopic dermatitis, which we also know as eczema. So this is a chronic inflammatory dermatitis that can affect children, infants, but it can affect adults, it can affect children, but it's very common in infants. And the pathophysiology is problem with filaggrin. So filaggrin is more like a protective support framework in the skin. If there's problem with filaggrin, you have desiccation. Water can escape, the skin becomes dry. The keratinocyte will start dying, and there's going to be inflammation. And the inflammation is going to lead to pruritus. When there's pruritus, individuals start scratching, and then there will be eventual lichenification. So don't forget, atopic dermatitis, think about the filaggrin that allows for escape of water because it compromises the integrity of the epidermal barrier. So there is escape of water, the skin becomes dry. There's inflammation, which brings about the pruritus and eventual lichenification. So what are those things you are looking out for? A dry skin that could be erythematous and it is pruritic. And what lesion are you going to be seeing? your papules, and your vesicle. That's all you need to remember. And I have it here. Papules, vesicles, dryness, and the puritic nature. Think about atopic dermatitis. Now, what is going to consolidate it for you is now the age group and the distribution. So, if it's an infant, you tend to see it more in their face. So, you can see this tiny, papules and vesicles. You see some of them containing fluid, you see some of them not containing fluid. So, that's why you call it papule vesicle, so papulovesicular rash. In the face of a young child, think about atopic dermatitis. If the person grows, and the person becomes a child, maybe after 1 year, you start noticing changes in the distribution of the rash. Now, before I go, in infant, you see it in the cheek, the face, and the extensor surface, just like we have here. The face, the scalp, the extensor surface. But in children, you see it in their flexural areas and the neck, just like this guy. So this guy is definitely, not an infant. This person is going to be more than 1 year, right? And the same distribution is also where what you are going to see in adult. So you see an adult having papulovesicular, dry, itchy lesions in the flexural area. You think about atopic dermatitis. Then you want to ask yourself, is there a family history of some allergic disease? Maybe asthma? Maybe the person is always scratching the nose, allergic rhinitis. You ask yourself. Or food allergy. The question can put that, the examiners can put that in the question stem. So you have to be alert. Then, you can have some complications of atopic dermatitis. Don't forget, we said that this lesion is very periodic. They are scratching. So you can have introduction of some viral, bacterial, fungal agent into that skin. And what are these complications? Number one, you want to remember is impetigo. Impetigo, which is caused by Staphylococcus aureus and Streptococcus pyogenes, right? Staphylococcus aureus and Streptococcus pyogenes, and you are going to be seeing, erythematous lesions in the skin, in the surface of the face, with yellowish crusting, dry exudates on the face. Think about Staphylococcus aureus or Streptococcus pyogenes causing impetigo. It could be bullous, it could be non-bullous. But if you are seeing these lesions developing on the background atopic dermatitis, that is a complication. Viral agent can enter. So you have talked about the bacteria. The viral agent can enter. And what are these viral agents? Herpes simplex and molluscum. So herpes simplex, they are going to tell you that you are now seeing vesicular lesions with erythematous base. That is eczema epithecal. You immediately want to give that person IV acyclovir. Molluscum can also, enter, and the person can develop the skin-colored papules with central umbilication. That's another complication of atopic dermatitis. The last one that is not here is the tinea infection. So they can develop tinea pedis, in which you are going to be seeing, erosion or erythematous lesion, depending on the part of the body. If it's the leg, in between the toes, or you can see it in the body. People with tinea corporis, you are just going to be seeing that scaly lesion that is erythematous with a central clearing. Think about tinea. So we have talked about the bacteria, we have talked about the virus, we have talked about the fungi, and you treat accordingly. So these are the triggers: the climate, food, skin irritant, allergy. You don't need to cram it. You don't need to. We have talked about the distribution of the lesion, and we have talked about the complications. So if the person has what's it called, impetigo, you can consider giving topical mupirocin and oral cephalexin. Don't worry about it now. I'm going to tell us when we get to that portion, and we are going to consolidate it very well. So your diagnosis is clinical. You don't need to do anything clinical, but sometimes you might need to exclude other things, by doing your potassium hydroxide mounting, to exclude tinea. And if you do your blood work, there's going to be eosinophilia and elevated IgE, but they have no diagnostic value. So we should not worry ourselves about that. There's a key fact here, and that is erythema toxicum neonatorum. I know that Dr. Barbarian they have talked about the benign skin lesions. Have we done the rapid review for pediatrics? Hello, are we there?
Yeah, yes, yes,
We have
we've
done
done it.
the rapid review for pediatrics. Okay,
Yes.
so Dr. Antonia, do you remember any of those benign dermatological lesions?
I know erythema toxicum usually occur within the third day
Mm-hmm.
after birth.
Mm-hmm.
Then media rubra anywhere from 2 weeks or so. Then
Okay.
the milia
Mm-hmm.
is after birth.
Yes.
Um,
Yeah. That's a
there's there's
that's
milia.
a yeah. Me too now. I don't know if I can remember everything, but I know we have the
Oh,
erythema. Hello?
yeah, I can't remember all of them, but I will
Yeah.
just reverse it. Sure.
Yeah. So your erythema toxicum neonatorum. This one, don't bother yourself about it. All you just need to remember is that it is present in the trunk and the proximal extremities. That is all you need. The trunk and the proximal extremities 1 to 3 days after delivery. And what are you seeing? That is what you need to know. I'm going to be looking for papules and pustules. Papules and pustules in a child that is just recently delivered, a neonate. 1 to 3 days. Think about ETN. You don't have to do anything. It will go after 1 to 2 weeks. That is all. Then there are others like your milia. Milia present at birth. As you are delivering, you are seeing the milia, which are whitish papules in the face. That's all you need to remember. Whitish papules in the face disappears in 1 month. That is milia. Then we have the milia rubra, which is due to occlusion of the eccrine sweat glands, blockage of the follicles, more like heat rash. It is not present at birth. It is after the mother have started wearing thick clothing that is not allowing fresh air to enter. That is why milia rubra develops. Then we have the neonatal cephalic pustulosis, and the neonatal uh, postular melanosis, right? So we can revise them when we get to our pediatrics. Um, what do you want to do? You want to break the itch scratch cycle, right? You want to reduce that inflammation causing that pruritus, because that is what is causing the problem. What do you want to give them because of that? Give them emollient moisturizers, moisturizers to keep that skin supple, and clean and wet so that it doesn't become dry and puritic. You can also give your H1 blockers to relieve the pruritus, like your hydroxyzine, right? It's good for you to use it in nighttime because of the sedative effect. But aside all this supportive treatment, your mainstay is to give your topical. Please pay attention to the route of administration. Topical corticosteroid. Just apply it to that surface. But you have to be careful of skin atrophy, of telangiectasial and rebound flares from prolonged use, particularly in the face. Sometimes you can use some steroid sparing agents like your topical calcineurin inhibitors, your tacrolimus for people with the moderate and severe eczema in individuals that are more than 2 years of age. So if it's more than 2 years and there's a contraindication to use of steroid, maybe they have used steroid for so many times and not working, you can switch your topical calcineurin inhibitors, right? And you want to talk about your supportive treatments like emollient, you know, to prevent the dryness, and reduce the inflammation and the likes. And at the same time, you also want to give your H1 blockers to reduce the pruritus. You know, your topical steroid is the mainstay that will help you to reduce the inflammation and prevent development of the symptoms. So you want to avoid using harsh soap that will irritate the skin, and you want to limit hot shower that can precipitate uh, the lesions. So sometimes you might also consider phototherapy and dupilumab, which is one of those drugs that inhibit interleukin 4 and 13. We don't need to remember that. The only thing we need to remind ourselves of is your supportive treatment, emollient, your antihistamine for the pruritus, and the mainstay, which is topical steroids. And if that doesn't work, maybe the trophy telangiectasia, we can give our calcineurin inhibitors. That is all you need to know. So let's look at one question. I think I have one question I have here. So uh, this is a 5-month-old male infant. A 5-month-old. I want to try if I can enlarge the screen. Okay, can't do that. Finding it difficult. A 5-month-old male infant is brought to the physician by his mother because of a generalized periodic rash for 2 weeks. The itchiness often causes the infant to wake up at night, which was strictly breastfed. It was strictly breastfed until 4 months of age, whereafter he was in transition to formula feeding. His father has a history of asthma. His immunizations are up to date. The length, the weight is okay. Examination shows dry and scaly patches, papules on the face and the extensor surface of the extremities. The groin is paired. Which of the following is the most appropriate next treatment in the management? So, which one are we going for? Hello, are we there?
The emollient.
The emollient, fantastic. So, after applying the emollient, what else can we give?
You can give antihistamine for
Antihistamine.
pruritus and then the mainstay corticosteroid to control inflammation.
Nice. So, that is that about allergic dermatitis. So, moving on to contact dermatitis. This is of two types. The irritant and the allergic. So, the allergic contact dermatitis is mediated by a type 4 hypersensitivity reaction. It's just like the type 1. You already have, the allergen being exposed to the skin and it has sensitized the body. And the body have already produced some T cells that will respond to that antigen or the allergen agent the next time it comes. And if it comes the next time, the response is going to be faster. So within 12 to 72 hours or 48 hours, you already have the lesions appearing because of the T cell response to the antigen. So that is allergic contact dermatitis. While you have the irritant contact dermatitis that occurs because you have a particular substance that is irritating the skin, causing destruction, of the skin cells like the keratinocytes, precipitating inflammation. So, what are the triggers for your allergic? What are the triggers for your irritants? What you don't want to forget for your exam for the allergic is the poison. It's heavy. The poison hook, the poison sumac. The poison heavy, poison hook, poison sumac are plants that contain urushiol. So, urushiol acts as an allergen that can provoke T cell mediated inflammatory response. You don't want to forget that. So the question stem is going to tell you that the person has gone hiking, has gone gardening, has gone for a walk in the mountain, and afterwards they start developing the lesions. After the poison heavy, you want to remind yourself about the personal care agents, the clothing, perfumes, the necklace, the jewelries, the deodorant that the patient is using. So if they tell you that the person notices the lesions within the neck, you already know that that's sensitivity to the jewelry. Nickel jewelry. If they tell you that you are seeing the lesions in the armpit, in the axilla, you already know that that's going to be what? Anybody wants to guess? We are seeing the lesion in the axilla. What can that be? The deodorant. The deodorant. Person spraying PEF in that side. Irritant. Allergic contact dermatitis. So that's the way it goes. Some topical antibiotics too, like neomycin too, can cause allergic contact dermatitis. So this is a very common stuff in adults. Irritant too can occur in people that, wash their hands with some soap, some irritative detergent, get exposed to acid, to alkali. They can cause inflammatory damage to the hands. So irritant is more common in the hands, the back of the hands, or the front of any part. The hands majorly irritant, and it's going to be bilateral. Why allergic can be unilateral or bilateral, and you get history of exposure to any of these allergen. So just like atopic dermatitis, you are going to be seeing, you know, like vesicular lesions and papular lesions in a way. That's why they use the word eczematous rash, which is also going to be pruritic, but it will have a shape. That's the difference. It's going to have a shape. It's going to appear angular or linear. So you know that, oh, it's kind of focused to that area alone. There must be something irritating, or there must be an allergic contact with that area. So look at this now. We cannot call this allergic, we cannot call this atopic dermatitis. Why? Because it is demarcated, and that's a particular appearance, angle, shape. It's not in all part of the body. So we notice that it is the parts, where the skin is making contact with the shoe, that the lesions are appearing. Think about your contact dermatitis. So you're going to be seeing erythematous papule and vesicles with serous discharge. That's why you call them weeping lesions in areas of contact with the offending agent. Don't forget about that. It is type 4 hypersensitivity reaction. So you have to exclude atopic dermatitis sometimes because it can be confusing, but it's a clinical diagnosis. So people that get exposed to some cosmetics agents, that's why you see them having the lesions in their face, in their eyelids, nose. Some antibiotics like neomycin, latex wear, gloves made up of latex, so they can develop it. How do you make your diagnosis? You can further, if you are not sure, to nail the causative agent, you can do your patch testing. So the patch drug contains a list of different type of allergens, that can provoke this dermatitis. So once you apply the patch, you look for the areas of induration afterwards, and you correspond that area with the agent that is in contact with that skin. Then you tell the patient to be avoiding that particular allergen. That is it. So your patch testing results can be affected by use of topical steroids and calcineurin inhibitors, because it is an inflammatory response. So if you have used steroids and you have used calcineurin inhibitors, you might not be able to get the result in your patch test. So you want to delay it for like 1 week after you have used your steroids and your calcineurin inhibitors to calm down that flare, right? Your antihistamine is not going to affect the result of your patch, because type 4 hypersensitivity reaction is not mediated by histamine. So it does not affect it. How do you treat? Avoid the allergen. That's number one. In fact, that might be what you are going to see in your question. Avoid the allergen. If it's the irritant, avoid the irritant. And you can now apply topical corticosteroid, just like we do in atopic dermatitis. Apply your topical corticosteroid. If it's severe, you might need to use your systemic corticosteroid. You might do some supportive treatment to apply your calamine lotion, like your emollient, to reduce the itching. You can apply warm compresses also for the blisterous lesions. But the mainstay is your topical corticosteroids and avoiding the allergen. I don't think I have any question. Do I? I think I have. So, this is a 20-year-old man who comes to the physician because of 2-day history of pruritic rash on the arm. He returned from a 2-week hiking trip in North Carolina 1 day ago. He has ulcerative colitis, works as a landscape architect. His only medication is mesalamine suppository twice daily, and he smokes a pack of cigarettes daily for 4 years and drink 1 alcoholic beverage daily. He does not use illicit drug. His temperature is 36.8, the pulse is 65, the vital signs are normal. So they showed us a photograph of the rash. The remainder of the examination shows no abnormality. Which of the following is the most appropriate next step in the management? So let us look at the rash. So this is the rash. Have we seen the rash? What are we thinking? Let's go back to the question. What do we think? So pruritic rash on the arm. He returned from a 2-week history of camp in North Carolina 1 day ago.
And Mr. Oral prednisone, I'm thinking of Urishol something because of the camping.
So Dr. Antonia, if you remember, what is the progression of the treatment? If we are giving the mainstay, which one are we giving?
Topical
Topical,
corticosteroid.
topical.
Oh,
But you
sorry,
said
is it? Okay, yeah, it's topical corticosteroids.
exactly. So this
Mm,
will be out.
yeah.
So, so which one do you think we can give out of everything?
Um,
Don't you want
you
to
can
apply
give
your
the
calamine lotion, your
yes,
topical calamine lotion? It is an emollient. It can
yes.
help. It can help. So apply
Do
your
you
emollient.
give okay?
The what?
Do Can you give histamine,
Yeah,
like histamine for pruritus
you
to them?
remember, Dr. Antonia. We said this is a type 4 hypersensitivity.
Okay,
Histamine plays no role.
that's no
So
role.
so it's
Just
a catch. It's a catch. So you only use antihistamine in allergic
allergic
or atopic dermatitis. You don't use it in contact dermatitis.
dermatitis.
So that is it.
Okay.
So remind yourself, use your topical corticosteroid and your emollient. Avoid the allergen. Your antihistamine have no role here, but you can use your antihistamine in the atopic dermatitis. So the seborrheic dermatitis is the next one, and this is just like a chronic inflammatory skin lesion to an infection, which is malassezia for 4. Malassezia can cause so many things. Seborrheic dermatitis is one of them. It is an harmless yeast that you can find in sebum and hair follicles. So anywhere that is rich in sebum, anywhere where the sebum is highly produced, you can see malassezia colonizing that area. So it has a high predilection for areas with sebaceous gland. Like just follow your nose upwards. The nose, when you go up, you want to turn to the right, your eyebrow, then to the back of your hair. So the nasolabial fold, the eyebrows, the posterior hair, and the scalp. That's where your seborrheic dermatitis develops. And the presentation varies with the age. In infants, what you just see is just a erythematous lesion with a greasy, this word, greasy, because of the sebum, oily, greasy yellow scale. Once you see, you don't need to read the question again. Please, I'm just joking. No. It will just heighten your suspicion. Erythematous, greasy, yellow scaling on the scalp of an infant. Your answer is seborrheic dermatitis until otherwise proven. So you can see this guy now having this yellow crusting and scaling, seborrheic dermatitis. And we can see this adult, although not very prominent, but we can see this yellowish deposit here. You can see some image that will be more clear than this, but this is not very good. But we can see the yellowish deposit in the face. That is seborrheic dermatitis. So you already know the cause, malassezia for 4. So this is not the one that will not be bombarded with steroids like that. We just give agent to kill this malassezia guy. It's as simple as that. So in adults or children, you are going to see the lesions in the hairs, the eyebrows, nasolabial fold, the midchest, and the scalp, just like we have said. If you see seborrheic dermatitis in unusual location or it's widespread, think about HIV. Very important stuff. Think about HIV if it's widespread. It could be, in people with psychotic disorder, people with schizophrenia, or people with Parkinsonism. The reason why they are present in people with psychotic disorder or Parkinsonism is not known, but it is present in those people, and it's usually widespread. So have a high index of suspicion for seborrheic dermatitis when you are seeing erythematous yellow crusting lesions, maybe plaques or papules or whatever, yellowish crusting, widespread seborrheic dermatitis. Could be from HIV, psychotic disorders, or Parkinson's disease. Very, very important, please. Very, very important. Very, very important. Your diagnosis is clinical. Don't worry about what they are talking about. Your diagnosis is clinical. How do you treat? So, if it's an infant that is having the cradle cap, which is your lesion in the head, that's the cradle cap, just do like routine bathing and application of your emollient. The infant is going to come out well. But if it's adult, If it's present in the head of an adult, you need to wash that scalp with shampoo containing selenium sulfide or your zinc parinthrione. So your zinc parinthrione and your selenium sulfide are toxic to the Malassezia furfur. You can also apply ketoconazole cream to the scalp. But if it's present in other areas outside the scalp, like maybe the face, the upper chest, you can apply your topical. Can you see that? We are not still talking about oral, topical antifungal, like your ketoconazole cream. Or you can also apply your topical corticosteroid to reduce the inflammation. But I can assure you, you are more likely to see your antifungal than your steroids. So always remember your antifungal first. If it's a scalp, a small child, just wash, bathe the child, apply your emollient. The scalp for adults, just apply your shampoo, zinc parinthrione, your selenium sulfide, and your ketoconazole cream. Other parts, apply your topical ketoconazole cream to that area and also your steroids. So, I think I have a question here. A 3-month-old boy is brought to the physician by his parents for the evaluation of a rash on the scalp and forehead. The parents report that the rash has been present for several weeks. They state that the rash is sometimes red and scaly, especially when it's cold. The patient was born at 6 weeks and healthy. The father has psoriasis. The patient appears comfortable. Examination shows several erythematous patches on the scalp, the forehead, and along the hairline. The scalp, the forehead, and along the hairline. Some patches are covered by greasy yellow scales. Greasy yellow scales in a 3-month-old boy. Which of the following is your diagnosis? What is our diagnosis? Seborrheic dermatitis. So what are we going to do for this 3-month-old boy?
Just bath and apply normal routine bathing and apply emollients.
Nice. That is all you need to do. Psoriasis. Psoriasis is going to come out in our exam. If it doesn't come out for Dr. Antonia, it's going to come out for Dr. Joy. It's going to come out for Dr. Lushola. I can assure you, one of you are going to see psoriasis. Psoriasis is a T-cell mediated inflammatory disease. And the lesions are well demarcated. You can define the borders of the lesions. You see them. And it is due to dermal inflammation or epidermal hyperplasia. In fact, this alone can be a question. They will show you the psoriasis and they will tell you what is the pathophysiology of these lesions you are seeing. So there is dermal inflammation and epidermal hyperplasia. That is the most important part. Who knows the nomenclature for epidermal hyperplasia? What do we call that from our step 1? Anybody remembers? When there's epidermal hyperplasia, what do you call that?
Hyperkeratosis.
Hyperkeratosis. So you just see it in the option. Hyperkeratosis. That's what you are picking. That is what psoriasis is all about. A T-cell driven epidermal hyperplasia and dermal inflammation. It can occur at any age. When you see widespread psoriasis, rule out HIV. When you see widespread seborrheic dermatitis, rule out HIV. Very, very important. But what do you see to raise your suspicion for psoriasis? You are going to be seeing your papules and your plaques. So we are now moving away from papules and vesicles now, which is common in people with contact dermatitis and allergic dermatitis. Here, it is plaque and papules that we are going to be seeing. And the plaque and the papules are going to be covered by scale, which is going to be silvery in color. We call it Mercatius scale. So if your question is saying an individual, a 50-year-old man, has erythematous plaques, papules covered by Mercatius silver-colored scales, that is psoriasis until otherwise proven. What is going to make you more sure of your diagnosis? You are going to be seeing these lesions in the extensor surface of the body, like the elbow, the back of the hands, the buttocks, the back of the legs. but most commonly the elbows. Psoriasis. The psoriasis have some extra dermal presentation. Number one is the nail pitting. You are going to be seeing pitting, indentation in the nail pitting. The second is oil spots. So I don't have an image for the oil spot, but the oil spot is just you seeing reddish, yellowish lesion beneath the nail bed. Classic for psoriasis. You can see onycholysis, removal of the nail. The nails are going to be breaking from the nail bed. Can you see this? This is onycholysis, the nail pitting, the oil spots, the erythematous plaques and papules covered by micaceous scales in the extensor surface. By the time you start peeling these scales, there's going to be bleeding because you are going to be exposing the vessels at the dermal papillae. That is what you call which sign? Anybody remember the sign?
Auspice sign.
The auspice sign. Very easy. Now, if you stroke any part of the body, maybe trauma, local irritation, these lesions are going to be appearing again. That's what you call the Koebner phenomenon. What are the medications that can trigger psoriasis? You talk about the LAPS. Your LAPS, lithium, A for the L, your A, your ACE inhibitors, and your B, beta blockers. Mind you, I want to say it here that the commonest dermatologic manifestation of lithium is acne. The commonest dermatologic manifestation of lithium is acne. But lithium can also cause psoriasis. Very important stuff. In 30% of people, you are going to be seeing features of psoriatic arthritis, which is more like arthritis affecting the small joint of the hands and the feet. So, they can have problems affecting the distal interphalangeal joint, the proximal interphalangeal joint. It can affect the sacroiliac joint too. We call that the seronegative spondyloarthritis. Psoriatic arthritis is also part of the seronegative spondyloarthritis. Dr. Antonia, am I right?
Sorry, come again.
Psoriatic arthritis is also part of the seronegative.
Yes.
Yeah. So you are going to be seeing lesions affecting the small joint of the hands and the feet with a negative rheumatoid factor. So keep that at the back of your mind. We have talked about the auspice sign, we have talked about the scaling, and we need to talk about the histologic features. Thickened epidermis, that's the hyperkeratosis. You are going to see elongation of the recti regis, which are like projections from the epidermis into the dermis. You are going to be seeing absent granular layer. In fact, this is what separates psoriasis from lichen planus. In psoriasis, there is a prominent stratum corneum, but the stratum granulosum is absent. The stratum granulosum is prominent in lichen planus. Please note that distinction. And aside hyperkeratosis, there's going to be what we call parakeratosis in people with psoriasis, which is retention of the nucleus of the keratinocyte within the stratum corneum. That is parakeratosis. It's a feature of psoriasis. And there's going to be a neutrophilic infiltrate in the stratum corneum, which you call the Moro microabscess. Don't forget these 5 things. Any one of them can come out in your exam. Pay attention to them. How do you treat? You stratify. Is it local? Is it severe? If it's local, think about your topical steroid first. Then your vitamin A and your vitamin D derivative. Very, very high yield for psoriasis. Your topical steroids, your vitamin A and your vitamin D derivative. So your vitamin D derivative like your calcipotriene. Your vitamin A derivative are your retinoids like your tazarotene, your acretine, your adapalene. There are so many. Vitamin A, vitamin D, topical steroid, they work for local. But once it is severe, it is widespread, affecting large part of the body, or you are seeing extradermal manifestation like psoriatic arthritis, please don't start with topical steroids or calcipotriene. That is indicative of a more severe condition. So you give your agent that looks like your demand, your methotrexate. That's what you are going to apply. Your methotrexate and your anti-tumor necrotic factor agent, which includes etanercept, infliximab, or your adalimumab. All of them inhibit TNF. So methotrexate and your TNF blocking agent for severe or psoriatic arthritis. Once you are seeing psoriatic arthritis, please, your methotrexate and your anti-tumor necrotic factor. You can also use the other ones. I don't really recommend us remember, but it's good, just for academic purpose. Your anti-interleukin 17 and your anti-interleukin 12. So the way I remember it is that I know that sec means 7. Maybe in French, or is it French or something? Looking at it, SE 7, anti-interleukin 17. Your ustekinumab, that's your anti-interleukin 23 and 12. All of them play a role in the inflammatory process of psoriasis, so you can inhibit them to treat the condition. In people with extensive skin involvement, you can also give UV exposure. But in people that are immunosuppressed, you have to be careful of provoking skin cancer. So that is not very important, because you will have picked your methotrexate or your anti-TNF before you even be seeing UV light. But before you start your methotrexate or your anti-TNF, you have to do some checkups. Do your complete blood count, because methotrexate can cause iron deficiency anemia. True or false?
True.
Methotrexate.
Myelosuppression.
So, Dr. Antonia, does myelosuppression cause iron deficiency anemia?
No.
Yeah, so I said iron deficiency anemia. I'm wrong. It's not iron deficiency. What type of anemia would methotrexate cause? Aside from the bone marrow myelosuppression. Megaloblastic anemia. You also want to do your comprehensive metabolic panel, particularly your EUCR and the likes, because of the renal effect, of methotrexate, right? You also want to, do your hepatitis test and your TB test, because your anti-TNF can reactivate your latent hepatitis and also your TB. So you have to check that this person doesn't have some latent infection of hepatitis and tuberculosis before you start your anti-TNF. Very, very important stuff. So your sausage digit and your pencil in cup deformities are X-ray finding of psoriatic arthritis. I know that Dr. Babande will have shown us this in our what's it called? In our rheumatology classes. I have a question here.
Sorry.
I'm with you, Dr. Antonia.
Yeah, I wanted, you said something about iron deficiency anemia with methotrexate.
Yeah, I was asking the question. So, like I said, methotrexate can cause iron deficiency anemia. True or false? That was what I said.
Oh, okay.
Yeah, so what's your answer to that? False, exactly. So, this is a question. A 42-year-old woman comes to the physician because of stiffness and pain in multiple joints. The patient says that the fingers on both of her hands have become increasingly stiff and difficult to move over the past 8 months. During this time, she also noticed that the nails, they break easily and they look spotty. 1 year ago, she had a UTI and she was treated with antibiotics. The only medication she has now is ibuprofen for back pain. She's sexually active. She uses condoms inconsistently. The vital signs are normal. The photograph of her right hand is shown. There are multiple well-demarcated red plaques with silvery white scales over the shin and the back. The serum study shows a negative rheumatoid factor and ANA. Which of the following is the most likely diagnosis? So what are we working with here, even without looking at the lesion?
Psoriatic arthritis.
Psoriatic arthritis. So what are we going to be giving this patient, Dr. Antonia?
The DMAT methotrexate.
Yeah. So
anti-tumor necrotic factors.
Anti-tumor necrotic factor and our methotrexate. After checking the metabolic panel, check your ECR, check your glucose, what's it called? Then also looking at your complete blood counts, you have to check for latent infection like hepatitis and your tuberculosis. Yeah. So That is that about psoriasis. Moving on to urticaria. Urticaria is also known as hives, and this results from release of histamine and prostaglandin from the mast cells in type 1 hypersensitivity response. So it can be provoked by anything. Probably the person use a drug, person had consume a food that can drive that allergic process, or the person got exposed to some bee sting. You can have that lesion develop it, and they are sharply demarcated edematous plaques with surrounding areas of erythema that usually disappears within 24 hours. So the word here is transient. They are usually transient, but you can have the chronic form, which can last for more than 6 weeks. The cause of the chronic is usually idiopathic. So this is what you are going to see, and sometimes it can be severe that the person will have associated features of angioedema. So there's going to be subcutaneous swelling in the eyes and mouth. The person can also have asthma, GI symptoms, joint swelling, and fever because of the allergic process. So that's very straightforward. You don't need to waste time. The commonest triggers include, food, drugs, virus, insect bites, or physical stimulus. The chronic urticaria is idiopathic. You don't know the cause. So, the diagnosis is clinical, but sometimes they can have what we call positive dermatogravism, in which you can introduce these new lesions by the time you stroke the skin. In fact, you can even use it to write somebody's name. If I stroke in the direction of E, it's going to appear as E. That is dermatogravism. If you are still in doubt, you can draw the serum tryptase test, because this is a mediator that's released with histamine from the degranulation of the mast cells. Don't forget, it is a type 1 hypersensitivity. So if you check for the serum tryptase, it's going to be elevated. How do you treat? It is histamine mediated. So give systemic antihistamine. Give your oral antihistamine. If the patient is anaphylactic, give your high-end epinephrine with fluid and airway support. Because if there's angioedema involving the neck, compromise the airway, you might need to get intubation. Because of the hypotension, you need to give fluids. Then you need to bombard them with histamine, antihistamine, and high epinephrine. So that's very easy. I don't think we need to. So this is a question. A 14-year-old boy is brought to the physician by his parents for evaluation of his skin rash for one day. The patient reports intense itching. He was born at 39 weeks gestation, and he has a history of atopic dermatitis. He attended junior high school and went camping trip with his school the day before yesterday. His older brother has celiac disease. Examination shows erythematous papules and vesicles that are arranged in a linear pattern on the right forearm. Laboratory studies are within normal limits. Which of following is the most likely cause of the patient's symptoms? What is our diagnosis first? Based on what we have learned. Anybody?
He has a history of atopic dermatitis.
Okay.
Yeah.
So just marry the symptoms together. Look at the symptoms. Look at the way it started. Look at the lesions. So sometimes I might be showing you a question that is not related to what I'm thinking, to what I'm teaching at that particular point. I want to know if you can actually remember what we have learned. So let us no. Okay. Don't give me the diagnosis. Just tell me. Don't give me the answer rather. Just tell me your diagnosis. There's a skin rash for one day. It is pruritic. The patient went camping And afterwards, there is erythematous papule and vesicle, which is arranged in linear. They've given up the answer already.
Wheels.
No, these are not wheels. I intentionally put it there to see if we'll be able to remember what we have learned. But I said it.
Contact. Sorry, contact dermatitis.
Yeah, which one is it? Is it allergic or irritant? Which one is it going to be?
Allergic.
This is allergic contact dermatitis. So sometimes if I show you question, it doesn't necessarily mean I'm trying to show you question of what we have done.
Mm-hmm.
It's just to see if you are following.
Allergic dermatitis.
The person had papules and vesicles. You already know that this is going to be atopic dermatitis or your allergic contact dermatitis. Now them they cause papules and vesicles. They told us that it is periodic and it went camping the previous day. And there's a linear patterning. I mean, that is it. They've given us. If it has a pattern, that is allergic contact dermatitis. So what are we picking as the answer?
Okay. Pre-sensitized T cells.
Pre-sensitized T cells. Good job. So that is the way you are going to be analyzing the question. Look at the lesion. Look at the characteristics of the lesion. Look at the preceding situation. Have a diagnosis, then go to your answer. Very important. So, moving on to drug eruptions. Drug eruption can range from mild morbilliform rash to rare, life-threatening cases like toxic epidermal necrolysis. So what they are trying to tell us here is that drug eruption can cause morbilliform rash, which are measles-like rash, starting from the head, coming down to the trunk. Or in extreme situations, they can have toxic epidermal necrolysis. Please, once it gets to maybe 2 o'clock, we'll go for a break, 15 minutes break, and we'll come back so that everybody doesn't get too tired. So, we have to have a very high suspicion for people who are hospitalized that develops rash afterwards. Drugs can cause all 4 types of hypersensitivity, so we have to know that drugs can cause type 1, type 2, type 3, type 4. If drug is causing type 4, that is toxic epidermal necrolysis. If drug is causing type 3, for example, serum sickness, drug is causing type 2, that is drug-induced hemolytic anemia. Drug is causing type 1, so that's like maybe drug causing urticaria. That's what they are just trying to tell us. What do you see when you do your histology in people with drug eruption? Pay attention to this. There's going to be peripheral eosinophilia and eosinophils on the histology. Just keep that with you. The drug reaction, which is mediated by anaphylaxis, is already straightforward. We have talked about that previously. That's the type 1, and they occur almost immediately after exposure. So you know that, okay, this is likely to be drug-induced urticaria reaction or the likes. But for the non-anaphylactoid eruptions, it usually occur after 1 to 2 weeks after exposure. So if you give somebody a drug and the person is developing the lesion the next day, don't think about the drug causing it. It is not. If it doesn't happen immediately, it should happen after 1 to 2 weeks. That's the way to look at it. If it's happening the second day or the third day, it is not likely to be the cause. The eruptions are widespread, they are symmetric, and they are periodic, and they disappear 1 to 2 weeks after you stop the drug. So what is the spectrum? You can have erythroderma. Erythroderma just means you have started the drug, and after 1 to 2 weeks, you are seeing redness all over the body, erythroderma. Sometimes, some people can have a severe form of drug reaction that you call drug reaction with eosinophilia and systemic symptoms. That's what we call DRESS. DRESS. Drug reaction with eosinophilia and systemic symptoms. DRESS. And what you typically see here in the question stem is that they will tell you that the patient has used some particular drugs like antibiotics, penicillin, cephalosporin, anticonvulsants, or sulfonamide. And you do your labs, you are seeing eosinophilia, elevated eosinophil count. If you are not sure, look at your table and check. You are going to be seeing thrombocytopenia. You are going to see leukocytosis. And most importantly, there's going to be systemic manifestations. But before we get to the systemic manifestation, because we are talking of a drug reaction, there's going to be skin lesion. Because this is dermatology, there has to be skin lesions. Skin lesions, which most of the time it's usually mobiliform rash. There's going to have this mobiliform rash, measles-like rash. Sometimes it could be papular, it could be, you know, what's it called? Plaques that will develop after you have started drugs, and you do your labs. You are seeing eosinophilia, you are seeing thrombocytopenia, you are seeing lymphocytosis with systemic symptoms, particularly affectation of the liver, hepatomegaly, elevated liver markers, the kidneys, AKI, maybe from interstitial nephritis, from acute kidney injury, from, you know, uh, so many things that can happen to the kidney. You can see affection of the heart, but the commonest one you are going to see is derangement of the liver markers. You already know that that is DRESS because you have seen that the patient has been placed on certain medications, and you do your blood work, you are seeing all this eosinophilia, you are seeing leukocytosis, you are seeing thrombocytopenia, and you are seeing affection of the liver. Think about your DRESS. SGS and TN, they mean the same thing. It's just the percentage of the body that's affected. When less than 10% of the body surface area is affected, that's your SGS. When more than 30% is affected, that's your TN. When it's between 10 to 30, you call that SGS TN syndrome. And what are you going to see here? You are just going to see exfoliative dermatitis. So the person is going to be having some skin rash, could be maculopapular, which will evolve to targetoid lesions. And from there, they will start desquamating. You start shedding off. And you're going to be seeing erythroderma, redness of the skin. Right? And you get history that the person has used medication. And what is going to further make you be confident that this is SGS or TN, aside all those things I've said, is that there's going to be mucosal affectation. That is what you need to check again. Is it affecting the mucosa? Because there are so many things that can cause exfoliation. But is this one affecting the mucosa? And has the person started any drug? Okay, patient have started drug. There is desquamation. There's affectation of the mucosa, affectation of the mouth, affectation of the eyes, affectation of the genital mucosa. Patients having genital lesions, having conjunctivitis, blepharitis, keratitis, having oral lesions, blisters, after commencing the medication, within 1 to 2 weeks, think about SGS or your TA. What do you do? Any one of them, erythroderma, DRESS, SGS, discontinue your medication. That's the first thing. Stop that medication. Give the person antihistamine or your topical steroids to relieve the pruritus. Very important. Very, very important. And also for the situation of your TN, SGS, you might need to give fluid support because the person will have, because of desquamation, the person is losing fluid, electrolyte imbalance, correct them. If it's very severe, you might need to give systemic steroids or your IV immunoglobulin. So, but most of the time, what you are going to see in the option is what? Discontinue the offending agent. They want to be sure that you actually know what is provoking that lesion. Because if you don't know, the person is not going to function. You're not going to be, treating that patient because the lesion, even if you are giving antihistamine and steroid, the lesion will keep persisting. So you have to discontinue that agent. Then give your antihistamine and your topical steroid. But if it's widespread, for example in TN, you can't be giving topical steroids. Give your systemic steroids or your IV immunoglobulin. So we are going to still discuss them further. That's just like an introduction. The next one is erythema multiforme. Do you have any question on drug? Let me see. A 13-year-old girl is brought to the physician by her father because of a worsening pubic rash for 2 days. 5 weeks ago, she was diagnosed with juvenile myoclonic epilepsy and treatment with lamotrigine was begun. Her immunization are up to date. Temperature is elevated. Physical examination shows facial edema with a partially confluent mobiliform rash over the face, the trunk, the extremities. There's a swelling of the cervical and inguinal lymph nodes and hepatomegaly. Further evaluation is going to show which of these. Anybody? What is our diagnosis? Anybody? Hello?
Increase absolute eosinophil count.
Yeah. So what is your diagnosis?
Dress.
Stress. Fantastic. There's mobiliform rash. We can see evidence of, organ problem, hepatomegaly. Although they are not showing us the blood work, but we can identify hepatomegaly. I forgot to talk about this lymphadenopathy. Is present. You can see the mobiliform rash, and we can get the history that the person has begun some drugs, particularly the anti-epileptics and your antibiotics, and also sulfonamide. So most of the time they arise within 2 to 8 weeks of starting the medication. So I just don't want to be saying something that is contradicting or contradicting rather. Sorry about that. Contradicting our first aid. That's why I said 1 to 2 weeks. But ideally, it's about 2 to 8 weeks after starting the medication. So dress is not easy. It's not hard to identify. Erythema multiforme. This is a lesion that is characterized by presence of targeted lesions. That's all you need to be looking out for. Once you see targeted lesion, have high index of suspicion for erythema multiforme. You are going to be seeing a lesion that has outer erythematous layer, a pale middle layer, and a inner blisterous necrotic layer. That's all. It's very good for you to know that it has many triggers and it is often recurrent. In fact, for the triggers, you have to remember two major stuff. Epi-simplex is the commonest. Then after epi-simplex, Mycoplasma pneumoniae is the next common causative agent. It can also come from antibiotics, but just have this at the back of your mind. Just know it. But the number one you want to remember, erythema multiforme. Does this person have epi-simplex infection? They're wheeling the person into the hospital. That's the first question you want to ask yourself. Is there epi-simplex infection or Mycoplasma pneumoniae? We have described the rash. That's all you need to know. Then you need to divide it into two forms. Are you dealing with erythema multiforme minor or you are dealing with erythema multiforme major? But it's good to know the characteristic appearance of the lesion, but I must also tell us that it starts from the palms and the soles. It starts from the back of the hands, rather. Sorry about that. The back of the hands, and spreads to the palm and the soles and upwards to the trunks. And you are going to be seeing the classic targeted lesion. Don't forget that. Don't ever forget it. You have the erythema multiforme minor, erythema multiforme major. The difference is that the minor is localized to the skin. It does not affect the mucosa. The major affects the mucous membrane. It is different from SGS and TN, and it does not progress to them. So don't confuse them. The patient can have systemic symptoms, fever, myalgia, arthralgia, headache. They can be present. But what you are looking for in your exam is a targeted lesion, and you want to separate if it affects the mucosa or not, so that you can tell if it's minor or major, because the treatment is different. The implicating organism is what? Mycoplasma pneumoniae and HSV. Dr. Antonia, you want to say something?
Yeah, sorry. I want to answer. You said for the drug reaction is usually from 2 days to 2 weeks. I didn't get.
I said ideally it is 2 weeks to 8 weeks. 2 weeks to 8 weeks after starting.
Okay.
Because if you go by the logic of our first stage, you know that we will not be picking drugs because that one happened 5 weeks. The patient took the drug 5 weeks ago. Do you get, Dr. Antonia?
Yes. Yes,
Yeah.
I got you.
But you know the lesion is just too classic to be. So that's why I said I did is 2 to 8 weeks. 2 to 8 weeks.
Okay. Okay.
It's also important for us to remember that erythema multiforme is a type 4 hypersensitivity lesion. Many people don't remember, but you have to remember. Just like SGS and TN, it is also type 4 hypersensitivity. Don't forget that. Never forget it. The Koski sign is negative. So if you apply friction or pressure, the skin does not shed off. It is negative in erythema multiforme. But you can have Nikolsky sign, your SGS and your TN. So those are the differences between SGS and TN. Nikolsky sign is negative in erythema multiforme. Even though SGS and TN can also have targetoid lesion, they will involve the mucosa, and Nikolsky sign will also be positive. And you are going to get history of use of a drug. But in erythema multiforme, drug use is not common, but the person will have had HSV or Mycoplasma pneumoniae. How do you treat? If it's erythema multiforme minor, symptomatic treatment, just manage supportively. The pruritus, the pain, give you analgesics. The fever, give you antipyretics. But if this person has erythema multiforme major, you have to treat that condition like a tamaborn, because it's going to be involving the mucosa, and the person is going to be having targeted lesion that can involve in blisters, which could, lead to fluid loss. So set up your IV line, keep fluid. If the blisters are severe, you can apply your dressing, right? Correct your electrolyte derangement, give your analgesia, give you antipyretics. The patient is going to be fine. So just manage as born. And the most important thing there is your fluid and electrolyte correction. Don't forget, Nikolsky sign is negative in them. So let us look at the question on erythema. I don't know if the question is talking about erythema, but I just put it there. So until we check, that's when we are going to know. So that's why I always encourage us to open our mind and just don't think that. So, a 14-month-old girl is brought to the emergency by a parent because of a 3-day history of rash, generalized rash, and difficulty feeding. The rash started on the hands and feet as small erythematous papules before spreading to the entire body. Prior to the onset of the current symptoms, the patient had a 1-week history of mild non-productive cough. The patient has been given dextromethorphan cough syrup at night to help with the cough. 2 months ago, the family visited their relative in the US. There was no history of serious illness, and the patient takes no other medication aside the cough syrup. The growth is okay, the immunization is fine, there's fever, there's tachycardia, and there's tachypnea. The blood pressure is 160. Physical examination shows slightly decreased skin turgor. And the findings in the photograph, I'm going to look for the photograph. Examination of the oral cavity discloses erythema and ulceration of the buccal and the labia mucosa. Cardiopulmonary examination shows no abnormality. Chest X-ray shows diffuse reticular opacities in both lungs. Exposure to which of the following is the most likely explanation for the patient's symptoms? I don't think I have the image. I'm not sure. Okay, let me see. Oh, fantastic. So this is the image. Can we appreciate the image?
Yes.
Fine. So, Dr. Antonia, what can you see here? What's this?
Targetoid lesions have a
Targetoid.
central part.
Fantastic. So let's go back to the question. So I want you to discuss this lesion. Just tell me what you can make up from this history. What is this talking about? Manage this patient.
I think this child, going by the By the symptoms, this child has cough, and X-ray findings show some reticular opacities in the both lungs. And besides, the child also developed rashes which started from the hand and spread outwards. So I would think most likely this child was exposed to Mycoplasma pneumonia and is erythema multiforme major because there are mucosal involvement too.
I am impressed. I am impressed.
Mucosal involvement too. So patient will most likely be treated as a case of a born patient.
That is very fantastic. That is very fantastic and encouraging. So that is the way you are going to look at that question. That is erythema multiforme major, mucosal involvement with dehydration signs. The implicating organism from the reticular opacity talks about Mycoplasma pneumonia. You are not going to please herpes simplex. Fantastic. Well done, Dr. Antonia. So, moving on to the next, I want to even be sure. Do we have other people in this class? I'm only hearing Dr. Antonia. Dr. Miriam, are you there? Dr. Victor? Okay, maybe Dr. Joy is busy. Okay, please. I need us to participate once we have the chance. Yeah, so Stevens-Johnson syndrome and toxic epidermal necrolysis. We have talked about it. So I'm not going to waste time again. I've talked about the fact that you can have widespread maculopapular lesion that can desquamate, and sometimes you can have targeted lesions, and of course the Nikolsky sign is positive. There's epidermal detachment. Don't forget by slide Robin. This guy now is going to be having TN. Can't even cause this SGN again. It's affecting the back. Don't forget the mucous membrane is going to be affected. The eyes, the mouth, the genitals, conjunctivitis, keratitis, blepharitis, any of the itis you can think of. The mouth ulcer, genital ulcer, which can be hemorrhagic. And you are going to get history of exposure to drugs. Sulfonamide, penicillin, your anti-seizure medication especially. And you can get it from the quinolones and the cephalosporins, and sometimes the steroid and NSAID, but not very common. Think about the antibiotics, your penicillin, your cephalosporin, your sulfonamide, and your anti-seizure medications. If you do your biopsy, what are you going to see? Full thickness, eosinophilic, epidermal necrosis. So there's necrosis of the epidermis. That's why you're having desquamation. So, and you are going to be seeing eosinophilic infiltrate. Dr. Antonia, do you want to tell us the reason why you are seeing eosinophilic infiltrate? Like, okay, I know we might not know the reason, but why do you think there's eosinophilic infiltrate there? I'm just asking. Like, just tell me anything you think. Why?
Because it's drug induced.
Because it is drug induced. That is what I want to hear. We have talked about the fact that once you see anything from drug, think about eosinophilic infiltrate. And that is why you are seeing eosinophilic infiltrate here with your epidermal necrosis. So you cannot call this stress, because in dress we don't expect epidermal necrosis, but we can expect eosinophilic infiltrate. Very easy. So do not confuse SGS and TN with SSS. SSS can be seen in children less than 6 years rather, especially those of them with renal. Okay, maybe not in children, but in adults with renal insufficiency. So if an adult have SSS, think about associated renal insufficiency, because it's typically common in children less than 6 years. And I think we are going to talk about SSS. So just in case we don't talk about it, SSS presents similarly like your SGS and your TN. There's going to be desquamation. You see your maculopapular rash, whatever rash. There's going to be desquamation eventually. But the next question you are going to ask yourself, is there affectation of the mucosa? No. Does it affect the mucosa? No. But what you are going to see in the question that looks like mucosal affectation is what? Perioral crusting. You just see crusting around the mouth. Don't mistake it for mucosal affectation. It does not affect the lips. There's no mucosal affectation in SSS. Very important. And the person is going to be a young patient, less than 6 years. If it's adult, renal impairment. Desquamating lesion, fever, hypertension, but with no mucosal affectation. And you will not see targetoid lesion, which is present in TN and erythema multiforme. And it's not typically caused by drug reaction. So that's that about SSS, because SSS is mediated by Staphylococcus aureus due to release of the exfoliative toxin. So, because of the high risk of mortality for TN, HGS, you want to discontinue the offending. You can see early diagnosis and discontinuation of the offending agent are critical. If you have not done that, you have done nothing. You have done nothing. Diagnose early, discontinue the medication, start your treatment as if you are treating burn. Your fluid, thermoregulatory, and your electrolyte disturbance are the first thing. Because of the extensive blisters, you want to apply wound dressing to cover the skin, and you can prevent secondary infection. So the data on steroids, cyclosporine, and IVG are mixed. Some studies are showing that it works. Some studies are saying it doesn't work. So that is why I can assure you that you are not going to be seeing the answers laying emphasis on this, but they will lay emphasis on what you do first, which is what? Fluid and electrolyte correction, wound dressing to prevent infection, and of course, making your early diagnosis and discontinuing the agents. Moving on to erythema nodosum. Very simple. This is a paniculitis, inflammation of the subcutaneous tissue of the body. Commonly occurs in the shin. Here, you just see nodular lesion that is erythematous, tender, and painful to touch. If you touch it, it's very painful, and they are going to appear nodular, just like this. What are the causes? Think about nodosum, just like what we have here. This can help us. No means in 60% of cases it is idiopathic. We don't know the cause. But for the other ones, which is D, drugs, think about your sulfur drugs, think about your iodide, think about your penicillin. So sulfur drugs, iodide, and penicillin. Mind you, in severe cases, you can even use potassium iodide to treat it. So it's kind of paradoxical. Iodide can provoke it. Severe cases, you can use potassium iodide to treat. Your next O is your what? Your oral contraceptive, OCPs. Your S is your sarcoidosis. You cannot go to the exam and forget that erythema nodosum can be caused by sarcoidosis. I mean, it's ridiculous. The U is our IBDs. So part of the extradermal, or am I right? Extra is not going to be extradermal. It's going to be part of the extraintestinal manifestation of erythema of our IBD is what? Erythema nodosum. Please, can you remind us the other ones, just to know that we are keeping up with our revision? What are the other extra intestinal manifestation of IBD? Anybody wants to help us? Please, I should be begging us to stop. We are quiet. Dr. Antonio, are you there? Dr. Miriam?
What's your question, please?
So I said extra intestinal manifestation of IBD.
Okay, of IBD.
I should be begging us.
Uveitis.
What else? I can see that Dr. Joy is whispering. Maybe she's in the office. What else? Dr. Antonia? This thing did the blood, the spinal level. Dr. Miriam? Uveitis, what else? What about arthritis?
So we have uveitis, we have arthritis. You can also talk about rash also.
Which rash? Pyoderma.
Those peridermal gangrenosoma.
Yeah.
What about renal? Like that.
What about renal complication? What renal complication do you expect? IBD. Renal. What kind of stone can they have? Guys, this thing should be spinal.
Gallstone or something.
Yes, they can have gallstones. Why not? They can have gallstones, yes, but renal stones. It's renal stone that I'm talking about now. renal stones. Which renal stones is peculiar to someone that has a Crohn's disease? Okay, let me just remind us.
Calcium oxalate stone.
Calcium oxalate stones. Calcium oxalate stones. Okay. I guess we have not done rapid review for GI, Habi. We have not, Habi.
Not yet.
Okay,
Not
okay,
yet.
okay. That's the reason. So, ulcerative colitis, Crohn's disease. The hem, microbiology. Think about the chronic infections, tuberculosis, leprosy, histoplasmosis, all of them. So, don't forget your acronym. Nodosum. Use it. No, idiopathic. D, your drugs. Your penicillin, your PIS, your penicillin, your iodide, your sulfur drugs. Your S is talking about your sarcoidosis. Your U, your ulcerative colitis, Crohn's disease. Your hem is your microbiology infections. So, infections like Streptococcus, Coccidioides, your Yersinia, your TB, your leprosy, your histoplasma, they are abundant. They can cause it, but don't forget that it is an inflammatory process affecting the subcutaneous tissue. Don't forget that. It is a panicolitis. Important stuff. Drugs, your PIS, penicillin, your iodide, sulfonamide, OCPs, and of course the other things like Behçet, your UC. So there are tender nodular lesions in the shin. You might also remember that they can have a false positive venereal disease research lab test, just like someone that has SLE, leprosy, hepatitis. This is our guy. What's the name of this guy? Please, you guys should help me now. It's plenty. EBV. What's the name of this? What do you call EBV infection?
Infectious
mononucleosis. All of them, they can have this false positive venereal disease research lab tests for syphilis. So you can have a falsely positive test. The diagnosis is clinical. A biopsy can help you establish the diagnosis, and what you are going to be seeing is inflammation of fat cells. That is all. You can walk up for your ASO titer to rule out your strep, your PPD for your tuberculosis, your chest X-ray to rule out your sarcoidosis, and your IBD workup, your fecal blood testing. You are testing for your Pianca, to rule out your IBDs. So, how do you want to treat? Supportive. Just apply your cold compress, bed rest, and your NSAID. That is all. Don't forget that this thing is painful. So, cool compress to reduce the inflammation. You bed rest so that you are not stressing that leg, and of course, give them NSAID for the pain. If this doesn't work, give your potassium iodide for persistent cases. Very simple. I don't think I have any question on erythema nodosum. I think I have a question hidden here. Yes. So let's look at this. A 56-year-old woman comes to the emergency because of 3-day history of malaise, dysuria, blurry vision, painful itchy rash. Okay. The rash began on her chest and face and spread to her limbs, the palms, the soles. Okay. So 1 week ago, she was diagnosed with trigeminal neuralgia and started on a new medicine. She appears ill, and the temperature is 38, fever is there, the pulse is elevated. Physical examination shows conjunctival injection and ulceration in the tongue and the palate. There's no lymphadenopathy. Examination of the skin shows confluent, annular, erythematous, macus, bullae, and desquamation of the palms and the sole. The epidermis separates when the skin is slightly stroked. Which of following is the likely diagnosis? What are we dealing with here? Anybody?
That's positive Minkowski sign.
Mm-hmm.
I said. So you think of SJS 10.
Very easy. There are so many things that point to SJS here.
Yeah. So
the person was started on the medication for trigeminal neuralgia, which is likely to be what? Dr. Antonia?
Carbamazepine.
They started the person on carbamazepine, and subsequently the person started developing fever, having mucosal affectation, conjunctival injection, ulceration of the tongue, the palate, and of course the rash started erythematous, bullae, macu, with eventual desquamation. So We already know that this is likely to be the SGS or T, and they further confirmed by telling us that the Nikolsky sign is positive. That's the way to look at it. So, bullous pemphigoid and pemphigoid vulgaris. We already know this. This is very very common. We talk about this almost every time. So, just know that these two guys are disease of older people. Pemphigoid vulgaris is very common in people more than 40 to 60 years. Bullous is people more than 60. But both of them, they are common in older people. So you cannot see a child and be making the diagnosis of pemphigoid vulgaris or bullous pemphigoid. That would be ridiculous. Where is the location of the lesion? So the first thing I must mention is that the lesions, both of them, they are blisters, bullous lesions. But the bullous pemphigoid, the blisters or the bullae, they are tense, so they don't rupture, which is good. That's why the prognosis of bullous pemphigoid is better. While for pemphigoids, they are not tense, they are flaccid and they rupture easily. Where's the location of the bullous pemphigoid? Because of the B, the blisters are located at the basement, the basement. While the pemphigoid is intraepidermal. So the collection occurs in between the keratinocytes in the epidermis, the intraepidermal location. Both of them are what type of hypersensitivity? Anybody. What type of hypersensitivity is bullous pemphigoid or pemphigoid vulgaris?
Type 2.
Type 2. Because they are mediated by antibodies, destroying those desmogleins or the hemidesmosomes. So, autoantibodies against the hemidesmosomes, which are located in the basal membrane, is for bullous. Why the pemphigoid vulgaris is antibodies against the desmosome gland 1 and 3 within the epidermis. So, the selective toxin of staph causing SSS is also attacking the desmosomes. And that's why they have blisters that are flaccid, they rupture, they desquamate. Very important stuff. Don't forget that. So, the blisters in bullous is tense. That's all you need to know. It does not rupture. While the blisters for pemphigoids, they rupture and there's erosion. Because the keratinocyte cannot adhere to each other. So, the Nikolsky sign is going to be negative in the bullous, while it is positive in pemphigoid. You can see that the prognosis in pemphigoid is worse. There's mucosal involvement in bullous, in pemphigoid, but it is rare in bullous. You can further see that prognosis is bad. The age is older in bullous, 60 years, while it's 40 to 60 years in pemphigoid. For bullous, it is generally idiopathic, just like chronic urticaria. But in pemphigoid vulgaris, they can put the medication. But the thing is, even if you don't remember the medication, by the time they start describing the lesion and you are seeing the lesion, you will know that it is pemphigoid. So you should not actually struggle to cram them. If you know them, it's good. If you don't know them, it's fine. So your A and your P's, your AP, ACE inhibitors, your penicillamine, your phenobarb, and your penicillin. ACE inhibitors, penicillamine, phenobarb, and your penicillin. So mortality is very high, or it's possible with pemphigoid, but rare with bullous. I have treated a patient with bullous before in my dermatology rotation, and that stuff is so terrible. They are lying on the bed and the body is just gumming everywhere in the bed, like it's so discomforting. It's very, very bad. To even set line, na wala. It's terrible. It's terrible. How do you make the diagnosis? Of course, you will have seen the clinical lesions. It's going to be tense in bullous. In pemphigoid, it is flaccid. Very easy. That's the first thing you have to know. Then the second thing you will know is your biopsy finding, because that's the most accurate test to confirm your diagnosis. So, you do your biopsy and you examine with your immunofluorescence, examination. So, what are you going to see by the time you do your immunofluorescence? Now, we have to remind ourselves how the lesion starts. For pemphigoid vulgaris, you are destroying the desmoglein that are there, the keratinocytes within the stratum spinosum to the stratum granulosum. So that means you are going to be having spaces in between them. And fluid is going to be accumulating here. Now, for bullous pemphigoid, it is separating the basal cells from the basal membrane. So fluid is going to be accumulating here. Now, if fluid accumulates here and fluid accumulates here, which one is going to show a linear patterning? Which one is going to show a reticular patterning?
The pemphigus vulgaris will show a reticular pattern.
Fantastic.
And the bullous will show the linear pattern.
Because you can see that this one is linear. So the antibodies are just depositing linearly here, right? While here, we are going to be seeing reticular deposit of the IgG on our immunofluorescence. So, and by the time we also do the biopsy, we are going to be seeing tomb, roll of tomb, or roll of like tombstone roll, like as if you are arranging a roll of tombstone, for the graveyard in the pemphigoid vulgaris. Why? Because here, your basement membrane and your stratum basale, that looks like the roll of tomb, they are intact. So you are going to be seeing this has been intact. But here, they are already lifted, they are destroyed. So you are not going to be seeing this again. This is what you are going to be seeing. So your roll of tomb appearance is lost in your bullous, while it's preserved in pemphigoid vulgaris. Just remember that which one is preserving the basal cell. That's the one that you are going to be seeing the roll of tomb appearance. How do you treat steroids? I dose steroids for both of them. I bombard them with steroids. I dose steroids. You can add immunomodulatory therapy like your methotrexate, your azathioprine for people with pemphigoid, especially azathioprine. In bullous, because of the fact that bullous is not very, very severe like the pemphigoid, so you can give your steroids topically to those areas, or sometimes if it's widespread, you can administer your systemic corticosteroids or use doxycycline. So evidence have shown that doxycycline can help to improve the lesions in the bullous pemphigoid, but I doubt if they are going to be testing that. So moving on to nummular eczema. I'm not sure I have a question. Okay, I do. Let me see. A 50-year-old woman comes to the physician because of blisters on her forearm that appeared 3 days ago. She reports pain in her left cheek when eating and pain during sexual intercourse for the past week. She has not been sick for the past 6 months. She has started hiking in the woods on weekends with her son a couple of months ago, but she has been careful to avoid poison ivy. So what is the poison ivy going to cause? Anybody?
Allergic contact dermatitis.
Yeah. She has a history of hypertension and osteoarthritis. She recently started taking captopril and stopped taking meloxicam 2 weeks ago. She has a family history of pernicious anemia and Graves. Vital signs are within normal limits. Examination shows multiple flaccid blisters over the volar surface of the forearm and also in the buccal, gingival, and the vulvar mucosa. The epidermis of the forearm separates when the skin is slightly stroked. The total body surface area involvement of the blister is estimated to be 10%. The remainder of the examination shows no abnormality, which of the following is the most likely diagnosis. What do we think we are dealing with here?
Pemphigus vulgaris.
Pemphigus vulgaris. You can see that the blisters are flaccid. You can see that there's mucosal affectation. And we can see that the mucosal sign is positive. And we cannot see any history of drug. For us to be thinking of SGS, she did not use any drug that can provoke SGS, because what she uses is captopril. And captopril is even part of the drug that can trigger pemphigus vulgaris. And what is also going to assist us with the diagnosis is the family history of the autoimmune disease. And these autoimmune diseases are what? The type 2. Do we get? Graves and pernicious, type 2. And what we are having in the pemphigus 2 is type 2. So you can be sure of what you are picking. So let's end with nummular eczema, then we'll go for a break. Nummular eczema is just like atopic dermatitis, but there's a shape to the lesion. and the lesion occurs in the lower extremity. You are going to be seeing an individual having a chronic, relapsing and remitting, pruritic, dry, scaly lesion that is cone-shaped. It is circular. It is circular. I tend to see it more in the legs, in the lower extremity. And it is believed to be due to an abnormality affecting the skin barrier, causing desiccation, xerosis, and decreased skin lipid. So, because of the decreased skin lipid and the xerosis, the skin is going to appear dry and rough. So to treat, just like we remember the treatment of atopic dermatitis, Dr. Antonia, do you want to remember? Do you want to remind us?
Yes, use emollients. You can also use antihistamines and for pruritus and steroids.
Yes.
Steroids for inflammation.
So that's like what you do here too. You use your emollient, right? And you avoid harsh soaps and your emollient to keep the skin supple and moist. Then you can also use topical glucocorticoid, just like you do in individual with atopic dermatitis. But don't forget, the lesions are going to be having a circular shape, and they are going to be present within the lower extremities, and it's due to dryness and loss of skin lipids. Don't forget, nummular eczema. So let us see a question. A 52-year-old woman comes to the physician because of multiple skin lesions over her legs for 1 month. She reported that the lesions are red, dry, and intensely pruritic. She has had 3 episodes in the past 2 years with similar lesions that resolved spontaneously after a couple of months. She mentions that she has been using a moisturizer daily because of that dry skin. Medical history is otherwise unremarkable, and she takes no medication. The vital signs are within normal limits. A photograph of the lesion is shown. The gram stain of a skin swab of the lesion and skin scraping for fungal hyphae was negative. Which of the following is the most likely diagnosis? So I think I have the lesion here. So, what do we think is this? Anybody? No catch. There's no catch. Hello? Are we there?
There's a history of recurrence. And the lesion is dry and scaly and intensely pruritic. So
look at the way the lesion looks like.
Yeah, it's scaly and round like a coin. So
yeah. So
nummular eczema.
That is classic for nummular eczema. So let us take a break and we'll come back in by 2:15. I will continue. Okay. Hello everyone. Hello.
We're here.
Okay. Yeah, sorry I was 3 minutes late. Yeah, so I think we stopped at, if I'm still recording. Yeah. So we stopped at pyoderma granulosum, and we said that this is a part of, the extra-intestinal manifestation of people with IBD. So you see this in people with IBD, people with rheumatoid arthritis, and people with some cancers. So we have to pay attention to this. Very important. IBD, rheumatoid arthritis, and malignancy. The 3 can cause pyoderma granulosum. And what do you see? There's going to be neutrophilic infiltration. Causing what lesion? The lesion is going to start as a papule or a pustule that will now rapidly progress and enlarge to form an ulcer with a purulent base and violet colored or purple colored margin. So once you are seeing an ulcer with a purulent base and a violaceous or purple colored margin with a background history of either IBD, rheumatoid arthritis, or a malignancy, think about pyodermal gangrenosome. The question stem is going to tell you that the individual has this background condition, and when they do maybe biopsy, they were able to demonstrate neutrophilic infiltrate. Neutrophilic infiltrate, think about pyodermal gangrenosome. So you want to avoid, doing the biopsy really, or debridement. You want to avoid debridement because if you debride, you can demonstrate what you call pathogy, in which the more you inflict trauma by debriding, the more the ulcer starts spreading at the other side. So that is what you call pathogy. And because of that, you don't usually debride this wound. You just give that person the glucocorticoid, either local glucocorticoid or systemic glucocorticoid, depending on the extent. Very, very important. I don't think I have any question on that. So moving on to the viral disease. So we are going to be starting with the human herpes viruses, and we know that they are a group of DNA viruses that have the tendency to form lifelong latent infection, which can be easily reactivated from time to time. So starting with the first two, the herpes, the human herpes virus type 1 and 2, we know them. The simplex virus type 1 is transmitted by the respiratory and oral secretions, and the type 2 is transmitted by sexual contact. What is common to both of them is using vesicles with erythematous base. Once you see that being described in the question stem, just have it at the back of your mind that they are talking about the herpes simplex virus type 1 or 2. Vesicles or ulcers with erythematous base. Now, type 1 can be transmitted through respiratory oral secretion, and it can become latent in where? The trigeminal ganglion. The type 2 can be sexually transmitted, and it will become latent where? In the sacral ganglion. I'm sure you will remember this. Now, what is going to be the primary manifestation? What is going to be the primary? Please excuse me for a minute. So, sorry about that. Yeah. So what is going to be the primary manifestation of the herpes simplex virus type 1? This individual is going to be having the vesicles in the mouth, right? What you call gingival stomatitis. So very important you are able to differentiate this from Coxsackie type A vesicles. The vesicles from human herpes virus, the herpes simplex virus type 1, is going to be more anterior. So you see it affecting the mucosa, the buccal mucosa, the gingiva, and the anterior part of the mouth, the lips. While that of Coxsackie, you are going to be seeing the vesicles more posterior, the posterior pharynx, the part of the mouth. That's where the vesicles are going to be. It's not going to be gingival stomatitis. This infection, the herpes simplex virus type 1, can also cause other lesions. It can cause, just like we have said, is the commonest cause of erythema multiforme. They can cause temporal lobe encephalitis, in which you just see the patient developing fever, altered sensorium, with what? Brocal aphasia. Think about temporal lobe encephalitis. They can cause esophagitis, in which you are going to be seeing, deep punched out ulcer by the time you do your endoscopy. They can reactivate, and when they reactivate, they are not going to come back as gingival stomatitis. Rather, they are going to come back as what? Who wants to remind us? Anybody? The reactivated
cold sores.
They are going to come back as cold sores or the herpes labialis. Very, very important for us to remember that. So, for the herpes simplex virus type 2, they cause genital lesions. And the other thing they can cause is viral meningitis. So, as type 1 is causing temporal lobe encephalitis, your type 2 is causing viral meningitis. So, if you see CSF work that is showing elevated protein but normal glucose, lymphocytosis, think about viral meningitis. And if you have to pick between the two of them, you are going to pick herpes simplex virus type 2. How do you make the diagnosis? It's clinical. But if you are going to do a laboratory test, just think about your culture or your PCR. For any of the virus, you are going to get it. Either you culture or you do your PCR. That's it. So I'm still going to talk about the treatment, but just to have a glimpse. The mainstay of treating the herpes simplex guys is to use your acyclovir, your valacyclovir, or your famciclovir. But anybody that is immunocompromised, having disseminated lesions or lesions involving the brain, you have to give IV acyclovir instead of oral. You give IV acyclovir. Please don't ever go and pick topical acyclovir. Either you are giving oral or you are giving IV. So if you are giving IV, it's going to be for people disseminated, immunocompromised, or the one affecting the CNS. We're going to talk more on it. For the and same treatment also applies for the type 2. For the varicella zoster virus, that's the human herpes virus type 3. So this one is airborne. I don't think the statement they have here is correct. It is not the only herpes virus with airborne transmission. You can also transmit Epstein-Barr airborne. You can transmit the type 1 and 2 herpes simplex airborne. So it is not the only. So you can transmit varicella zoster airborne and by physical contact. The primary infection for the varicella zoster virus is what you call chickenpox. And what happens is that you are just going to see pruritic vesicles, pruritic papules that's going to start developing from the trunk, and they will move centrifugally outwards towards the head, the proximal extremities from there. And what you are going to see in the question stem that is going to raise your suspicion is that the lesions are going to be at different evolution, different stages. As you are seeing vesicles, you are seeing papules, you are seeing macules, you are seeing crusted lesions, and they are disappearing. And by the time they disappear, they can stay latent in the dorsal root ganglion or the trigeminal ganglion or any ganglion, and they can reactivate later. Some of them can cause complication before they start becoming latent. And what complication are we talking about? The HEP complication, the HEP. H for hepatitis, E for encephalitis, and your P for your pneumonia. Your HEP complications. By the time they are reactivated from the dorsal root ganglion or from the geniculate ganglion or from the trigeminal ganglion, they come back as what you call shingles. And what should raise your suspicion for shingles is that you see vesicular rash. That's very common to the herpes virus, vesicular rash. But before you see this vesicular rash, you are going to get in the question stem that there's a burning, painful sensation in that part of the body before the vesicular rash appears. And the appearance of the rash is going to follow a certain dermatome, either the thoracic, the ophthalmic, any part of the body. But it's going to be dermatomal in distribution. That is what you call your shingles. That's the reactivated form of your chickenpox. What are the complications of shingles that you cannot forget? The first is your acute neuralgia, acute hepatic neuralgia. So the patient is having pain within like a month of the lesions appearing. Within a month to 4 months, that is subacute hepatic neuralgia. After 4 months, that's what we call post-hepatic neuralgia. In fact, that is what they like asking. And the risk factor for that is an individual that is elderly developing zoster infection. They usually have the post-hepatic neuralgia. The treatment differs. If it's acute or subacute, you just give your NSAID. Patient is okay. You cannot use NSAID to be treating your post-herpetic neuralgia that is actually with the pain persisting for more than 4 months. Then you need to use your neuropathic agent like your gabapentin, your pregabalin, or your TCAs to treat that pain. I'm going to show us very soon. How do you make your diagnosis? You just look at the complications. Either you scrape the lesions from the skin, or you can collect sample from the lungs for people with pneumonia, collect CSF analysis for people with encephalitis, and you can do your PCR analysis or a culture. Very easy. How do you treat? First, you want to ensure precautionary measures. You isolate anybody with chickenpox, isolate them so that they are not transmitting it airborne, right? Use your mask. And people with disseminated, you also have to separate them because they have a very high risk of transferring to other people. How do you treat? You have to start your acyclovir or your valcyclovir within 72 hours of the rash onset, because at that point you have a very high tendency of replication of the virus, so you want to catch it at that time. If you start it after 72 hours, it is not very effective, but it can help, maybe just to reduce the intensity of the symptoms and the duration of the pain, right? So give it within 72 hours so that you can catch the virus when it's replicating. You limit the duration of the lesions, the intensity of the pain, and you can quickly cure whatever you are dealing with. If it's severe, you have to give your IV acyclovir, just like in Episimplex. IV for severe or disseminated. That's the rule. Otherwise, use oral. There are vaccine to protect against varicella. You give it 2 doses, age 1 and age 4. Age 1 and age 4. Once you take your 2 doses, or you have had a previous infection with varicella, you are considered to be immune towards varicella infection. Moving on to Epstein-Barr virus, infectious mononucleosis, kissing disease, transmitted through respiratory secretions and saliva. What you don't want to forget about this guy is the constellation of symptoms that makes up infectious mononucleosis. Number 1, the person is going to be a young patient, usually between the age of like 7 to 15 years. They are very young boy, having fever, having sore throat, having fatigue, unexplained fatigue, fever, sore throat, exudative sore throat, fatigue, and of course, they can have lymphadenopathy, but the clincher is the presence of your hepatomegaly or your splenomegaly. Very important. If you have not seen hepatomegaly or your splenomegaly, please don't bother thinking of infectious mononucleosis. Your Epstein-Barr virus can cause some lymphoproliferative conditions, can lead to lymphoma, the Burkitt and the Hodgkin lymphoma. Burkitt is an example of a non-Hodgkin. It can cause Hodgkin. It can cause B and T cell lymphomas. It can cause nasopharyngeal carcinoma, which is very common in the Asians. Epstein-Barr virus is the implicating organism. It can cause post-transplant lymphoproliferative disease. How do you diagnose this? It's clinical, but you can do some tests to further confirm your diagnosis, and that talks about the monospot testing, which we are familiar with. By the time you get the serum of an individual with Epstein-Barr virus and you mix it with the red blood cell gotten from sheep or horse, there's going to be an agglutination reaction because of the presence of the heterophile antibodies in the serum of an individual with Epstein-Barr infection. You can also test for the IgM against the Epstein-Barr viral capsid antigen. That is another test to confirm the infection. If you do your blood smear, you are going to be seeing atypical lymphocytes, which are reacting to the Epstein-Barr virus, causing proliferation of the B lymphocyte. So it replicates inside the B cells using CD21 receptor. But your T lymphocytes are going to respond to it to try and eliminate it. and they are going to appear large and atypical. What's the treatment for Epstein-Barr? You are not giving penicillin, you are not giving acyclovir, but you are managing it supportively. You rest the patient, tell the patient to avoid contact sports for at least 4 weeks because they have a very high risk of having splenic rupture. Very important stuff. And it's also important for us to know that if you think an individual with infectious mononucleosis is having streptococcal sore throat and you start amoxicillin, there's a high chance of developing a rash in response to that treatment. So a patient that is suspected to have sore throat that is now given amoxicillin now develops a maculopapular rash, think about infectious mononucleosis. Moving on to the next, which is the cytomegalovirus. This guy can be transmitted through any route. Think about it: blood, fluid, saliva, sex, transplant, blood transfusion, anything. Cytomegalovirus is there. It is very similar to Epstein-Barr, but the difference is that there is a negative monospot test. It can present exactly like infectious mononucleosis. The fever, the exudative pharyngitis, the fatigue, the cervical lymphadenopathy, and of course the hepatosplenomegaly. But by the time you do your monospot test, it's going to be negative. It can cause problem in immunocompromised patients, and it can cause CREEP, which is your CREEP. Your C for your colitis. Mind you, who knows what is classic to the colitis from CMV? Anybody wants to remind us what is classic for the colitis I share with CMV? Anybody?
It's a bloody diarrhea.
It is a bloody diarrhea. The R, retinitis. Pizza pie exudate. Pizza pie exudate. You are going to see whitish patches deposited, and you are going to be in surrounding areas of hemorrhage. That is your pizza pie appearance of CMV retinitis. The E, esophagitis, lineal ulcers. The P is for the pneumonitis. The next E, sorry, I missed the next E, encephalitis. Then the P is the pneumonitis. So, and of course, they can affect the bone marrow, causing cytopenias. You make your diagnosis by doing your PCR analysis, and you treat by starting your ganciclovir, IV ganciclovir, or your oral valganciclovir. Just remember your ganciclovir for your CMV. The next is your Roseola viruses, HHV6 and 7. It says HHV6 can cause your Roseola infection, in which is transmitted by saliva. Don't forget that saliva, Roseola, saliva. And of course, just like a reminder, the patient is going to be having high fever, usually like a young child, a neonate, or a young child having high fever. The fever is severe enough to provoke febrile convulsion. And after the fever subsides, they start developing the rash, which start from the trunk, just like chickenpox, and they move outwards. That is Roseola for you. It is a clinical diagnosis and it is self-limited. You do nothing. HHV7 can also cause similar lesion, but what I must also say in response to HHV7 is that HHV7 can also be implicated in pityriasis rosea. Maybe that's why they call it rosea. Pityriasis rosea. HHV7 is involved. That is why before you see the rash patch and the Christmas tree distribution of the rash, there's going to be some constitutional symptoms which is indicative of a viral pathology, like the cough, the sore throat, the fever, the headache, the malaise, before the rash patch develops and the lesions develops. We are going to talk about it. So I'm just saying it now, so that by the time I'm talking about it then, it's just going to be as if I'm re-emphasizing it. The last is the Kaposi sarcoma virus, HHV8, sexually transmitted. Very common in people with HIV/AIDS. One of the 8 defining illness, and people with transplant because they are immunosuppressed. You diagnose by making your biopsy, and you're going to see spindle cells because they affect the endothelial cells, they appear spindle with lymphocytic infiltrate. That's what you need. So, dilating more on the episymplex, you are going to be seeing painful, recurrent, vesicular. You can see the word. They will always be there. They will always be there. Vesicular lesion affecting the mucocutaneous surface for both of them, both HSV1, HSV2. One is genital, the other is extragenital, involving the head structures. Although they can now switch now. 2 can cause extragenital, 1 can cause genital. And one thing about them is that they spread through the epidermal cells, fusing them together, forming giant cells that you call the acanthocytes. And you can do it, you can see them by the time you do your T-Zac smear. We don't do T-Zac smear again now because it's outdated. So, this is a key fact talking about dermatitis epithyphomy, and it is sad that this is the only section, where they talk about dermatitis epithyphomies. And don't forget, what you just see there is just vesicles, erosion, bullae, papules. Please, it's one of the bullous conditions, so don't confine it to vesicles only. You can see bullae that can become eroded. You can see vesicles at the extensor part, like the elbow, that are bilaterally symmetrical, and it is puritic. Once you are seeing that, think about dermatitis epithyphomies, rule out the associated condition like celiac disease, and you assay for your IgA, blah blah, and treat by using Dapsone, and you avoid the gluten diet. That's just for dermatitis. So continue with our human herpes simplex virus. Both of them, you can transmit them oral and genital fluid. They cause their primary infection, which is gingival stomatitis for type 1, and the genital ulcer for type 2. And afterwards, they can become latent in their respective ganglia. Type 1, trigeminal; type 2, sacral. The first episode is usually much more severe. You cannot forget that. It's very much more severe and longer than the first one, than the subsequent ones. And they can become reactivated, right? And by the time they become reactivated, for the type 1, you can see the coat sore or the herpes labialis, in which you are going to be seeing clusters of crusted vesicles with an erythematous base. Sometimes it can be triggered by this. The stress, sunlight, and infection is not very important. And you can also have recurrent genital ulcers from HSV2 also developing, but it's not with so much pain and systemic involvement like the primary one. So that's the recurrent, stuff for the type 1 and the type 2. So for the treatment, okay, now for the clinical diagnosis, we have to know that it's clinical. We see the group vesicles with erythematous base, just like I've said. And just like I've said for hot viral, most of the time you just do your viral culture or your PCR analysis, right? If you want to do a rapid test, you can do your DFA, your direct fluorescent antigen testing. And what you are going to see on your T-Zac smear is what? The classic multinuclear giant cell. They can show us, but know that it's no longer commonly used again. So how do you treat? For the first episode, if the individual is immunocompetent, that's the first thing. So is the individual immunocompetent or not? If the individual is immunocompetent, there's a very high chance that they are going to clear that infection. So you might not do much. Just give analgesics for the pain. If there's fever, give antipyretics, supportive treatment. But sometimes you might need to give antiviral depending on the severity. The person cannot bear the pain and so you can give your acyclovir, your famciclovir, your valciclovir to just speed up the healing and reducing the viral proliferation and subsequent shedding. But this does not prevent recurrence. The fact that you have treated does not prevent recurrence. If the individual is immunocompromised, definitely you must. It's not something you must consider. It's not something that you must think about rather. You must give your cyclovir or famciclovir usually within 72 hours, to limit the spread of the infection and to limit the risk of causing complications, so that you can quickly speed up the healing, reduce the shedding, reduce the risk of, complication. You can also have hepatic, an individual can develop hepatic whitlow, from the herpes guys, and you are just going to be seeing the blisters, the vesicles on the hands. Usually, what you are going to find in the history is an individual that is having an occupation that puts the person at high risk of being in contact with secretions from the mouth, like healthcare worker, particularly dentists, like respiratory therapists, like people that wash the dish, because of course you are going to be washing spoons that people have put to the mouth and the likes. What about for people with recurrent episodes? So don't forget, first episode, immunocompetent, just supportive. Sometimes you might need to give your acyclovir. But for immunocompromised or for people with severe infection, give it within 72 hours. That's where it is most effective. Even if the patient comes to me after 72 hours, I might still start it. But for you to get the best effect, give it within 72 hours. For recurrent episodes, if it's minor, you can manage it supportively, just like for the first episode. But you can, give your acyclovir so there's no golden rule. You can decide to give it just to reduce, to shorten the healing time by at least 2 days if you start the person on the antiviral. But if an individual is having severe frequent recurrence for more than 6 outbreaks in a year, you have to place that person on daily prophylaxis of any of the three. Once you are able to identify the question stem, I've never seen a question on this. So, but if we see it in the question stem that the person has been having the infection for 6 outbreaks in a year, daily prophylaxis is indicated. So it's important for us to know that most of the time it's viral, it clears off and becomes latent. But in people with HIV, it can last for more than a month. So you know that that's an HIV, defining illness you are dealing with when HSV infection persists for more than 1 month. So the management is not very hard. First episode, immunocompetent, supportive. Person cannot bear pain, give you antiviral. If person is immunocompromised or it's very severe, give your antiviral within 72 hours. If it's recurrent, mild, supportive. If you want to give antiviral, you can, just to shorten it for 2 days. But if the person is having severe frequent outbreaks, more than 6 times in a year, prophylaxis, daily prophylaxis. You can see, very easy, very, very easy. For the varicella zoster, we've already said it, droplet and contact. After the incubation period of 10 to 20 days, you are going to see the rash developing. And of course, the individual is going to be having the prodromal symptom first, the fever, headache, malaria, then the rash will start developing and they'll be evolving from the macule to the papule so they can become pustular, vesicular, bullous, then rust, then they crust afterwards and they become latent. And by the time they are coming back, they come back as epizoster. So, in adults, it is a very severe problem and they can cause complication of hep, which is what? Hepatitis, encephalitis, and pneumonia. So, an adult that is having chicken pox, we have to watch for that person that what will happen to your immune system, because this is a problem that is very common in younger children, that it comes and it goes. But if an adult is having chickenpox, there's a high risk of the person developing complication of hepatitis, encephalitis, and pneumonia. Once the varicella becomes latent and it comes back, it's going to come back as zoster. But depending on the ganglion where it has, hidden. So if it's high within the trigeminal ganglion, it can come out, as epizostal ophthalmicus, in which you are going to be having the vesicles developing within the face. We know this already. So this is an emergency. We need to give acyclovir, ASAP, to reduce the risk of causing blindness. Sometimes it can reactivate in the hair, And this is when it stays within the geniculate ganglion, you know, and the facial nerve is connected to the geniculate ganglion, and the person can have facial nerve paralysis. But because the facial nerve is very proximal, very close to the vestibulocochlear nerve, they can have problems with the vestibulocochlear nerve too, having vertigo, sensorineural deafness. So if you see a patient, they've told you that the patient had prior history of chickenpox or something, and now the person is having painful lesions. And after the pain, burning pain, you see vesicles cropping out from the hair, right? And the person is now having facial paralysis, problems with, hearing, vertigo. You know that what they are talking about is what? Epizoster oticus, or what you call the Ramsay-Hunt syndrome. Very easy stuff. You can have the pain persisting, acute hepatic neuralgia, just as I've said, for 1 month to 4 months, to 3 months rather. That's your 1 month to 4 months. That's your subacute, and for more than 4 months, that's your post-hepatic neuralgia. So epizoster is usually confined to a particular dermatome, maybe the ophthalmicus, maybe the thoracic dermatome, but it does not become widespread. If it becomes widespread, that's disseminated form, and you have to check for the immune status of that person. If you're having disseminated zoster, check for the immunity. I've talked about this. How do you make your diagnosis? Your PCR and your viral culture. How do you treat? It is a self-limited thing in healthy children. So if a child has varicella, you don't need to worry. The child is going to be fine. But if an adult has varicella, you have to watch out for your hepatitis, encephalitis, and the pneumonia. So usually there is a vaccine for varicella, which I've said that you give 2 doses at the age of 1 and the age of 4, and in adults after the age of 60, and also to HIV patients when their CD4 count is more than 200. Please do not give it to HIV patient with CD4 count less than 200, because it is a life attenuated vaccine. You give it when the CD4 count is more than 200. So adult with varicella, because of the fact that it is not usually self-limiting, you can treat with systemic acyclovir to treat the symptoms and prevent complication. What is the complication? Hepatitis, encephalitis, pneumonia. If they have the pain persisting, give NSAID for the acute and the subacute. But if they develop the pain for 4 months and more, that is your post-hepatic neuralgia, give your gabapentin, your pregabalin, and your TCA. Now, there's something you call the post-exposure prophylaxis. This is different from the vaccine. So, an individual can get exposed to an individual with varicella. An adult can come in contact with a person with varicella. So, you must give that person PEP to know if this person is already immune. Hello, can we hear me?
Yes.
So
Yes.
you want to know if this person is immune to the varicella or not. That's what you want to ask yourself. How do you know this? Ask the patient, have you been vaccinated? Have you had childhood varicella? If the person has been vaccinated twice and the person had childhood varicella, the person is immune. So what you want to do for that person is different from an individual that is not immune. So hope I'm not missing anything. Yeah. So if the individual is vaccinated and the person had childhood varicella and the person got exposed to an individual varicella, you don't need to do anything because the person is already immune to the varicella. That is it. But if the person has not been vaccinated and the person had not had childhood varicella, it means that the person is not immune. Then the next question you want to ask yourself, are you immunocompromised? Are you pregnant? Or are you a newborn? If the person is not immunocompromised if the person is not pregnant and the person is not newborn, so you put the person under the category of immunocompetent, then what do? You give the person your the vaccine. They should receive the vaccine, the varicella vaccine, within 5 days of exposure. But that is an active immunity because the person is immunocompetent. But if the person is under the category of immunocompromised state, maybe the person is having HIV or something, the person is pregnant, the person is a newborn, usually within like 5 days post-delivery or 2 days after delivery, usually you give them the immunoglobulin within 10 days of exposure. So that is the algorithm for the PEP for varicella. Please, we have to pay attention to it. They ask it. So if the person is immunocompetent, give the vaccine within 5 days. If the person is immunocompromised or pregnant or a newborn, give the immunoglobulin, not the vaccine. That is passive. You are giving a passive immunity to the individual within 10 days of exposure. Don't forget about the complications. Epizooster ophthalmicus, epizooster oticus or the Ramsay hunt, and the congenital varicella syndrome. So, congenital varicella syndrome, the first thing you are going to see is what you call cicatrization. So, there's going to be hypertrophic scar in that baby. That's the first thing. The second thing is that the baby will be having some cranial problems. There's going to be microcephaly, seizures, brain atrophy. The third is the limbs. There's going to be hypo limbs, small limbs, reduced development of the limbs, Then they have eye problems, choroidititis, cataracts, I think I should have it here. Yeah, I have it. Thank God. So hypertrophic scars, brain atrophy and seizures, hypoplastic limbs, choroidititis, cataracts, congenital varicella syndrome. Molluscum contagiosum. This is an infection that's common in young children and HIV people. You transmit it by use of fomites, clothing, towels, or by skin to skin, maybe during contact sports or during sex. Now, the age is going to tell you where the lesion will develop. If it's an adult, they are likely going to develop it through sex. So you are going to be seeing the papules with the central umbilication at the genital areas. In children, because of the fact that they get it through contact or through use of fomites, just imagine you are rubbing your towel on your body. Where do we rub your towel? You rub your towel on the face. You rub your towels on the hands and the trunk. So they tend to get the lesion on the trunk, the extremities, and the face. It usually spares the palms and the sole. Most of the time, it is asymptomatic, unless if it's inflamed or irritated, that's when it becomes painful. How do you make your diagnosis? If your diagnosis is uncertain, although it's clinical, but if it's uncertain, you can do your Wright or your James staining, and you are going to be seeing the molluscum bodies, which are eosinophilic granular inclusion of the virus within the epidermal cells. So they are going to have this cup-like indentation. These guys you have in here are the eosinophilic granules within the epidermal cells. Very important stuff. Molluscum bodies. If you see a giant molluscum contagiosum, think about HIV or anything that causes reduced cellular immunity. How do you treat? You ask yourself, am I dealing with a child or an adult? Am I dealing with a child or an adult? If I'm dealing with a child, I just wait. It disappears. I do nothing. If I'm dealing with an adult, I have to correct. I have to apply liquid nitrogen for cryotherapy. I can apply laser or can apply a blistering agent I call cantaridin to eliminate it. Just correct it out. Cryo surgery, cantaridin, remove it. I think I have some couple of questions. Let's see what is here. Okay. A 30-year-old man comes to the emergency department because of painful rash for the past 2 days. The rash initially started on his left lower abdomen and has spread to the rest of the abdomen and left upper thigh over the past 24 hours. The pain is exacerbated with movement. He initially thought the rash was an allergic reaction to a new laundry detergent and did not respond to over-counter histamine. 6 weeks ago, the patient was diagnosed with Hodgkin and started on Doxil, Pleo, Vinblastine. Sexually active with one partner, uses condoms, is pale, temperature is 37.9, the pulse is 80, the BP is 117. Examination shows 2 markedly enlarged cervical lymph nodes. A photograph of the rash is shown. Which is most appropriate next step in the management? So let us show us. Okay. What do we think this is?
This looks like a widespread molluscum.
Are you sure? Can you identify any central amplification?
Yeah.
Are you sure, Dr. Antonia?
Yes, I can see.
Sorry, I'm finding it difficult to. Okay, this. Are you
I'm
sure?
seeing umbilication, sure. I don't know.
But the I can't see any umbilical. Is it this one?
Yes.
But that's just. But you have to have like the umbilication to be very prominent. Yeah, but look at this.
Okay.
What do you look like?
Is dermatoma.
It's dermatoma.
Looks.
It's dermatoma. These are vesicles. These are vesicles. Vesicles with erythematous space, and so what do you think?
Herpes.
You can see
Yeah.
vesicles.
Shingles. Shingles.
Yeah, shingles. So you can see that they told us that the pain started. Then
Before the rash.
yeah, and even if they don't start before, but the rash is painful. So you can't think of molluscum again because molluscum is what? Asymptomatic unless
Symptomatic.
it is irritated or inflamed. So that's why I gave you that history. Once you are seeing pain, think about those guys. So what do you want to do for this patient?
This patient was diagnosed with Hodgkin's lymphoma, so he's immunocompromised and he's on anti-cancer medication. So he should be treated with IV IV acyclovir.
Exactly.
Acyclovir.
So if this patient is not immunocompromised now, we can give outpatient oral valacyclovir. But because of the fact that this guy is immunocompromised, or if this guy is having encephalitis, or if this guy is having disseminated infection, give inpatient treatment with intravenous acyclovir. So that's just the way to look at it. Good job. Let me see if there's anyone up here. Okay, there's one here. So, a 67-year-old man comes to the physician because of progressive burning pain and intermittent electrical shocks in his right chest for the past 4 months. Over the last 2 weeks, the pain has been increased to the extent that he can no longer tolerate clothing on the affected area. That is what we call allodynia. 4 months ago, I forgot to mention that. 4 months ago, he had a rash around his right nipple and axilla that resolves a week later. The patient had myocardial infarction 2 years ago. He had smoked for 47 years. He's on drugs, aspirin, statin, metoprolol, ramipril. His temperature is 36.9. The pulse is normal. BP is elevated. Examination shows increased sensation to light touch over the right chest. The reminder of physical examination shows no abnormality. Which of the following is the most appropriate next step in the management? What do we think? Don't forget, marry the symptoms, have your diagnosis, then pick your answer. Hello, are we there?
Yes. I'm saying that patients seem to wait, let me look at the question. Okay, patients seem to have post-hepatic neuralgia.
Post-hepatic neuralgia, fantastic.
Yes.
Why?
It has a pain. He said electric-like shock pain in the right chest for the past 4 months,
Fantastic.
and earlier on has had a lesion in that area. Yes.
Fantastic. So what are we giving this guy?
So you give all these pregabalin and gabapentins.
Fantastic.
For that.
So we pick our gabapentin and we move. A 53-year-old man resides in California is brought to the emergency department because of shortness of breath and a dry cough that started 1 day ago. He has had a periodic rash for the past 3 days. He has CML and is undergoing allogenic bone marrow transplantation 4 months ago. And he underwent bone marrow transplantation 4 months ago. Fever is present. The pulse shows saturation of 92. Physical examination shows multiple crops of vesicles over the trunk, the face, extremities. The X-ray shows multiple nodular interstitial infiltrates bilaterally. What is the most appropriate treatment for this patient condition? I think this is straightforward. So what does this patient have, Dr. Antonio?
This patient is a post-transplant patient and is also immunosuppressed.
Nice.
So, thinking of varicella.
Varicella, you don't sound confident. Why?
No, I'm thinking of varicella because the lesions, like you said, on the face, the crops of multiple crops of vesicles over the face, trunk, and extremities.
Yeah.
Yeah, that has varicella.
Yeah, and again, can you identify any complication here?
Pneumonia has a dry cough.
The guy is already
He can
having
with shortness of pneumonia. Yes.
Don't forget. Why do you think he's having the pneumonia? Why?
His complication of varicella is causing in an adult. Is immunocompromised.
Exactly. So this guy is an adult and he's not having background immune support. So those two factors put him at risk of having HEP, hepatitis, encephalitis, pneumonia. So this guy is a candidate to take IV Cyclopin. Okay. So that is that. Let's move to the warts. So we're already familiar with warts. They're just like cauliflower-like papules that occurs within the body, and they are caused by the human papilloma virus, serotype 16 and 18, usually. And serotype 6 and 11. Please, I'm so sorry about that. They're usually caused by serotype 6 and 11. Why the serotype 16 and 18 of HPV can cause squamous malignancy, which is squamous cell carcinoma of the skin, of not really the skin, but different part of the body, like the oropharyngeal, the cervix, the anus, and the likes. The skin too. And the spread is by direct contact. So people that engage in sexual activity, they can transmit the HPV. So you commonly see it in the hands, although they can occur anywhere. The classic genital wart, which is the condyloma acuminatum, can be caused by serotype 6 and 11. And they appear as cauliflower papules and plaque in the vulva, the perianal region, and the penis. So this is just what we are going to see. And they cause the serotype. They cause the benign wart, which is the cauliflower wart, and the serotype implicated is 6 and 11. Very important, 6 and 11. 6 and 11. So mothers with genital warts can transmit the HPV to their babies during birth, intrapartum. And in that baby, the baby is going to develop respiratory papillomatosis. So this is a very common step 1 question. And it can come out too in our step 2. So if the baby is having respiratory papillomatosis, so they can develop weak cry, hoarseness of voice, stridor, which is talking about obstruction at the upper airway. So you make the diagnosis clinically. If you apply acetic acid to this area, is going to be white. So that helps you separate the wart from the normal skin lesion. So if you see the question saying they apply acetic acid and the lesion became distinct, that is in keeping with what? The most accurate test is to do your PCR for HPV. Don't forget, most of the virus, PCR or culture. So PCR. How do you treat? So just like molluscum contagiosum, you can use laser, you can use cryotherapy, you can correct, different things. You can exercise, just normal things that you use in excision, cryotherapy, laser therapy, curettage, and sometimes you can use chemical treatment, but the chemical treatment is peat, podophyllene, imiquimod, and trichloroacetic acid. The podophyllene and imiquimod, the first and the last, is contraindicated in pregnancy. They are teratogenic. Why the trichloroacetic acid can be used in pregnant people? Because of the fact that the HPV can cause cervical cancer, you have to monitor them, for cervical cancer by constant pap smear, and you need to vaccinate individuals, against HPV. And if they are involved in sexual activity, encourage use of barrier method, to limit the development of the HPV infection. So you can reduce infection by vaccinating and by using condoms or diaphragm. So that is that. Anybody that develops a genital wart, you can excise, surgically. You can do your laser, you can do your cryotherapy. If you want to do your chemical, you can use your peat, podophyllene, imiquimod, and trichloroacetic acid. But beware of podophyllene and imiquimod in people that are pregnant. Sorry, I said the first and the second, not the first and third. The PI, that's what that's what you don't use in pregnant people. But the T, trichloroacetic acid, you can use. So moving on to the bacterial infections, we are not going to be wasting more time here. Impetigo is the first to know, and impetigo is local infection of the epidermis, and it is caused by Staphylococcus aureus and group A strep, right? We have two types, the non-bullous and the bullous. The non-bullous and the bullous. The non-bullous can be caused by the strep and the group A, while the bullous is caused by the staph. So the non-bullous can be caused by staph and the group A, while the bullous is caused by the staph. And what do you see in both of them? You are going to see lesions that are covered by honey-colored crusts, with papules, usually within the face, in the mouth, the nose, the ears. That is impetigo for you. So if it's bullous, you are going to be seeing those bullous lesions. This one now, it is non-bullous. It has, busted. So this one now is a non-bullous type. It can be caused by both staph and your gas, your group A Streptococcus. But if you are seeing the bullous type, think about your Staphylococcus aureus. Because it's caused by the bullous type, for example, is caused by the Staph aureus through the release of the exfoliative toxin. The Nikolsky sign is going to be positive in them. Nikolsky sign is positive in them because it is caused by the exfoliative toxin producing strain of Staph aureus, and from the bullous type, it can evolve, to progress to the Staphylococcus scaly skin syndrome. So I have talked about the Staphylococcus scaly skin syndrome, right? Which is usually caused by Staphylococcus aureus, and the exfoliative toxin destroys the desmoglein, which causes intraepidermal separation. And the patient can have fever, the discomforting rash, flaccid blisters, and they do not form crust when they rupture. But this individual can have perioral crusting in the mouth. But the lesions in the part of the trunk and the other part of the body do not form crust when they rupture, and it does not affect the oral mucosa. But Nikolsky sign is going to be positive. So this is very common in neonates and in adults with renal insufficiency, just like we have said. Ecthyma is another bacterial, lesion of the skin, and this one is just a more deeper form of the vertigo, in which you have the ulcers penetrating down into the dermis, and you are going to see them appearing punched out with yellow crusting. So instead of the impetigo to be confined to the epidermis, if you now have like a form of impetigo deep down penetrating into the dermis with yellowish crusting or exudate, think about ecthyma. So this is an example of ecthyma. So the bullous type and the ecthyma, the bullous impetigo and ecthyma, they are more severe. So the medication you are going to use is quite different from the non-bullous. So we are going to look at the medications shortly. The diagnosis is clinical, it's clinical, and you can do your gram stain and culture to identify the causative organisms. So the antibiotics that you are using is actually is based on the severity and the suspicion for MRSA. So if you are thinking MRSA, particularly people with the bullous impetigo, you are thinking MRSA, just give your anti-MRSA agent, which I'm going to talk about shortly. So now, if an individual has impetigo and it is non-bullous, you can give topical mupirocin. To treat it. But if it's severe, if this non-bullous impetigo is severe, you might not want to give topical mupirocin. So in that case, you might want to give your DC, which is your oral cephalexin or your oral dicloxazilin, which can cover for both gas and your staph. So let me come again. If you see the lesion to be non-bullous type, but it's mild, just apply your topical agent, topical mupirocin. Now, if it is severe, non-bullous impetigo, but severe, give your DC, which is your what? Dicloxazilin and your cephalexin. Oral cephalexin. Cephalexin comes in oral form only. So oral cephalexin and your dicloxazilin. It covers for both staph and the strep. You also do this if this individual has ecthyma. You consider ecthyma to be a severe form of non-bullous. So you give the person your dicloxazilin and your cephalexin. If the individual has the bullous type, so you give your DC, dicloxazilin, or your cephalexin. But if you have a very high index of suspicion for MRSA, you now use your DCT. But your DCT is going to be your doxycycline, your clindamycin, and your Septrin. So let me show you. So if you are dealing with, so that's not the way it actually is here, but just like we have said, if it's non-bullous, mild, give your topical mupirocin. If it's severe, you can use your oral cephalexin and your dicloxazilin. Or if the person has a timer, just give oral cephalexin or dicloxazilin. If the person has the bullous type is a severe disease. That's what they call severe disease. The bullous is severe. And if the person has MRSA, if it's likely to be MRSA, just give your DCT, which is your doxycycline, your clindamycin, or your trimethoprim sulfamethoxazole. Because there's a high chance that the bolus type is going to be caused by MRSA. So that's why they just start any of those three straight up. If the person has SSS, you can use nafcillin or your vancomycin. And of course, you are going to treat the wound, appropriate dressing, fluid balance, and the time, and the others. Then the individual that can return to school 24 hours after you start your therapy. So what are the complications of these guys? The impetigo can lead to acute post-surgical glomerulonephritis, which we know, and impetigo can also progress to SSS because we've said that both of them, they are caused by the exfoliative toxin of the staph. Please, do we understand this management, or I should come again because I know it can be confusing? Dr.
Yes,
Please come again, please.
Okay. Now, identify the lesion. Is the lesion bullous or non-bullous? If the lesion is non-bullous, okay, you know that this one is not very severe, right? So, if it's not very, you have seen the description of the lesion, it's not very severe, it's just mild non-bullous, just give your topical mupirocin. That is all. If the person is having non-bullous, but severe, you are seeing fever, you are seeing chills, rigor, severe lesion, don't give topical antibiotic. Instead, give your DC, which is your oral dicloxazine or your oral cephalexin. You also do this if the person has ecthyma. You consider ecthyma to be the severe form of non-bullous impetigo. So, ecthyma and the severe form of non-bullous impetigo are the same thing, the same treatment, your D and your C. If the person has bullous impetigo, just assume that the cause is your MRSA. Then you give your DCT, your doxycycline, your clindamycin, and your trimethoprim sulfamethoxazole oral. Do you understand that?
Yes.
Nice.
Yes.
Then, if the person has SSS, you give your nafcillin for your staph or your vancomycin, and you do your wound care. Then the child can resume back to school after 24 hours of treating. Complications, your PSGN and your SSS. Very easy. Let me see if I have. Okay, this is a picture. I don't think I have any question. Let me see if we can get this. I think we are going to get it because you can see the option is not. Okay, now let me see if we can get this. So, a 13-year-old boy is brought to the physician because of a non-pruritic painless rash on his face for 5 days. His 62-year-old maternal grandmother has bullous pemphigoid. His development is adequate for his age, and immunization are up to date. He's healthy, is well nourished, temperature is 37, pulse is 90. Examination shows a non-tender rash, just anterior to the lower lip. The photograph of the patient's face is shown. Oh my God, I do have this photograph. The remainder of the examination shows no abnormality. What is the most appropriate next step? Oh my, I did not have this.
Well, going by the location, it's more of impetigo.
Yeah, but we need to know it. We need to know if it. I thought I used to have it. Let me see. Oh, when I was arranging that stuff, let me see if I can. I'm not sure I have it. Damn it. Okay, but yeah. So which one are we thinking of? Now we don't even know if it
topical mupirocin.
Why? Because you think it's what?
I'm thinking because of the location is non-bullous impetigo.
Yeah, so it could be
The
non-bullous
usual part of
impetigo.
it is around the nose and around the mouth.
Yeah, so it's possible. It's possible it's non-bullous. So if it's non-bullous, and because this presentation is not very severe, you know, so just give your topical material if it's non-bullous. So that is that. And then let's see this. A previously healthy 4-year-old boy is brought to the physician because of blisters and redness in his cheek, redness on his neck and chest for 2 days. So blisters and redness on his neck and chest for 2 days. He also had a fever, lethargic, and has not eaten since the rash started. He has not had cough, wheezing, or dysuria. He's the only child, and there's no family history of serious illness. Immunization are up to date. Temperature is high. Pulse is normal. Blood pressure is low. Examination showed flaccid blisters all over his neck and trunk that rupture easily. Area of erythematous moist skin are noted. Swelling and erasure about the trunk result in a blister. Oropharyngeal examination is normal. Laboratory study shows this elevated leukocytes, segmented neutrophil is elevated, ESR is elevated, urinalysis is normal, which is a likely diagnosis. So, what are we going for?
SSS.
SSS. Why?
Well, because the presentation and also the mucosal, the oral pharyngeal examination is normal, so it can't be SGS or the other one.
Nice. So we can see the flaccid blisters. So they said he had flaccid blisters, that rupture easily, and there's diffuse erythematous moist skin, right? And they also told us something related to the Nikolsky sign. And look at the systemic features. There's hypotension. So you know that this is much more severe, So, hello? You hear me?
Yes, we can hear you.
This is much more severe. So that's in keeping with Staphylococcus scarlet skin syndrome. And see the segmented neutrophils. And the child is within the age range for Staphylococcus scarlet skin syndrome, which is less than 5 years, 6 years rather. So that is that. So see. Okay, I think that'll be all. Good job. Okay. So moving on to cellulitis. This is a deeper infection. This one is now entering the dermis and involving the subcutaneous tissue. And it is caused by staph and group A strep 2. And it usually comes from maybe a damaged skin or systemic, origin. Probably the person is an IV drug user or something. And the first thing for us to do for cellulitis is to identify, is this lesion purulent or not? If it's purulent, think more of staph. If it's non-purulent, think more of group A strep, right? And another thing for us to look out for is the cardinal sign of inflammation. So by the time you start saying that the area of the leg is tender, it is edematous, is warm to touch, we know that this is likely going to be like a deeper infection. Then what you want to do next is to see, is it well demarcated or not? If the question tells you that that area of inflammation is well demarcated, please, that is a recipe. If it's not well demarcated, then you can be thinking of cellulitis. Very, very important stuff. What are the risk factors? DM, IV drug, venous stasis, immunocompromised trait, previous trauma, previous injury, think of anything, because it's very common in the lower extremity. How will they present? They will have red, hot, swollen, tender skin, cardinal signs of inflammation. You can have fever and chills. This doesn't rule out erysipelas. In fact, the fever and the chills come very early in patients with erysipelas. So, erysipelas is confined to, it's just very similar to cellulitis, but it's confined to the dermis and lymphatics, unlike cellulitis that extend into the subcutaneous tissue. But people with erysipelas will have a characteristically raised, well demarcated erythematous area of skin. Very important. How do you treat your erysipelas? If this patient is having systemic symptoms, give, like fever, chills, give IV cefalozine, cefazolin, IV cefazolin. If the patient is not having systemic findings, no chills, no rigor, just give your oral cefalexin. So I've said it, cefalexin comes in oral formulation only. So if it's less severe, just give your oral cefalexin. If it's systemic findings, fever, chills, blah blah, IV cefazolin. IV cefazolin. That's for your erysipelas. You don't give anything topical in erysipelas and cellulitis because their own infection is deeper. So the diagnosis is clinical. You can take wound or blood culture, to determine antibiotic sensitivity and the right treatment to institute. Rule out complications. Abscess can get to the bone, it can get to the fascia, causing necrotizing fasciitis, causing osteomyelitis, causing abscess. How do you treat? I've talked about erysipelas. If it's fever, chills with it, IV cefazolin. No fever, no chills, give your oral cefalexin, right? So for cellulitis now, you need at least 5 to 10 days of oral antibiotics. But if the person is having maybe DM, having all these things that we have here, extreme of age and infection, orbital infection that you need to penetrate, diabetes, comorbid, systemic toxicity, you have to give it IV. You have to give it IV. But what are you giving IV? You have to ask yourself, this cellulitis I'm seeing, is it a purulent cellulitis or a non-purulent cellulitis? If it's purulent cellulitis, consider MRSA to be the implicating organism. And what is the treatment we said we use for MRSA? Anybody? MRSA causing bullous impetigo?
Vancomycin.
No. MRSA causing bullous impetigo.
MRSA causing bullous impetigo. Doxycycline,
Yeah.
clindamycin, and trimethoprim sulfate.
So your DCT, and here now you can also use your Vanco. So your SSS, you can use your nafcillin or your Vanco. So here, purulent cellulitis, MRSA, use your DCT or your Vanco. For non-purulent, it's going to be gas. So you can use any of those, first generation cephalosporin that we have said, your cefalexin or your cefazolin. So if you want to give it IV, you are going to pick IV cefazolin. If you want to give oral, you give oral cefalexin, or you can also use your penicillin for your beta hemolytic strep. Please, is it confusing? Or
Yeah, can you explain a little bit?
So if it's cellulitis, what do we say you do? You identify if it's purulent or not. If it's purulent, you are using MRSA. You are treating MRSA. You can give your vancomycin or you can give any one of your DCT. If it's non-purulent, it is your gas. And the treatment for gas is your penicillin or your cephalosporin. But your cephalosporin that you are using is first generation, just like we have been using. Any one of cefalexin or cefazolin. And I told us that cefazolin is the preferred one when we want to give IV. So, for example, if somebody is having non-purulent cellulitis and the person is having DM, you know that that's an indication for IV. So you give IV cefazolin. If the person is not having DM, the person is immunocompetent, you can give oral cephalexin, or you can just give penicillin. Do you get it now, Dr. Antonia?
Yes.
So that is what you are going to ask yourself. Let me see if yeah. A 3-year-old boy is brought to the physician because of a 3-day history of pruritic skin rash on his chest. He has a history of atopic dermatitis but is otherwise healthy. The immunizations are up to date and he takes no medication. The temperature is 37 degrees Celsius, the pulse is elevated, respiration is normal, blood pressure is low. Examination of the chest shows multiple vesicles and flaccid bullae that contains clear yellow fluid, as well as ruptured bullae that is surrounded by thin brown crust. Examination of the oral mucosa shows no abnormality. Result of complete blood count are within reference shape. Which of all is the most likely diagnosis? What's the diagnosis here?
Is it bullous impetigo?
This is bullous impetigo.
Yeah.
A 43-year-old man comes to the physician because of redness and swelling on his right leg over the past 2 days. He reports that it's very painful to touch. He has had fever and chills. He has no chest pain or shortness of breath. He has a history of type 2 DM and underwent saphenous vein stripling and ligation on his right leg 3 years ago. He works as a security guard. He does not smoke or take alcohol. His medications are the anti-diabetic drugs. Temperature is elevated. Pulse is normal. Blood pressure is normal. Blood pressure is 138/72 elevated. Examination shows a 8 cm indurated, tender, warm erythematous skin lesion with sharply demarcated margins on his right lower leg. There is no inguinal lymphadenopathy. Toe web intertrigo is noted. Toe web intertrigo is noted. Which of the following is the most appropriate next step in the management of these patients?
Give IV cefazolin.
So what is your diagnosis?
Erysipelas.
Good job. I will give IV cefazolin because this guy is having fever, is having chills, is diabetic, So you give IV cefazolin. So, necrotizing fasciitis. We know necrotizing fasciitis, we don't need to waste time. The patient is just having infection from Staph aureus, from E. coli, or from Clostridium, or from strep pyogen, Clostridium, your gram negative, and Staph aureus, any one of them. But the common ones is Clostridium and strep pyogen. They can gain entry after history of trauma or surgical operation on the part of the body, and they start releasing their toxin, which will start destroying the fascia. For example, Clostridium perfringens release the phospholipase that is an aflatoxin that can destroy the fascia, and from there you start having eventual necrosis with appearance of bullous lesion. Initially the patient is going to be having exaggerated pain, which is not in keeping with what you are seeing. The pain is out of proportion to what you are seeing, and the area becomes necrotic, the color becomes dusky, purplish, like something like this. You see bullous lesion, you see foul smelling putrid discharge, and of course we should not forget If you touch it, you are going to feel the crepitus, which is gas accumulating within that area. So most of the time, they will tell us that the patient had a trauma, a prior surgical operation at that area, which allows for entry of the Clostridium or the strep pyogen, causing the infection. So we are not wasting too much time on that. What do you want to do? Immediate surgical exploration and debridement. That is the next thing you do. If you do your imaging, you are going to see gas in the soft tissue because the anaerobes, they produce gas. They cause the crepitus. They cause the foul-smelling putrid discharge. All of them are classic for necrotizing fasciitis. So, do your immediate surgical exploration and debridement and bombard that individual with antibiotics. So, surgical emergency. Early and aggressive surgical debridement is critical. Give your blood spectrum antibiotics. And if strep is the principal organism, give your penicillin G. Penicillin is a mainstay for your strep. Then you add clindamycin to limit the exotoxin production, and to cover for the anaerobes, you have to give metronidazole, just like we know, or a third generation cephalosporin. So, if the organism is Clostridium, you can give your metronidazole or a third generation cephalosporin. If the organism is strep, give your penicillin G, and you add your clindamycin to limit the exotoxin. Moving on to folliculitis. I think I have a question here. If previously healthy 5-year-old boy is brought to the physician because of a 2-day history of rash and swelling on his left lower leg, rash and swelling, the mother says that the boy complained of an insect bite while playing outdoors 3 days before the onset of the lesion. Immunization are up to date. The weight and length is good. Temperature is elevated. Pulse is elevated. Blood pressure is low. The left leg is swollen and tender with sharply demarcated erythema. There is a narrow red line with a raised border that extends from the lower leg to the groin. The remainder of the examination shows no abnormality. Which of the following is the most likely cause of this finding?
It is a history of rash and swelling, the left lower leg, or of insect bite,
Okay, I don't think I told us, but let me know. Just tell me the diagnosis and I will help us with the answer.
Is it not erysipelas?
This is erysipelas. Swollen, tender,
sharply detected erythema.
There's no catch. This is erysipelas, but I did not tell us the causative agent for erysipelas. Do we know? Anybody knows?
Gas.
Gas. That's why it's gas.
Okay.
Gas causes erysipelas. So that is that. That is why you use your first generation cephalosporin to treat erysipelas. You can see that we are not using vancomycin or DCT for erysipelas. We use, if the patient has fever and chills, you give your IV cefazolin. If the patient doesn't have fever and chills, you give your oral cephalexin. Both of them are first generation KEF and they treat the gas. So gas causes erysipelas. The lesions are always well demarcated. If the lesions are not well demarcated, it changes the diagnosis immediately to what? Cellulitis. So, a 63-year-old man comes to the physician because of 2-day history of redness, swelling, and pain in the right leg. During this time, he has also had fever, chills, and nausea. He reports seeing liquid oozing from the affected area of the right leg. He has hypertension and GERD. 3 months ago, he was hospitalized for treatment of a hip fracture. His current medication includes metoprolol, enalapril, omeprazole. His temperature is elevated, pulse is elevated, blood pressure is elevated. Examination of the right lower leg shows a large area of erythema with poorly demarcated borders and purulent drainage. The area is fluctuant, warm, and tender to touch. Examination of the right groin shows several enlarged tender lymph nodes. There is a mild edema of the ankles bilaterally. In addition to incision, drainage, and taking cultures from the wound, which are following is the most appropriate next step in treatment. Anybody?
Surgical debridement.
Dr. Antonia, what is your diagnosis? You know, I always say it. Say your diagnosis. Then
okay, this is cellulitis. This is cellulitis.
So, Dr. Antonia, when we were talking about cellulitis, did we talk about surgical debridement?
No. This is cellulitis and it's oozing.
So you have done your incision and you have drained. So already you have done a form of debridement, a little. So you don't need to do surgical debridement. So what do you now do if you have identified that this person? What is the first thing I said after you have identified your cellulitis? What do you check next?
The causative organism.
No, aside that, there's something you will ask yourself before you know the likely causative organism.
Is the discharge
purulent?
Yes. Is it purulent or not? Now, what about this? Is this purulent or not?
It's purulent.
This is purulent. So what's the causative organism going to be?
Staph.
MRSA.
Exactly. So if this staph, so what are we going to do for this patient?
Vancomycin.
Intravenous vancomycin. Someone is laughing.
No, I'm coughing. I have a airway.
Okay. Yeah. So intravenous vancomycin. That is it. I'm not sure I have any other stuff. Okay. So that guy is already having systemic toxicity, you know. He's having a comorbid stuff. Look at it, maybe DM, GAD, everything. So you need to give IV antibiotics. Okay, so don't forget the one that you debride is your what? Your necrotizing fasciitis. That's the one that you do your aggressive surgical debridement. So folliculitis is inflammation and infection of the hair follicle. So it is caused by staph, by strep, or your gram-negative bacteria. Sometimes the yeast can also cause it, Candida or Malassezia 44. And I'm not sure I have an image. I don't like this image. I forgot to add that image, and I thought I had it. You know, what you are just going to be seeing is that you notice an area of erythema that is going to be folliculitis. Let me see if you can have folliculitis. Yeah, so we are going to notice that the folliculitis is going to be appearing in area where you have hair growth. This is not very clear. You are going to see the hair coming out of that follicle. I've seen the image. So look at this now. Oh, I thought I saw it now. Damn it. I'm not sure if this is very prominent, but you are going to be seeing hair growths, you know, at the center of this lesion. Like you'll be seeing hair growing out of it, you know, here. So that is folliculitis. The papule or your pustules, you know, they are going to occur at the center of the hair. You see hair coming out of the lesion. So that's telling you that lesion is occurring around the hair follicle, and that is in keeping with folliculitis from the word folliculitis. Follicles, lesions around the hair follicle. So you can see tiny pustules. Sometimes they have pus or papules around the opening of the hair follicle with the hair penetrating. You can see this. Please don't forget this. I'm sorry I cannot get a good image. You can check it at your own leisure time. You are going to be seeing the hair penetrating the papule or the pustule. Now, when the infection is deeper, you'll notice that there's going to be abscess at the downstream, inside of that hair follicle, inside, at the base. You are going to be seeing abscess happening there, and it's going to lead to a furuncle. So an abscess developing on a folliculitis is what you call a furuncle. Now, when the hair follicle abscess now coalescence together, you have multiple occurring at the same time. You call that the carbuncle. So that is it. So the starting lesion is folliculitis, papules around the hair follicle. Then at the base of the hair follicle, you have abscess forming furuncle. The abscess coalescing together, they form carbuncle. So this is now looking like carbuncle. You can see the purulent discharge. It shows that there's an abscess inside the base of the hair follicle. And you can see there are multiple. So if you saw only one now, you can call that furuncle. But if it's multiple like this, carbuncle. So this is a very serious stuff. Infection extending down to the fascia and has formed a confluence of many furuncle. Once you start seeing pus discharge, you think of stuff. So now, this lesion, folliculitis, is very common. The common one that they talk about in the USMLE is a hot tub folliculitis. So they will tell you that the patient swims regular in public pools, and they start developing the folliculitis. And the implicating organism here, don't forget, we have said that it's very common due to infection from staph, from strep, and gram-negative. The gram-negative we are talking about here is Pseudomonas. So Pseudomonas is the cause of hot tub folliculitis. You cannot forget, particularly in people that go to swim in hot tubs. So the risk factors include swimming in hot tubs. It includes background DM, immunosuppression. All of them, they increase the risk. And you can have what we call eosinophilic folliculitis, which is very common in AIDS. This will not respond to typical treatment. So they can have eosinophilic folliculitis. The diagnosis is clinical. Of course, by the time I'm looking at the lesion, I will know. You will see it. You see the hair growth. You know that, okay, this is folliculitis. If you see purulent discharge, this is furuncle. If it's multiple, this is carbuncle. You can do your KOH prep or your biopsy to exclude eosinophilic folliculitis in AIDS or fungal infection like malassezia and candidiasis. So the way I master the treatment is just to assume that you treat folliculitis like what? Impetigo. So if it's mild superficial disease, just give your topical antibiotics over that area, mupirocin. If it's more severe, so you give your DC. You give your DC, which is your what? Your dicloxazoline orally with your cephalexin. Both of them, they have coverage against your staph and your strep. Don't forget, 3 things majorly: staph, strep, and gram-negative, which is Pseudomonas. So if it's mild, give your topical mupirocin. If it's severe, give your DC, dicloxazoline, or your cephalexin. But if you suspect that what you are dealing with is MRSA, escalate to clindamycin or doxycycline. Don't forget DCT, doxycycline or clindamycin. You can see that it's very similar to impetigo. Now, I've never seen a question, on this, and what I'm just going to say is that there's a tendency that they will just tell us that they have used cephalexin or dicloxazoline and it's not working. So you know that that's likely to be MRSA. So give either your DCT, your big DCT, your dicloxazoline, your clindamycin, or your trimethoprim. The patient is going to be all right. But if you are able to identify the cause to be swimming in hot tubs, you already know that this is Pseudomonas causing hot tub folliculitis. So it's usually self-limiting. You don't need to treat. But if it's very severe, give a cephalosporin, a fluoroquinolone like ciprofloxacin. We all know that ciprofloxacin works against Pseudomonas, so you can give them for people that are severe. But if it's not severe, it's self-limiting, it will go. So don't forget that about folliculitis. Acne is already what we are very familiar with. We don't need to waste more time. It is a disease common in adolescents, and the pathophysiology is like categorized into 4 different mechanisms. You have hyperkeratosis with follicular obstruction from the keratin, and when there's occlusion, you tend to have sebum accumulation, and the individual can be, an adolescent that is secreting a lot of androgen that also, stimulates sebum production, and this sebum are not able to get out, and you have your Cutibacterium acnes colonizing the sebum, and from there you can have inflammation. So sometimes acne can come from drugs. What did I say is the commonest dermatological manifestation of lithium? Anybody remembers?
Skin rash.
Yeah, but which skin rash? Lithium.
Yeah.
The commonest dermatologic manifestation of lithium is acne.
Yes.
Then I also said that lithium is implicated in causing a particular skin lesion, and I use the acronym.
Psoriasis.
Yeah, psoriasis.
Psoriasis.
So we can also have corticosteroid causing acne, and that is going to be monomorphic. We're going to look at it closely very soon. We have to know that steroid can cause acne, and of course people that use too much makeup can also have acne due to occlusion of the follicles. People that produce a lot of androgens, there are some endocrinologic disorders that can produce androgens. We know congenital adrenal hyperplasia. Have we done our endocrine review?
Yes, we have done endocrine.
So what are the two?
Yes, we have done endocrine.
What are the two hormones that is elevated in congenital adrenal hyperplasia? Any type? No, don't let me say any
Sorry,
type.
what's the question?
What are the two hormones that are elevated in congenital adrenal hyperplasia usually?
The 17-hydroxy steroid.
Okay, let me say that. Okay, 17. Well, you'll be correct. But those hormones are actually part of. One of them is the reason why you have the hyperplasia, and the other is the reason why you have the virilism, the acne, blah blah.
It depends on the enzyme that is deficient. So
okay, so let me give you an example now. If it 11. What is making the 11 deficiency cause adrenal hyperplasia? I know I'm not asking the question well. I know it can be a little bit challenging. There's something about CH that is causing this hyperplasia. You guys never thought about it. That why are we having hyperplasia? We must be able to.
Cortisol deficiency.
Yes.
And there is elevated ACTH trying to. Yeah.
Exactly. So ACTH is elevated in CH, constant. That's a constant factor regardless of the enzyme. Then the other thing is the androgens. Although androgens might not be elevated in 17. You get so the androgen and the ACTH, is usually common, and because of the androgen, they can have acne. Then people with PCOS. PCOS is a condition that causes elevation of two hormones. What are they? I'm also trying to revise your endocrine and ONG with you guys. PCOS causes elevation of two hormones. Dr. Rande must have said this. Dr. Miriam, are you there? Hello? Hello?
Chief, we can hear you.
Yes, like what are the
androgens are elevated. The androgens are also elevated in PCOS.
And what again?
And then I think the follicle stimulating hormones.
That's Antonia. The ratio is equal to 2:1. LH is, I said the ratio is equal to 2:1. Even if you are going to talk about the LH FSH, you pick LH because LH is twice
higher than the other.
Yeah, but that's not the two hormones I want to ask. It is androgen and estrogen. You guys have forgotten this thing. Is an opening statement. PCOS elevate estrogen and androgen. So, because of the fact that PCOS is androvulatory, the follicles are not shedding off. Your granulosa cells are still intact. What does granulosa cell produce?
Estradiol.
Yeah, estrogen. So that means that this individual is going to be spending a lot of time in the proliferative stage. You know, that's PCOS. And again, the estrogen will be converted, to androgen by the, what's it called? No, not that. It's not actually, it's androgen that is converted to estrogen. It's androgen that's converted to estrogen from the
peripheral tissue.
From the peripheral tissue. Yeah, but don't forget the two major hormones that is elevated in polycystic ovarian syndrome is your androgen and your estrogen. So that's why they have the acne, because of the androgen. They have a lot of acne and the likes. So the Cushing syndrome too, they can produce a lot of acne, a lot of androgens because of the effect of what's it called, ACTH on the adrenal gland. So please don't forget all these things. It's very, very important. Very, very important. There are 3 stages of acne lesions: the comedoma, the inflammatory, and the scar. So comedoma just means you're having lesions developing from occlusion of the follicles. And when you have occlusion of follicles, you can have 2 types of comedones: the open and the closed, the open and the closed, the open and the closed. If it's open, it means that you can easily oxidize the content in the follicles and they are going to appear blackish. If it's closed, you cannot oxidize them, they will appear white. That's it. So comedoma is follicular occlusion. But when the follicles now ruptures, you now have inflammation. You start having the papules, the pustules, the nodules, the cysts appearing. So here now, comedoma, just give keratolytics that will open the follicles. Keratolytics like your salicylic acid, like your retinoids, But once you are seeing inflammatory, you need to introduce maybe your benzoyl peroxide and your antibiotics: erythromycin, clindamycin, doxycycline, right? So that's the way it works. Once you are seeing scarring, you know that it is very severe. So you have to use something like maybe your isotretinoin most of the time. So it's very common in puberty, because of androgen production. Drug-induced acne is a common side effect of glucocorticoid. And what are you going to see? The lesions are going to be monomorphic, papules. You are not going to be seeing comedones. You are not seeing nodules. You are also seeing one type of lesion. That's why they say monomorphic, papules. And you can bring it down when you discontinue the steroids. Don't forget, lithium can also cause acne. Acne mechanica occurs in area of friction and pressure. So people that the people that use crutches, that friction from the axilla can lead to acne. Heavy backpacks, people that travel a lot mountaineering carrying heavy backpacks, the backpacks can irritate the shoulders and they can have the acne. The bra straps also in ladies too can irritate the shoulders back to the part of the back and can lead to acne. But the acne is going to so that's that about the acne. And so don't forget, comedoma, open up closed comedones. Just give your keratolytic to open up the follicles, like your what? Retinoids. But once you're having inflammatory and you're having papules, pustules, introduce your benzoyl peroxide, your antibiotics. And you want to start by using your retinoids. You had your benzoyl peroxide. If that doesn't work, you had your topical antibiotics like your erythromycin or your clindamycin. Then you can now, if that doesn't work, you can remove your topical antibiotic and you can start oral antibiotic like doxycycline. If that doesn't work, then just start your retinoids, your your isotretinoin, particularly people with the nodulocystic form. So once you have that algorithm in your head, that's that about management of acne. Nothing can shake you. So doxycycline generally they can cause photosensitivity rash. So have that at the back of your mind. Anybody on doxycycline can have photosensitivity rash. So how do you treat mild to moderate acne? your topical retinoids, they are the most effective for comedoma. You can see the statement. I'm not the one that said it. The first state said it. So topical retinoids are effective for comedoma acne. You can add your benzoyl peroxide because it can kill the Corynebacterium acnes. Can you see like that? Your retinoid is just to open up the follicles and treat the comedoma. If you're adding benzoyl peroxide, it means you want to kill the organism. You can also add your topical antibiotics, your clindamycin, your erythromycin, if the response to other topicals is inadequate. If it's moderate to severe, you need to use your oral antibiotics, like your doxycycline or your minocycline. You have to add it to the other topical treatment of your retinoids and your benzoyl peroxide. When the acne is still severe and all treatment are failing, use your oral tretinoid, which is what? Your isotretinoin. You discontinue others and you give the patient isotretinoin. So, initially you start with topical retinoid. You add your which is erythromycin. If that doesn't work, use your oral antibiotics, which is your tetracycline. If that doesn't work, discontinue everything and start your oral retinoid, not topical retinoid, oral retinoid, which is what? Isotretinoid. But before you start your isotretinoid, make sure that the patient is not pregnant, and you have to monitor your lipid and your liver function test, because it can cause hyperlipidemia and it can cause derangement of liver enzymes. So isotretinoid, in addition to those things, can also cause, is also teratogenic. So make sure you rule out pregnancy and you place the patient on 2 different forms of contraception, e.g. barrier and hormonal, and you measure for pregnancy tests serially. Do we understand this, or there's some level of confusion? Hello, we are not saying anything. No?
You understood?
Okay. Now, one day after undergoing an open colectomy, a 65-year-old man with colon cancer experiences shivers. The procedure was originally scheduled to be done laparoscopically, but was converted because of persistent bleeding. Surgery was uneventful. 5 years ago, he underwent renal transplantation because of cystic disease and has been taking PRED since then. He has a history of allergy to sulfonamide. He appears acutely ill. His temperature is 39. The pulse is elevated. Respiration is 23. Blood pressure is 90. Abdominal examination shows a midline incision extending from the cervicsternum to the pubic symphysis. There's a 5 centimeter area of purplish discoloration at the margin of the incision in the lower abdomen. Palpation of the abdomen produces severe pain and crackling sounds ahead. Lab value shows this. What is the next step in the management? Anybody?
This sounds like necrotizing fasciitis.
This is necrotizing fasciitis.
Because of the crackling sounds that I heard.
The cracking sound, look at the color, purplish discoloration.
Discoloration.
This person had that surgery. When they palpated the abdomen, there was severe pain.
Mm-hmm.
And they heard the crackling sounds. So this is necrotizing fasciitis.
A surgical emergency.
Surgical emergency. What do you want to do?
Exploration with debris more.
Exactly. A 17-year-old girl comes to the physician because of 3-year history of acne on her face and chest. There's no itching or she's concerned about the possibility of facial scarring and has never sought treatment. She has no history of serious illness, takes some medication, BMI is okay, the vital signs are within normal limits. Examination shows several open comedones on the face and chest. Which of the following is the most appropriate initial treatment? Anybody?
Topical retinoids.
Dr. Antonia, look at the option. Look at the option.
You said several open comedons on the face. And
which one are you picking the option? Is it A, B, C, or D?
You start with topical. I know you start with topical.
So which one are you picking?
I'll go for topical benzoyl peroxide before antibiotics.
Yeah. So you said topical retinoid initially, and there's no retinoid here. There's no topical retinoid.
Okay, no, I was going with what you thought, Sha, but now looking at the.
Okay, I get what you are saying.
The stepwise approach.
Okay, yeah. So the closest thing that you can start with, since there's no topical retinoid here, is your
benzoyl peroxide.
Exactly. So that's correct. That's correct. So it depends on what you have. Yeah, good job. So these are the examples of the retinoid, the topical retinoid: tazarotene, adapalene, first, and you can also use your salicylic acid. They are all keratolytics. Okay, then moving on to the polynodal cyst. So this is just abscess in the sacrococcygeal region, just the superior part of the intergluteal cleft of the bottom. It's usually due to a foreign body reaction to excessive hair growth in that area. So it's very common in people that have that are obese, that have too much hair growth here. People that are seated on a position for a long time, so they have the hair irritating that area, inflammation, formation of cysts and abscess. So an abscess can develop at that area, and it can be tender, fluctuant, and warm, I share with cellulitis generally. And sometimes some of them can start having fistulas, just like this guy now. This guy is already having fistula. I can see like open drainage here. So they can become cellulitic, and sometimes they can also evolve into developing fistulas. So if it's just an abscess I have, what you do is to incise and drain the abscess and sterile pack it for some days. So incise and drain the abscess and apply sterile packing. If there's sinus tract or fistula, excise it if it's present, and you encourage the patient to maintain good hygiene, to shave the hairs around the sacrococcygeal skin to prevent recurrence. But if there's feature of cellulitis, then you need to give antibiotics. And you make sure that the antibiotics you are going to be selecting in the option is the one that is going to cover for both anaerobic and aerobic. So going over again, they usually have abscess. Sometimes it can be complicated with cellulitis, surrounding area of cellulitis, or fistula. If it's only abscess, drain, incise, drain, and pack so that you can take in the collection. If there is cellulitis, give antibiotics after you have drained, covering aerobic and anaerobic. If there's fistula or sinus tract that is discharging, excise it. Excises. So that's the management, for polynodal cyst. We also need to know leprosy. This is an infection caused by Mycobacterium leprae that affects the skin and the peripheral nerves. It is caused by this organism. It is acid fast. Very important to remember that. And it can cause granuloma. Very, very important to remember that. Very, very important. Now, how do they present? You are going to be seeing multiple hypopigmented, hypoaesthetic skin lesions. They destroy the skin, they destroy the nerves. So, hypopigmented, hypoaesthetic skin lesions with nerve thickenings. And of course, there could be palsy of different peripheral nerves. They can have foot drop, they can have medial nerve palsy, and the other types. We have two extremes of leprosy. Are you dealing with the tuberculous form or the lepromatous form? The tuberculous form or the lepromatous form? For the tuberculous form, it means that this person's immune system, the cell-mediated immunity, the T cells of this individual is strong. and they can curve the leprosy within the granulomas, and the leprosy is not able to proliferate and cause injury to the skin or the nerve. So you have one or two localized hypopigmented plaques. But for the lepromatous, the leprosy are playing. They are just moving up and down, causing serious injury. So you see many plaques, you see many nodules. You look at the face; they have lionin face, like they look like a lion, or like they have mycosis fungoides, which we are going to see very soon. The face is going to be disfigured, and they can have hair loss that you call maldarosis. It can even perforate the septum of the nose. It can have septal. All these things are just destructive lesions from the granuloma. How do you make your diagnosis? You can obtain a skin scraping of the lesions, or you do a punch biopsy, and the next thing you want to do is to do your senescent staining. And what are you going to see, I wanted to say Dr. Zuliat. Dr. Antonia, what are you going to see? Dr. Miriam, are you guys there?
And what test?
Are you guys not hearing me?
We heard you. I didn't hear very well. It says skin scrape.
So when you do your skin scraping and you obtain your punch biopsy and you apply your senescent stain, what are you going to see? Senescent stain. Does it ring a bell? Senescent stain.
Mycobacterial.
Yeah. So you are going to see acid-fast organism. Acid-fast organisms, right? So you can also culture. You can also culture your lesions. If you do your lepromine test is just to help you separate between the tubercular form and the lepromatous form. Lepromine test means that you are injecting this antigen of this leprosy into the skin, and you are watching for induration. If it's more than 5 millimeters, it is positive. If it's less than that, it is not positive. What type of hypersensitivity would that be? Anybody?
Type 2.
Like you ask yourself, is this antibody or T-cell mediated?
No, it's type 4.
Type 4 hypersensitivity. So, if it's more than 5 millimeter in duration, which of the extreme are we going to pick? Is it tuberculoid or lepromatous?
You said if it's more than 5?
Yeah, if it's more than 5.
Lepromatous.
Why? Why are you going to pick lepromatous?
Because in lepromatous, you have a fewer T-cell response.
Okay.
It's more of a humoral immune response than
T-cell dependent. It's more of type 2. It's not immoral.
Yeah.
It's more of type 2, not type 1 HEPA cells, So
yeah.
Okay. So, but do you think the induration will be more? Like, if the immune response is not vigorous, you are not going to have much induration. So it's going to be smaller. But if the immune response is vigorous, because you have many T cells to respond to the antigen, so it's going to be wider. So which one do you think is going to have greater than 5 now? From the tuberculoid. Exactly. That's the idea. Don't forget that. So how do you treat tuberculoid leprosy? Just give your dapsone or your rifampin. Don't forget, you also use dapsone in which condition that we have treated today. Hello?
Forgotten.
Where do we use dapsone? I mentioned it today.
Yes, you did.
Eh?
Yes, you did.
Yes, so that stuff is related to celiac disease.
Yes, herpetiform, dermatitis herpetiformis.
Dermatitis herpetiformis, dapsone. So, dapsone and rifampin, you use it in the tubercular leprosy. Clovaxamine will be added if it's lepromatous. Me, honestly, I know that dermatology is very boring. Dermatology is not as easy to explain as maybe as any cardio, endocrine. All these ones, they have mechanism that you can share with people. But dermatology is just all about facts. So I know that it can be cumbersome. to take in all those things. So that's dermatology for us, unfortunately. So dapsone and rifampin for tuberculosis, you add clovaxamine if you are treating the lepromatous or the multibacillary leprosy. Okay. Fungal infections. We are starting with the tinea versicolor. I think I have a question here. Let me see. A 46-year-old obese man comes to the emergency room because of paresthesias in his feet and hypopigmented skin lesions on his knee that was first noticed 6 weeks ago. He has also had fever, fatigue, and malaise for the last week. He has a history of chronic autoimmune thyroiditis for which he takes levothyroxine. He immigrated from Indonesia 3 years ago to join his family in the US. The temperature is 38.7. The BP is normal. Physical examination shows well-defined hypopigmented skin lesion approximately 3 cm in diameter over the anterior aspect of the knee. The area has no hair growth, hairless skin lesion. They are dry and is diaphoretic. There's diminished sensation to light touch and pink prick in the skin lesion when compared to the surrounding skin. There's reduced light touch sensation in the big toes bilaterally. A foot thickness skin biopsy confirms the diagnosis. Which of the following is the most appropriate initial pharmacotherapy?
Oral rifampicin and dapsone.
Fantastic. Okay, this is leprosy. We can see the hypoesthesia. We can see the loss of sensation. We can see the hypopigmented skin lesions. So that's basically what we have here. So, tinea versicolor is caused by Malassezia. It is a yeast that is part of the normal skin flora. It's very common in sweaty conditions. When the temperature is hot, high humidity, and you are sweating, Malassezia can become pathogenic, even though it's a normal skin flora. If the skin is it's pathogenic.
Yes, I just lost out. I can't hear you anymore. Yeah, I can see, but your volume is so low. I'm not seeing anything again. Yeah, it's very low. I don't know if it's the same with others though. I don't know. I can hear you.
It's very low.
Better now. Better now. Better now. Oh, is
Hello?
yeah, better now.
Okay.
We lost you. I didn't hear anything. Yeah.
Yeah. So, Malassezia, sweaty condition, high humidity, all of them, they can make the infection pathogenic. So Cushing syndrome and immunosuppression are also risk factors. So we don't really need to be cramming all these risk factors. They will not ask. It's very unlikely. But you have to be able to identify the lesions. So we are going to be seeing an individual having pruritic. They can have sometimes pruritic scaly patches of different colors. So the clinchers here that you need to pay attention to is scaliness. Once you have scaly lesion, fungal infection too should be at the back of your mind. So scaly lesions that are of different colors, you are seeing hyperpigmented, you are seeing hypopigmented, usually at the chest or at the back. Think about tinea versicolor. Most of the time, they will also show us the image. So by the time you see it, you will know that this is tinea versicolor. In Yoruba land, we call this ifo. So it's very easy for people, in Yoruba stuff to be familiar with that, ifo. That's what they say. So now, if you, of course, you are going to see patches that are hypopigmented due to melanin impairment in melanin production, or hyperpigmented lesion due to inflammation to the organism. So if you do your KOH preparation, so that's where, that's one information they might give us in the question stem, that when they did the KOH mounting, they were able to see spaghetti and meatball pattern of the hyphae and the spores. So what they are talking about is the spaghetti, which is like the hyphae, the stick, and the meatball are the spores born on the hyphae. So once you see spaghetti and meatball appearance on the KOH, you know that is likely to be your tinea versicolor. How do you treat? Just like we treat, which condition do we treat with topical ketoconazole and selenium sulfide? Anybody?
Seborrheic dermatitis.
Omo, I think my speaker is misbehaving. Hello, please.
Hello, seborrheic dermatitis.
Yeah. Dr. Antonia, you said seborrheic dermatitis, right?
Yeah.
Okay. So yeah, seborrheic dermatitis is also being treated by topical ketoconazole, selenium sulfide, or your zinc parathione, because all of them, they are caused by the same organism. That's the Malassezia 44. So don't forget the spaghetti and the meatball appearance. Candidiasis is another one that we need to know, and candidiasis can cause different infection. It can affect the oral mucosa, the esophagus, the skin itself, the vaginal mucosa, and some other parts. So, and what is peculiar to Candida is that it's very common in immunocompromised people, or people with some certain drugs like steroids, and they tend to develop erythematous papules and plaques, usually within the intratriginous areas or the most areas of the body, like the groin, skin fold, the axilla, the vagina, or beneath the breast. In infants, they tend to have the oral thrush. If you see candidiasis in an adult, you should suspect an immunocompromised state. So some of them can have history of use of broad spectrum antibiotics, steroid use, DM, on immunocompromised state. So DM, immunocompromised state, use of antibiotic or steroids can predispose to developing candidiasis. And for oropharyngeal, we are very familiar with that. We see the whitish lesions within the tongue, the buccal mucosal, and it can be scraped off easily without bleeding, as opposed to oral hairy leukoplakia from Epstein-Barr virus. Candidiasis of the skin. We don't talk much about this, but we need to be able to identify it because it's important. It's normally tested. So, and what we are going to be seeing is erythematous papules or plaque with satellite lesion. This satellite lesion is what you are looking for. And they are just papules that are isolated from the grooved lesion. So if you look at this lesion now, you can see that some grooved lesions here, but you can see some isolations, like the ones that are here, this ones, this ones, this ones, this ones, this ones, this ones. Those are satellite lesions. Once you see a rash distribution like this with the satellite lesion, you are dealing with candidiasis. In the infant, it is part of the diaper rash causes, and it does not spare the inguinal fold. If it's irritant diaper dermatitis, it will spare the inguinal fold. But if you see the question saying that you have erythematous plaques, papules with smaller lesions, satellite lesions involving inguinal fold, you know that is candidiasis they are talking about. So you must give topical agents like nystatin. That's what you give. Topical nystatin, patient is going to be fine. So vulvovaginal candidiasis involve the vagina. They have signs similar to UTIs. Burning, dysuria pruritus, and whitish cottage copious discharge. It's going to be whitish, copious, burning sensation, pruritic. Vulvovaginal candidiasis, just IM fluconazole, 1 dose is okay. Patient is going to be fine. Candidal esophagitis, you see pseudomembranes, in the esophagus, and they are going to have odynophagia. It's very common in people with HATE, people with hematologic malignancy. Very common. So how do you make your diagnosis? Just do your KOH mounting and you look for your pseudo-hyphae. That's what you need. Once you see pseudo-hyphae, candida is the answer. Your most accurate test is your blood culture. You might need to do endoscopy if there's esophageal involvement. Don't bother yourself by the other ones. How do you treat? If you are dealing with oral candidiasis, just give your oral fluconazole tablet, or you can do your nystatin swish and swallow, or your clotrimazole troches, or your miconazole oral. If it's esophageal, you need something more systemic and more powerful than fluconazole and miconazole and clotrimazole. So you give your fluconazole, oral fluconazole, or you use your echinocandins like your capsofungins or your amphotericin B. If the individual is having superficial skin infection, just apply your topical antifungal, any one of them. Topical, anyone, just apply. Topical antifungal is what you are going to be looking for in the question, and keep the skin clean and dry. If the patient has vulvovaginal candidiasis, topical antifungal, a single dose of oral fluconazole. So you can apply topical antifungal, or you give a single dose of oral fluconazole, 150 milligram. Patient is okay. Diaper rash, just like I said, topical nystatin, the patient is okay. Topical nystatin is okay. So the only one that needs more systemic stuff is esophageal. When you give your systemic fluconazole, echinocandin, or amphotericin B. For oral, give your oral fluconazole, your nystatin, swish and swallow, or your clotrimazole drug. Your dermatophyte infections. So I have to mention it here that your tinea pityriasis, your pityriasis versicolor is not a tinea infection. Your pityriasis versicolor is not a dermatophytic infection. What causes it is malassezia. Malassezia is not a dermatophyte. So they can paint a situation of someone that has tinea versicolor. Sorry, I said tinea. Pityriasis versicolor, and they will say that we should identify the organism, and they can say that it's caused by a dermatophyte, blah 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 blah. That is not correct. So tinea versicolor, I don't know why I'm calling it pityriasis versicolor. Tinea versicolor, it is not a tinea infection. So it is actually caused by malassezia for and it's not a dermatophyte. So don't make that mistake, please. Pay attention to that. Very important stuff. So the proper dermatophytes are the ones that infect the skin, the nails, and the hair because they contain keratin. And the implicating organisms include your trichophyton, which is the commonest. In fact, that's one you'll be seeing more in the options. Trichophyton, Microsporum, Epidemophyton. So the three of them, they are all dermatophytes. So if you are not seeing Trichophyton, pick Microsporum or pick Epidemophyton. So the risk includes immunosuppression stuff, DM, immunosuppressed state, chronic maceration of skin by water, especially sweat from athletes, and reduced peripheral circulation. Now, what I must emphasize is the fact that, excuse me, 1 second. Okay, so what I must emphasize, please, can we still hear me well?
Yes.
So,
Yes.
what I must emphasize is that there's a high risk of auto-inoculation with your dermatophyte infection. So, you just see that the stuff keep coming without any predisposing stuff. It is due to auto-inoculation because there's an area in the body where there's an hidden dermatophyte infection that is affecting other areas. I will show you why. So this is a common stuff you see in your question. So you have to rule out potential lesion at other sites once you make your diagnosis of your tinea infection. So the class or the types varies based on the region affected. So the first is the tinea corporis. So your Trichophyton, your Microsporum, your Epidemophyton can cause tinea corporis, which you call ringworm, but it does not affect the head. The ringworm I used to know when I'm growing is the one that affects the head, but it does not affect the head. That is tinea cavities, we call ringworm. Tinea corporis affect the body, and we are going to be seeing scaly, puritic eruptions with irregular border, and there's a central clearing. That's important. The central clearing is important. The scaliness is important. And the fact that the lesions are well demarcated, they look circular. So it's very common in people that are diabetic, people that are immunosuppressed, people that are exposed to a lot of water bodies or pets, having the fungus. This is it. We can see the well demarcated lesion with a central clearing. So when it occurs in the skin, in the body, like the trunk area where you have hairless skin, that's what you call tinea corporis. The next is the tinea pedis and the tinea manum, which occurs in the interdigital space of the toes, as athlete foot, or it can occur just beside the soles, which is called the moccasin distribution, or it can also present as vesicles, which you call the vesiculobulous type. So moccasin is just when you have the scaling thickened lesion within the side of the sole, and when you have the erosion of the erythema in between the digits, you call that the athlete foot. All of them, they are all variants of tinea pedis. But people with tinea pedis, you might want to check their hands, because this lesion is very puritic. We are going to be seeing puritic scaly lesions, and the individual is going to be scratching that lesion with the hand, and there's a tendency that there's going to be inoculation to the hand, causing tinea manum. So in addition, involvement of one hand is typical in the one hand 2 feet syndrome. So if you see somebody having lesion in one toe, check the other toe, it will be there. Check the hand, it will be there, because they will have been scratching, and in the process they will have distributed it to the other part of the body, and those ones at the leg can be the side of the auto inoculation. So that's why if you make diagnosis of tinea manum, check the leg to see if there's no lesion there, because if the lesion is in the leg and you don't identify it, there's going to be auto inoculation. If we don't know anything, we should know that tinea infection is scaly, it is puritic, and there is high risk for auto inoculation. We are okay. So this is the tinea pedis. The next one is the tinea cruris, which you call the jock itch, and this is erythematous scaly lesion involving the groin. It does not affect the scrotum, and you are not going to see any central clearing. So that's how it is distinguished from tinea corporis. The next is the tinea capitis. You are going to be seeing alopecia, halos with surrounding scaly lesions. You can see the scaliness. That is what we call lakpa in Yoruba land. And when we were growing up, we used to say ringworm. That we used to believe that it got in from sharing clippers. Well, I don't know. The individual is going to be having hair loss and scaliness. Sometimes there could be an inflammatory buggy mass that you call a carrion. It will look as if they are like wounds in the head. If you see some severe ones, you go shock. You know, it will look as if you are seeing like injury that is healing with granulation tissue. That's what you call the carrion inflammatory buggy mass. That is tinea capitis. The treatment for tinea capitis, tinea unguum, differs from the other ones because you need a high degree of penetration. So the treatment differs. So let's proceed. The last is the tinea unguum, which is onychomycosis. Fungal infection causing brittle, weak nails that can easily break out and they have a discolored appearance. Now, if you do a KOH mounting of your lesion, you are going to see the hyphae. The most accurate test, just like in Candida, is fungal culture. You can also do wood lamp examination, and it's going to show a blue-green fluorescence, for Microsporum species. Don't forget that. How do you treat? If it's outside tinea unguum and capitis, if it's outside the hair follicles of the head, the nails, you can give your topical antifungal. Anyone, topical miconazole, topical terbinafine. But if it involves the nails, tinea unguum, or the head, tinea capitis, you need to penetrate the hair follicles in the head and penetrate the nail. Give oral agent like oral grisofluvin and oral terbinafine. You don't want to forget. You forget this. Oral grisofluvin or oral terbinafine. If it's other ones, topical antifungal. If the infection is widespread, you can also escalate to your oral grisofluvin or your oral terbinafine, or if it's unresponsive, to your topicals. Also consider the oral in people that are immunosuppressed. Moving on. Okay, I think I have a question here. So, a 9-year-old boy is brought in to the physician by his mother because of an itchy rash on the right side of his scalp and progressive hair loss for 1 month. He has no history of serious illness. His younger sibling was treated for pediculosis capitis 3 months ago. The boy attends elementary school but has not been going for the past 1 week because he's too embarrassed by the rash. He appears anxious. The photograph of the scalp is shown. Occipital lymphadenopathy is present. The remainder of the examination shows no abnormality. What is the most appropriate treatment for this patient? Anybody?
Patient has tinea capitis.
Tinea capitis?
Mhm.
What are we giving?
So we'll give oral medication,
Which is?
oral grisofluvin.
Good job. When do we use topical calcipoterine? Let me see if you can remember.
Topical what?
Calcipoterine. The last option. This.
Calciprotein. That's a topical vitamin D analog.
Fantastic job, Dr. Antonia.
So psoriasis.
Good job. That's good. Psoriasis. So your vitamin A analogs, your vitamin D analogs, or your topical steroids. If it is severe and you are seeing psoriatic arthritis, you use your methotrexate, your TNF antagonist. Very easy. Sporotrichosis. We already know this. People that garden, Gardener's disease, when they come in contact with the thorn containing the fungus, the spore can inoculate into that injury, and the individual is going to be having nodular lesions which follow the lines of lymphatic drainage. Lymphadenopathy is usually absent, and they could have discharge from the nodules. You treat with itraconazole. If it's disseminated to the brain or to the lungs, you give IV amphotericin. I'm sorry I don't have an image for us. You can check that up. And if we do our KOH mounting, we can see septate hyphae with rosette-like spores. Moving on to the parasitic infections. Talk about the lice. And we have 3 types: the head lice, the body lice, and the pubic lice. The head lice, the body lice, and the pubic lice. So it's very common in people that share fomites with people that have this lice in them, or people that share comb with them, or hair accessories. The lice secretes local toxin that could cause pruritus, so it's very pruritic. It is not only scabies that is pruritic. The lice is pruritic. Bedbug is also pruritic a little. There's usually a classroom breakout. You just see that everybody for primary 5 gets head lice. They're always scratching their head on the assembly ground. Head lice. Because of the severe pruritus, they are scratching, and there could be high tendency for secondary bacterial infection from there. Impetigo, for example. Although impetigo is not very common in the head, but any other bacterial infection can come in. Most of the time, the body lice, they appear as crabs. If you check the image online, you are going to see them. They look like crab. In fact, you can see them, with your eyes, naked eyes. I've never seen one before, but they can appear, through our naked eye. They contain anticoagulant in their saliva, and they can be ecchymotic. So you see blood is not clotting because of the secretion from their saliva, and you see bleeding, ecchymosis. So you can see the lice, or you can see the nit, which is the egg on the hairs or the clothes of individuals with this stuff. Or you can use your microscope to also observe for the lice, the eggs, or their droppings. So now, treatment varies. If it's affecting the head, the pubic area, you treat with your parenterin. This is what I want you to remember: parenterin or permethrin. You can know everything if you want to, benzene alcohol, or you can do mechanical remover. But I can assure you, you are going to see more of your permethrin and your parenterin. For pubic lice, you do the same. You are just going to see that the individual is always scratching the pubic area, always scratching it. And they can show us a picture of the infection, or they can just, most of the time, if they want to test it, is either they show us a picture, or lice is only going to be the option. That will be there, that has a high tendency of causing the pubic pruritus. So they won't bring you anything more controversial. And again, if you even see someone that's having pubic, itchiness, think more of pubic lice. Scabies, they not usually go to the pubic area like that. So if it's the body lice, just wash the clothes, wash the body, beddings, and if it doesn't respond, you can now apply your topical permethrin. But for your head, pubic lice, give medications. Very important. For scabies, Sarcoptes scabies is a mite involved, and it burrows into the epidermis of the skin. There is increased pruritus, and this is due to allergen to the mite or its products. Secondary bacterial infection can also come in from the excoriation. They spread by fomites, close contacts. The pruritus is very severe, especially at night. So they can mention this in the question stem: severe pruritus at night, but it's not pathognomic, And the pruritus can also worsen after taking hot shower. Which hematologic condition comes to mind when a patient has pruritus after hot showers? Anybody?
Polycythemia rara.
Good job, Dr. Antonia. So, erythematous papules with linear tracts. That's what we are going to be seeing. And there are some conspicuous areas like the interdigital cleft of the hands, the anterior aspect of the wrist, the waistline, the axilla. Those are the common areas where we see the mite. So it can affect the genitals too, though. I remembered after I said it, but I know that they would put something there to actually separate those guys. There's no way they put something to separate them, so you know what you are dealing with. They can tell us that, okay, it's in addition to affecting the genitals, it's also affecting the interdigital space of the finger. So you won't be thinking of body lice. You're thinking more of scabies. And there's something called crusted scabies. That means that in addition to all these lesions, we're also seeing crusting, scaliness. Think about HIV. Widespread seborrheic dermatitis, HIV. Widespread psoriasis, HIV. Giant widespread molluscum contagiosum, HIV. Crusted scabies, HIV. With HIV, the wahala no dey finish. Kaposi sarcoma, HIV. It's a bothersome problem. History of pruritus can be common in the family members, and it is suggestive. That's scabies for you. So that's why if you are treating them, you have to also treat the family members. Make sure they iron their clothes, they dry, they wash it, they wash themselves, and they apply the anti-scabies agents. How do you treat scabies? 5% permethrin, just like lice. Permethrin or parentoids. You can use your permethrin or your parentoids, or benzene alcohol or mechanical remover. But here, you use your 5% permethrin from neck to down. If it's younger patient, head to toe, you treat it twice, but you have to separate by 1 week so that you allow for the incubation period and for the eggs to hatch, so that you can catch them by the second week. So you start the washing now, you wait for 1 week, you finish it the following week. Treat the close contact as well. If you are not using 5% permethrin, you can use oral ivermectin. For crusted scabies, just combine the two. That's it. Oral ivermectin with the topical permethrin. That's all. Don't forget to wash the beddings and the clothes. Bedbugs. Bedbugs usually cause painless erythematous papules in the skin due to the bite from the bedbug, which is a Cimex species. It is worse like at night, just like scabies. That's why I said it is not pathognomonic. In the morning, the lesions appear as a linear breakfast, lunch, and dinner pattern. What this means is that there is gapping in between the lesions. You take one now, breakfast, take one later, lunch, take one afterwards, dinner. So if you look at this lesion, you are going to see the breakfast, the lunch, and the dinner patterning. The image has refused to open. Probably I attach another. Oh my god. Let's just go and look at the image online.
Sorry, Dr. Babawane. So you said in treatment of scabies, you said the 5% penetrate from the neck down.
Yes.
For children or them for adults.
Yes.
But
Dr. Antonia, I'm listening.
Okay, I said from neck down.
Yes.
For
adults.
And
yes.
And okay.
Yes. For children. So this is it. This is what they are talking about. So you see this bite here. See another one here. See another one. So that's it. The morning, the lunch, the dinner. So that's the way they take their bites. And it's painless. It is when you wake up that you now be seeing it. What's waiting bite me for here? That is bed bug for you. So you have to, apply insecticide to the beddings and the furniture. And you can also treat the pruritus with topical steroids and antihistamine. But don't forget, you have to use insecticide to eradicate the infestation. And the lesions will have an hemorrhagic punctum, very similar to molluscum, but the central punctum is going to be hemorrhagic. So once you see this being described in the question stem, know that this is bedbug they are talking about. Painless hemorrhagic punctum. Bedbug. Cutaneous liver migrant. Do you have any question here? No, I don't. Cutaneous liver migrant. We are just going to see erythematous serpentine migratory rash. We know that snake-like rash in the legs of somebody that doesn't wear shoe and is moving around up and down. The lesion will be pruritic and it will be maculopapular. So most of the time they are caused by the hookworm, which is a Ancyclostoma, or the Necator americanus. To further raise our suspicion, in the question stem, we might see feature of iron deficiency anemia. From the labs, we can see features of gastrointestinal complaints, abdominal pain, nausea, vomiting, and sometimes there could be the Loeffler phenomenon or syndrome, in which you have this larva transporting to the lungs, causing chest pain, coughing, difficulty in breathing, and peripheral eosinophilia. Treat with ivermectin or diabendazole. Patient is going to be alright. So let's look at this.
Your volume is too low.
Dr. Antonia, is it better now?
Yes, yes.
A previously healthy 26-year-old man comes to the physician because of 1 week history of pruritic rash. Initially, he noticed a set of small red bumps in iliac pattern around his arm. Although this started to recede after a few days, he found another set of similar lesions in clusters on the back yesterday. The itching is worse at night. The roommates have also developed similar rashes since moving to their new apartment in San Francisco 2 weeks ago. There are no pets. Temperature is normal. Pulse is normal. BP is normal. Photograph of the rash is shown. Now, I don't even have this photograph. The remainder of the physical examination shows no abnormality. Which of the following is the most appropriate next step in management? Let me see if I have the image hidden somewhere. Oh my god. Unfortunately, in the course of trying to add all these things, I know that this is going to happen because it can be difficult at times. But I think this is bed bug. It is this is the image I was trying to add to this place, but I think I added because I labeled it bed bug, so I think I added something else. Let's go to the next one. So if it's bed bug, you have to ask the patient to consult a pest control service so that they can use the insecticide. A 4-year-old boy is brought to the physician by his mother because of rash on his fingers and feet. The rash is intensely pruritic, especially at night, no had fever, no headache, no diarrhea. The mother has a history of eczema. The child was due for an appointment later in the week to follow up on any potentially missing vaccination. His temperature is 37. Examination shows maculopapular rash with linear tracks affecting the interdigital space of fingers and toes. Examination shows no abnormality. Which of the following is the most effective intervention? Yeah. So what's our answer? It's straightforward.
It's scabies.
Scabies.
Yes.
So how do we treat?
Use 5% permethrin.
5% permethrin. Good job. Decubitus ulcer. Very easy. It's due to ischemic necrosis from pressure areas, bony prominences. The prolonged pressure compromises the blood flow to the skin, causing ischemic necrosis. What you need to do is to stage that decubitus ulcer. By the same time you see decubitus ulcer, you should be very happy. The next thing you want to do is to stage it. Is it stage 1, stage 2, stage 3, stage 4, or unstageable? What is stage 1? You are just going to be seeing non-blanchable erythematous skin. That's all. In stage 2, there is an ulcer that is pink, but you cannot see the subcutaneous tissue. Once you are seeing pink ulcer, shallow, I cannot see the subcute, stage 2. Once it's erythematous, no ulcer, non-blanchable, stage 1. Once there's an ulcer and I can see the subcute, stage 3. Once I am seeing beyond the subcute and I'm seeing muscle, I'm seeing tendon, I'm seeing bone, stage 4. Once there is debris, necrotic tissue in that ulcer and I can't even see the base, that is unstageable. Very easy. Do we get it? Hello everyone, no response. Are we still there?
Can you go again? He said second stage you see subcutaneous tissues.
No.
Also, okay.
In second stage there's an ulcer, but you are not seeing the subcute.
Subcutaneous tissue. Okay.
In stage 3, you are seeing the subcute. In stage 4, it is past the subcute. It's getting to the tendon, the muscle, the bone. Do you get it, Dr. Antonia? In stage 5, in unstageable, there's covering by Hisca or necrotic tissue, and you cannot see anything. You cannot see the base. So you don't know if it's stage 2, stage 3, so you call it unstageable. Is it clear now?
Yes.
Now, what are the stuff predisposing factors? Bedridden patient. They lie in a spot for too long. The area of the bony prominence is compromising the blood flow to the skin, particularly the sacrum, the heels, the occiput. It's very common in people that stay in the ICU and they are not getting regular 2-hour turning, or people that are not mobile and they are sitting on a chair for a long time, or people that have diabetes and they don't have cutaneous sensation and they are applying pressure on a particular area for too long but they cannot feel the pain. High risk. Or anybody that is having incontinence and you're having too much stool, urine macerating the skin. This can predispose to the dermatophyte. It can also predispose to what? To pressure ulcers. Now, you can do a biopsy for a non-healing ulcer to rule out marginal ulcer, which you call cutaneous squamous cell carcinoma of the skin, or you can rule out a chronic infection like a Buruli ulcer. You can also rule out pyoderma gangrenosum. What did I say we are going to see on biopsy for pyoderma gangrenosum? Anybody? Pyoderma gangrenosum. What are the predisposing factors?
Pathology if you do biopsy.
Hello? Dr. Antonia, what did you say?
Yeah, pathology. You see pathology if you do biopsy.
No. I made a mistake. So I said you elicit pathology when you do debridement. So you want to avoid debridement, right? But I said if you do a biopsy, you are going to see a particular infiltrate.
Neutrophil.
Neutrophilic infiltrate. Neutrophilic infiltrate. So what are the predisposing factors for pyoderma gangrenosum?
Immunocompromise. Immunocompromise.
No.
DM.
No. 3 things.
Okay, rheumatoid arthritis.
Rheumatoid arthritis.
I can't remember.
Well, you tried. It's part of the extraintestinal manifestation of IBD. So, IBD, rheumatoid arthritis, malignancy. You have to rule them out. You can do a bone biopsy to diagnose osteomyelitis if there's bone exposure. Okay, yeah. All these are not still what we need. This is where they are going to wait for us. You have to know that prevention is key. Change that patient time to time, every 2 hourly. You can use earbuds, water beds to redistribute the pressure, promote good nutrition to facilitate wound healing. If an ulcer develops, what are you going to do? Stage the ulcer. With stage 1 and 2, apply your hydrocolloid dressing. Stage 1 and 2. Stage 1 means there is erythema, non-blanchable. Stage 2 means there's an ulcer, shallow ulcer, pink, no granulation tissue, no debris, but I cannot see the subcutaneous layer. Stage 2. Stage 3, I can see the subcutaneous layer. Stage 4, it has gotten to the tendon, the muscle, or the bone. If it's involving stage 1 and 2, apply your hydrocolloid dressing. Your hydrocolloid dressing can absorb moisture from the ulcer and they exert auto debridement activity, autolytic debridement. And excuse me. So, and for your stage 3 and 4, you have to do a surgical debridement. Very high stuff. Once you see the pressure ulcer, the next thing is for you to stage to know what to do. If it's low grade, just do your routine wound care, apply your hydrocolloid dressing. If it's stage 3 and 4, you have to debride that wound. Debride. Stage 3, stage 4, stage 5. On stage 3, stage 4, unstageable, debride. Gangrene, necrosis of the body tissue. 3 types: wet, dry, gas. We have talked about gas because gas is when we are talking about which infection. Anybody remembers?
Clostridium papyritis.
Yeah. So what skin lesion were we talking about then?
Necrotizing.
Necrotizing enterocollar and necrotizing fasciitis. The wet gangrene, there's ischemia. Think about ischemia for many causes, usually atherosclerosis of the leg. Insufficient blood flow. When there is ischemia, what happens? You cannot feel pulse. When there is ischemia, blood will not flow. There will be pallor. Blood will not deliver warmth. It will be cold. Ischemic pain is going to occur. There will be dull, aching pain. All these are features of dry gangrene. They're usually background atherosclerosis of the peripheral vessels. As necrosis setting, it's going to appear dark, it's to be dry, and you can get history of diabetes causing peripheral arterial disease or hypertension, causing the vasculopathy, or smoking. For wet usually occur from background dry gangrene. Infection starts setting in, it appears edematous, blistered with pus. You know that it's already wet. We know gas gangrene, we don't need to talk about it. Surgical debridement is the mainstay of treatment. You can amputate. So if the gangrene is widespread, you need to amputate. Then you can now give antibiotics afterwards, after your surgery. You can apply hyperbaric oxygen for Clostridium paphyringeus after debridement to help with the treatment because Clostridium paphyringeus is anaerobic. So give oxygen to make it difficult for it to survive. Moving on to stasis dermatitis. Stasis dermatitis, I think we should take a break. Let us take a break. And we stopped at we're just about to continue. We are just about to continue with stasis dermatitis, and this is just skin ulcer that develop at the gator area of the ankle, which is just the part that is just superior to the medial malleolus. So once you have that description in your question, think about stasis dermatitis. Think about a venous ulcer, rather. So stasis dermatitis is just a lower extremity dermatitis due to stasis, and when there's stasis, there is venous hypertension. When there's venous hypertension, blood moves from the deep to the superficial venous system. So ideally, blood should be going from the superficial into the deep. But once you have stasis and there's pooling of blood in the deep, you are going to have a compromise of the valvular mechanisms, and you have blood flow in the reverse direction back to the superficial venous system with opening of new collaterals. So that's why you have the telangiectasias. Venous hypertension carries out from venous valve incompetence, from maybe smoking or flow obstruction. Probably somebody has DVT that is impeding blood flow back to the heart, or somebody has obesity and there's a lot of pressure, on the veins, or prolonged standing can also lead to stasis, impairing the venous drainage back into the heart. Or somebody's pregnant, they are not mobile, they are just sitting in one position for a long time, and it can also lead to impairment in venous drainage. So all these things, family history, DVT, pregnancy, obesity, smoking, all of them can be predisposed to venous hypertension, either from valvular incompetence or flow obstruction. The dermatitis usually involve the medial ankle, just like I've said, and when you have that stasis, you are going to start dilating the veins, opening up the capillaries, and you are going to be having extravasation of proteins, white blood cells into the tissues around that area. Just imagine that, you have a vein that is congested this way, and, the blood is pooling here, and from there, it gets to the capillaries, and there's extravasation into the tissues. So white blood cell moves out, the proteins move out, and the white blood cell starts secreting cytokines that leads to inflammation. So that's what brings about the exudative, because of the proteins, and the inflammation with eventual hyperpigmentation of that skin. With time, the skin will look like this, macerated. It looks as if it's eczematous, dry and the likes. And because of the inflammation, the skin will start breaking down, and you have the ulcer. So the dermatitis first before the ulcer. How do you prevent this? Encourage leg elevation so that you can increase venous return to the heart, increase the use of compression stockings so that you can pull blood back to the heart. You apply emollient, to reduce the dry skin, and also topical steroids can help with the healing. If you do your Doppler ultrasound, there's a tendency you can identify the incompetent valves, and you can also detect any DVT that might be present. So that's how you treat. Acanthosis nigricans. This is a condition in which you have thick hyperpigmented valvulate lesions within the intratriginous areas of the body, like the axilla, right? The neck, the genitals, the axilla. They become hyperkeratotic and hyperpigmented. And this is due to insulin resistance. So the insulins can exert a trophic effect on these areas. So anything that allows insulin to accumulate due to resistance, either from obesity or from any cause, can lead to acanthosis nigricans. You have two types: the benign one and the malignant one. So the malignant one is due to paraneoplastic manifestation of a GI adenocarcinoma, while the benign one is due to insulin resistance, either from DM, from obesity. PCOS can also cause obesity as well as Cushing disease. So all of them, they have obesity in common, and they can have the acanthosis nigricans. So how do you treat? No specific treatment for this. You rather treat the underlying cause, and also encourage weight loss and treat the underlying endocrinopathy. Moving on to lichen planus. Lichen planus is a self-limited recurrent chronic inflammatory disease of the skin, the oral mucosa, and the genitalia. You cannot forget the 6 P's of lichen. Very important stuff. They are flat-topped, they are purple in color, they are polygonal in shape, they are puritic, and they are papular and plaques. As opposed to psoriasis, you find lichen planus in the flexor areas of the body. They can be induced by drugs, thiazide, quinine, and beta blocker. I don't actually recommend I will cram this, but we must know that part of the dermatologic manifestation of HCV is lichen planus. Think of HCV, think of lichen planus. Think of your cryoglobulinemia. Think of anosclerotic purpura, from the cryoglobulinemia. Palpable arthralgia, blah blah blah. Think of porphyria cutaneosa. So HCV, think of cryoglobulinemia, think of porphyria cutaneosa, think of lichen planus. Very important. HCV. So for the oral, for the mucosal manifestation, they can have the lesions in the oral mucosa, which is going to exert burning pain. And what you are going to see in the question stem is the presence of lacy, white reticular marks or line. That's what you call the Wickham striae. So any mucosal involvement of lichen planus, you are going to see this lacy reticular white lines. It can also exert the Koebner phenomenon, just like psoriasis. The lesions also appear at site of trauma. And on histology, you are going to be seeing hypergranulosis. On histology for psoriasis, you see hyperkeratosis with parakeratosis. But here, you see hypergranulosis, prominent granular layer rather, with lymphocytic infiltration of the dermoepidermal junction. Very, very important. Very, very important. How do you treat? Just use your topical steroid, jejely. Apply your topical steroid to those areas. If it's more severe, use your systemic corticosteroid or use your phototherapy. Rosacea is something that is also... Okay, I think I have a question. Let's see. A 46-year-old man comes to the office because of lesions on his tongue and both inner cheeks that he first noticed 2 weeks ago. He said he has stopped drinking juice and eating spicy foods because they lead to a burning sensation on his tongue. He has chronic hepatitis C infection treated with ledipavir and sofosbuvir. He has smoked 1/2 pack of cigarettes daily for 16 years and drink 3 to 4 glasses of wine per week. Vitals are okay. Oral examination shows bilateral white lesions on the vocal mucosa that cannot be scraped off. A photograph of the lesion is shown. There are similar lesions and multiple red patch on the tongue. Which of the following is the most appropriate treatment for the patient condition? So, I guess this is a lesion. Yeah. So what do you think this is?
The Wickham's trial.
So this is a Wickham's trial. You can see the reticular white lines in the oral mucosa. So this is lichen planus. Don't forget, maybe when Dr. Abarinde treats the GI, we are going to see that the lichen planus can also predispose to malignancy. So, what are we picking for the treatment?
Steroids.
Steroids. That's it. Topical steroids. That's your treatment. And if it's widespread, systemic steroids. Rosacea is also something we need to know. This is a chronic disorder of pilosebaceous unit. The etiology is unclear. Some people believe it's due to vasomotor dysfunction. Some believe it's due to destruction from UV light exposure. Some believe it's due to exposure to infectious agents. We don't know. But we have different types. The erythematotelangiectaxic type. Erythematotelangiectaxic rosacea. This is one of the commonest. You just see erythema and telangiectasia. So central facial erythema, telangiectasia. That's what you are going to see. For the papulopustular, you see the papules and the pustule. For the phimosis, there's a connective tissue overgrowth of the nose. So the nose appears bulbous. It appears bulbous, big. And the last is the ocular, in which we are going to be having ocular lesion, blepharitis, conjunctivitis. You can have lid margin telangiectasia, conjunctival redness. You know, this guy now has a big nose, so this is likely to be the phimosis type. So the treatment varies depending on the type. So I just assume that the ocular and the papulopustular forms, they are caused by infection. So I think about infection. So we have to know that the provoking factors, and that includes when you consume hot drinks, spicy food, alcohol, or sun exposure. They just tell us that the patient develops abnormal flushing and erythema of the face after he takes alcohol, or he get exposed to sun, or he takes hot spicy food. You know that is rosacea that they are talking about immediately, and it's confined to the face most of the time. So how do you treat? Behavioral therapy. Avoid sunlight, avoid alcohol, maintain your skin, and use your emollient. For the erythematotelangiectasia, so just give your topical brimonidine. So this is a vasoconstrictive alpha 2 agonist. You vasoconstrict the blood vessel and you reduce the vasodilation, causing the erythema. You can also do laser therapy. For the papulopustular, give your topical, not oral, topical metronidazole. Treat it. The phimosis can also take laser like the erythematotelangiectasia, but the major stuff is to give oral isotretinoin, as if you are treating acne. Then is the ocular one. You give your antibiotic, which is what? Oral doxycycline. So that is how you treat rosacea. Moving on to pityriasis rosacea. So this is caused by human herpes virus type 7, which I said is like part of the roseola virus. And because of the fact that it is a virus, you are going to get a viral prodrome, which includes fever, headache, malaise, and afterwards you are going to develop a single rash that I call the Herat patch. It is an erythematous patch with a peripheral scale. So that's how the question is going to go. That the guy develops fever, headache, malaise, then afterwards he notices a single lesion somewhere, maybe in the trunk. That is erythematous, a patch with a peripheral collarate of scale. After this develops, then it starts developing crops of other papules and plaques along the skin lines, giving a Christmas tree appearance on the patient's back, usually on the back. Usually on the back. So I do not have a picture, but if pityriasis rosacea, so it's usually at the back. So you just see this at the person's back, like Christmas tree. You can see that it's coming outwards like a Christmas, outwards and downwards, preceded by the Herat patch. This with the prodromal symptoms. Think about pityriasis rosacea. Because it is viral, what do you want to do? Do nothing, right? So symptomatic treatment. You don't give antiviral or give anything, just symptomatic treatment. Um, Usually heals in 6 to 8 weeks without any treatment, but you can give supportive therapy like emollient and antihistamine. If it's pruritic, you can give your antihistamine and apply your emollient to minimize the lesions. Vitiligo. Vitiligo is something we are very familiar with. Just have autoimmune disruption of the melanocytes, leading to well-demarcated areas of depigmentation. So it is commonly shared with other autoimmune disease, but we are very specific in the autoimmune disease to worry about, and that is hypothyroidism, type 1 DM, and pernicious anemia. Most of the time, it's not going to exceed these three: hypothyroidism, type 1 DM, and pernicious anemia. Don't worry about don't worry about SLE, don't worry about rheumatoid arthritis, don't worry about anything. Most of the time, this is going to be the other autoimmune disease you want to rule out. They appear sharply demarcated, depigmented markers and patches due to the destruction of the melanin in this part by the autoimmune inflammatory process. So the melanocytes are already gone and the melanin content are lost. So you can have it in the hands, that's the acral distribution. You can have it in the face, you can have it in the genitalia. So most commonly you see it in the hands and the face. Of course, genitalia is covered. You don't know if somebody has genitalia vitiligo, but the common one that we see is the acral one and the facial one. Your diagnosis is clinical, right? But you must rule out other autoimmune disease like your anti-thyroid antibodies for your thyroid autoimmune thyroidism, maybe like Hashimoto thyroiditis, type 1 DM. You rule out your anti-GAD antibodies, pernicious anemia, anti-intrinsic factor. If you do your histological examination, there will be absence of the melanocytes and melanin pigments. If you do your wound lamp, it's going to, make that area more conspicuous, and you can see that it's different, from the other area. So it's going to appear blue-white with your wood lamp. How do you treat? So you have to separate it into stable or rapidly progressive. Is it stable or rapidly progressive? If it's rapidly progressive, give your oral glucocorticoid. If it's stable, you can apply your topical corticosteroids, and you can also do your behavioral stuff like application of sunscreen. You wear sunscreen, and you can also apply cosmetics to cover up. So if it's stable, topical corticosteroids, you can apply your tacrolimus ointment, or your UV light. Those are the common ones I know they can ask. If it's progressive, oral glucocorticoid is the mainstay. Don't forget that. Then use sunscreen to prevent burn and also cover up with makeup for cosmetic purposes. Moving on to the eyelid lesions. We have the xanthelasma, which we are very familiar with. You just see yellowish plaques in the medial part of the eyelids. It's very common in people that are having hyperlipidemia or people with primary biliary cirrhosis, because they can also have hyperlipidemias too. Sometimes your serum total cholesterol may be normal. Treatment is not necessary. Just treat the underlying cause. Odolium. Odolium is worse than chalazion. Odolium is also known as style, and it is painful. You are going to see painful erythematous tender lesion, nodules on the eyelids due to obstruction or bacterial infection of the tear gland, the meibomian gland, or the gland of Zeiss. What do you do? The implicating organism is usually Staph aureus. You just, most of the time they will resolve spontaneously. Just apply warm compress, to help with the healing. But most of the time they will resolve spontaneously. So most of the time they just want you to either identify the condition or just talk about the treatment. Chalazion can be a complication of odolium And this is just when you have a cyst that is painless, unlike a duodenum that is painful. Chalazion is chronic and it is painless, and it is due to obstruction of the eyelid gland. Sometimes duodenum can become chalazion after the infection resolves. So look at the question. Is it painful or painless? If it's painful, duodenum. If it's painless, chalazion. Most of the time too, you apply compresses too for chalazion. It can also resolve with that. Epidermal inclusion cyst. This is a cyst that is lined by epithelium that contains most of the time they contain keratin and granulation tissue. That's why they are called epidermal. The epidermis contains keratinocyte, which secretes keratin. So they appear dome shape, they are firm, they are freely movable, and they are often surrounding a hair follicle. Yeah, fine, this is good to know. And sometimes they can have cheese-like discharge because of the keratin. But what do we need? What we need is the buttonhole or the dimpling test. Once you pinch it, does it dimple? If it does not dimple, your answer is epidermal inclusion cyst. If it dimples, your answer is dermatofibroma. Most of the time, it will resolve spontaneously, but it can recur. That's the problem of the cyst. But if you see a large cyst that is discomforting, you might need to excise. So I have a better picture of what you are going to see for your epidermal inclusion cyst. And this is how it's going to look like. Sometimes you can have discharge, cheesy discharge. If you try to indent, it's not going to dimple. It's kind of taut. It has dome shape and it does not dimple. Epidermal inclusion cyst. For the dermatofibroma, contains fibrous tissue, hyperproliferation of fibroblasts. So they are small, less than 1 cm, and they are like this. They can dimple if you apply pressure. So that is the buttonhole sign or your dimple sign. It's benign, just like your epidermal inclusion cyst, but you can excise if it's worrisome or for cosmetic reasons. Hidradenitis suppurativa. It is chronic inflammation of the folliculopilosebaceous unit. They become inflamed, they become painful, and you see like multiple sinus tract that is discharging foul-smelling product. Usually occurs in people that smoke. That's what I don't want us to forget. Smokers, people that are obese, people with metabolic syndrome, or people with family history, and it's common in black race. So if you have a family history, you are obese, diabetes, metabolic syndrome generally, or you're a smoker, they can develop hidradenitis suppurativa. It is due to inflammation of the folliculopilosebaceous unit. And usually worse than this, is disfiguring. This is mild. This is nothing. If you look at hidradenitis suppurativa, very bad. Very, very bad. Sinus tract. Look at this. See this. Look at this. This is not bad too, but all this. You can see this carrying the discharge are usually foul smelling. Smokers, metabolic syndrome, DM, obesity, family history, black race, risk factors. So it's clinical, you don't need any biopsy, and your first line is your oral antibiotic. Don't ever forget. Apply your topical clindamycin. Very important. Can apply incision and drainage. Do your proper wound care and dressing, and surgical excision, and skin grafting. If it's very, very severe, you can excise those sinus tracts and apply grafted skin to that area. So sometimes it's kind of relapsing. To keep coming back as you are treating, it's coming back. It's not responsive to treatment. So try and modify these factors, weight loss, and stop the smoking. Very important. So don't forget the first line. Give your oral antibiotics like your clindamycin, your wound dressing, right? Weight loss, smoking cessation, incision and drainage. And sometimes you might need to excise the sinus tract and graft that area with skin. Ichthyosis vulgaris. So this guy here is very similar to atopic dermatitis in terms of the pathophysiology. Both of them occur due to mutation in filaggrin. So there's loss of the epidermal barrier, there's problem with keratinocyte desquamation, and they appear dry. So you tend to find it in the extremities and the trunk, particularly the extensor surface, and it spears the face and the flexural surface. So you see them having this fish scaly kind of appearance. Once you see this, you know that this ichthyosis vulgaris is very easy to identify. So they have problem maintaining hydration of the skin due to problem with the epidermal skin barrier. So it's clinical. Don't forget, you want to apply moisturizer. That's all you need to do. Encourage everyday bathing. They are like taking their bath every time, washing off those scaliness, and apply your keratolytics, salicylic acid, your glycolic acid, apply emollients and moisturizers. Daily baths every time. Age-related skin changes. So I have it categorized: skin wrinkle, solar elastosis, and senile purpura. You don't need to worry ourselves. With age, you have damage or loss, apoptosis of the collagen fibers, elastin fibers, and the tautness that they give the skin is lost, and the skin starts to wrinkle. Age-related skin changes. They can develop senile purpura, which is like bleeding into the extensor surface of the hands. I've seen this so many times. Senile purpura, very common, and this is because with aging you have the generation of those elastic fibers that provides support for the connective tissues surrounding the vessels. You see something like this, you think that maybe they were injured or something. It's very classic in elderly people, because the elastic fibers are no longer there to provide support within the perivascular connective tissue. So the vessels are weak and fragile, so they easily break out and bleed, causing senile purpura. The last is solar elastosis. So with aging and increased exposure to UV light, you have degeneration of the collagen fibers and the elastic fibers. They kind of cross-link and they deposit in the skin. That impacts a thickened appearance of the skin and a yellowish color. So once you see thickened yellowish skin with wrinkle, that's the solar elastosis until otherwise proven. You have seen senile purpura have shown us, and also the wrinkling. Age-related changes. What do? You can give botulinum toxin here to paralyze our skin so that you can relax the muscles and the wrinkling will reduce. The senile purpura is due to the ecchymosis in the older patient due to areas exposed to repetitive trauma such as the extensor surface. It is a benign finding. No need for further workup. So they just put that picture in our exam. They can ask us what's the pathophysiology. They can ask us what do you do next. No further workup is required. Sun protection. Sometimes we might need to protect ourselves from UV light because UV light can cause serious damage. I've talked about one, solar elastosis. UV light can worsen vitiligo. Use sun protection. Sun exposure is a very highly important risk factor for many skin cancers. Melanoma, squamous cell carcinoma of skin, basal cell carcinoma. Sun is the implicating factor. You might need to protect yourself from sun. How do you do this? You use sun protection factor. We have sun protection factor 30, sun protection factor 50. The higher you go, it doesn't mean that you are going to be getting higher protection. So once you have your 30, you are okay. In fact, 50 might have some diminishing returns on the effectiveness. So it's better for you to just stay with your 30 and be okay. Just apply it the way you should. So Before the individual goes out, they apply their sunscreen. If the individual swims or does some exercise that leads to sweating, with washing off of the sunblock, reapply it every 2 hours after that swimming or the sweating activity. Don't say that the sunblock is water resistant. Reapply it. That's what you are going to be picking in your exam. What is sunburn? Sunburn, I see sunburn as type 1, as superficial burn injury, in which you just have like vasodilation of the dermal blood vessels, causing blood flow to the skin, giving the erythematous appearance. And sometimes you can have some blisters being formed due to chronic exposure to sun. What do you do? Sometimes they can have some systemic symptoms. They can be fever, headache, vomiting, depending on the severity of the sunburn. Most of the time, you just want to cool that skin from the burning. Apply your cool, moist compress and emollient, with aloe vera for topical relief. And if the lesion is painful, give NSAID. It's usually tender to touch. It's usually painful. It's usually edematous. It's usually erythematous. So you need to give moist compress, emollient, and NSAID. If the individual is showing signs of heat exhaustion or heat stroke, you might need to hospitalize, give your IV fluid, and proper wound care. I think I have a question somewhere here. Yeah. A 13-year-old boy is brought to the physician because of pain and redness on his back for 2 days. He returned yesterday from a vacation to East Africa with his parents, where he took multiple rides on hot air balloons. His vitals are within normal limits. Examination shows a tender non-periodic erythematous rash with edema. A tender non-periodic erythematous rash with edema. That's all you need. Covering the external surface of the body, the forearms, the shoulders, the upper back, and small patches of skin exfoliation. The rash becomes pale when pressed and then rapidly regains color. So that means that the rash is blanching. So, the remainder of the examination shows no abnormality. Which of the following is the most appropriate next step in the management? He has gone to East Africa. What is peculiar to East Africa? Anybody knows?
Sun exposure
Sun
is dry.
exposure. Look at it. They said where he took multiple rides on hot air balloon. So, what do you think we want to do for this patient?
Let me see. Does he know the existing? Use emollients. Can you use
Yes.
emollients as
So, which one are we picking?
aloe vera
Aloe
based
vera.
moisturizer?
Yes. So, cool, moist compress. Apply your emollient. This patient is experiencing some pain, is tender. Give your NSAID. If the patient is dehydrated, give your IV fluid and other corrections as necessary. That is all you do. Very easy. So, aloe vera moisturizers is here. Emollient with aloe vera for topical relief and NSAID for the pain. Sunburn. Moving on to the neoplasm of the skin. Seborrheic keratosis is the first we are looking at. This is a skin tumor which is common in people more than 50 years. Etiology is not known. Very similar to melanoma, but doesn't have any malignant potential. What are you looking for? You are just going to look for history of a waxy or warty, velvety or greasy plaque with superficial keratin cysts. You see the cysts inside. These are the cysts. This tiny thing here. This thing, this thing, this thing, this thing. Once you see that, and it looks like stuck on appearance, it looks as if you press it to the skin. like you gummed it to that skin, stuck-on appearance. It looks waxy. Sometimes they can describe it as being greasy, like oily. That's your seborrheic keratosis you are dealing with. Don't mistake it for melanoma. You can see that the margin is well defined and the color is uniform. It does not follow the ABCD characteristics of melanoma. What do you do? Clinical diagnosis. If it's multiple, rule out what? Rule out a malignancy. You know, if you have multiple seborrheic keratosis, rule out, malignancy. And that is what you have in your lesser trailer sign. Multiple seborrheic keratosis at the back. It could be associated with what? A gastric adenocarcinoma. Rule out malignancy. What do you treat? Exercise, just remove it. Cryotherapy, surgical excision, laser, whatever you want to use. Shave, just exercise. Next is actinic keratosis. Very easy to identify. This is just erythematous, scaly lesion, usually within the sun exposed area of the body, particularly the face. And the lesion is going to be described as being rough, erythematous, and scaly. Once you see that, please go and pick actinic. Don't even think about it. Just go and pick actinic. Rough, scaly, erythematous lesion on the face. No ulcers. Actinic keratosis, especially in somebody that is more than 50 years. That is actinic keratosis, and there's a 5 to 10% chance of progression to squamous cell carcinoma of the skin. They can have some people like texture. Diagnosis is clinical. If you want to separate from squamous cell carcinoma of the skin, do your biopsy. How do you treat? Just don't forget your 5-fluorouracil and your topical imiquimab. You see, your topical imiquimab and your 5-fluorouracil, they are very good for pre-malignant lesions like actinic keratosis or localized form of basal cell carcinoma. You can apply your topical 5-fluorouracil or your topical imiquimab. Which other lesion can we apply the imiquimab that we said today? Anybody remembers?
What?
What? Good job, Dr. Antonia. Can you use it in someone that is pregnant?
No.
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 Which one will you use?
Trichloroacetic acid.
Good job. Good job. So, do your cryosurgery, apply your 5-fluorouracil, apply your topical imiquimab, destroy that lesion. And of course, ensure sun protection so that you don't facilitate progression to squamous cell carcinoma of the skin. I think I have a question here. Let's see. Okay, there's a question here. A 68-year-old man comes to the office 3 months after noticing skin changes on his scalp. When he scrapes off the crust of the lesion, it reappears after a few days. Occasionally, his scalp itches or he notices a burning sensation. He had a mole removed on his right arm 5 years ago. He is a retired winemaker. Vitals are within normal limits. Examination shows multiple rough patches on his scalp. The photograph is shown. What is the most likely diagnosis? So what do we have here? What do we think this is?
Actinic keratosis.
Why are you saying actinic keratosis? Why?
It's flaky and scaly.
Yeah, you can see the erythematous scaly lesions on the head. Head is unexposed. So, pick actinic keratosis. And that man is 68 years. High risk for that. Okay? Don't forget the treatment. Cryosurgery. Apply your 5-fluorouracil or your imiquimab. You are going to be fine. Cutaneous squamous cell carcinoma. So this is the second commonest skin cancer. The commonest is basal cell. One thing about cutaneous squamous cell is that it has locally destructive effects. It can metastasize. It can even cause death, and it can invade into the nerves, causing numbness, causing paresthesia. The single most important risk factor is sun exposure. Know that. It can be caused by exposure to chemicals too, like arsenic, radiation, wounds, chronic wounds like burn injury, osteomyelitis that is non-healing ulcers. They can all lead to cutaneous squamous cell carcinoma. People with chronic immunosuppression are high risk for developing it. There is a low-grade type of squamous cell carcinoma that you call keratoacanthomas. And what you are going to see is a rapidly growing dome-shaped nodule with a central keratotic plug. Once you have that, that is keratoacanthoma until otherwise proven. A rapidly growing dome-shaped nodule with a central keratotic plug. That is all you need. Keratotic plug. You see, I want to show you a lesion like this, and they are telling you sun exposed area, and there's central keratotic material. Just go and pick keratoacanthoma. It is a low-grade form of squamous cell carcinoma. It can occur in older adults with sun-damaged skin, arising from actinic keratosis. And what do you need to know about the presentation? They will usually appear ulcerated. That's important. They are usually erythematous and they are ulcerated. You remember that our actinic keratosis, I said there's no ulcer, just erythematous scaly lesion. But once it becomes squamous cell carcinoma of the skin, it becomes erythematous and ulcerated. And they can be bleeding easily when you touch them. Very important stuff. Look at this one now. This is an ulcer here in the head. I cannot be thinking of anything else aside squamous cell carcinoma of the skin. I've talked about the neurologic signs because it invades the nerves, can cause numbness and paresthesia. That's another thing. Basal cell rarely spread, but squamous cell can spread and cause death. Majorly ulcer is a type of squamous cell, and it appears following background scars from injuries, burns injury, ulcers that is non-healing, that can all transform into squamous cell carcinoma that I call a Majorly ulcer. So it usually takes 5 to 10 years to develop. So once you see them painting a non-healing ulcer, know that it is squamous cell carcinoma they are trying to tell you about. Arsenic exposure can cause the ulcer, usually in the palmoplantar distribution of the hands and the soles of the foot. They can have what you call squamous cell carcinoma in situ. You call that the Bowen disease. Dr. Antonia, you want to say something?
No.
Okay. Squamous cell carcinoma in situ, that is the Bowen disease. The squamous cells are abnormal, but they have not breached the basement membrane. So, the lesion is usually well defined. And you can also have what you call the erythroplasia of Kierat. That's another squamous cell carcinoma in situ, but you find this within the glans penis. You see them, they appear reddish, valvet-like plaques. Once you see an individual having valvety, erythematous plaques in the glans penis, think about a potential premalignant squamous cell carcinoma, which you call the erythroplasia of Kierat. Erythroplasia. Plasia of Kierat. Glans penis. So it's Bowen disease of the glans penis. So this is it. You can see this. You can have burning sensation sometimes. This. Reddish lesion. It is squamous cell carcinoma in situ. It is a type of Bowen disease. Squamous cell carcinoma from actinic keratosis rarely metastasized, but the one you find in the lower lip, very important stuff. Squamous cell carcinoma can occur in the lower lip, and if they occur there, they they have a very high chance of metastasizing. How do you treat? How do you make your diagnosis? Clinical, but you can confirm with doing your shave biopsy. And what are you going to see? By the time you start seeing keratin pairs, you know that they're talking about squamous cell. Keratin, squamous cell. And you are going to see full thickness atypical keratinocytes that have invaded into the dermis. Of course, it is no longer squamous cell in situ, it has invaded into the dermis. How do you treat? Surgical excision or more surgery? Please, always have your more surgery at the back of your mind. Don't forget it. Particularly if it is affecting cosmetically sensitive areas like the fingers and the distal extremities. You don't want to excise and be causing scar and abnormal disfigured pattern in that area. Like, just imagine you are disfiguring somebody's face. You can imagine. So in that kind of person, you don't want to do surgical excision. Instead, you are going to do the most micrographic surgery, in which you are going to be removing the skin lesions in layers, slices, and you are going to be examining if you have cancer cells as you are removing. It might waste time, but it's going to be cosmetically good. If you do your surgical excision, probably it's in the stomach or the chest or whatever. Your surgical excision with at least 4 to 6 millimeter margin. Very important stuff. If the lesion has a very high metastatic potential, you might have radiation or your chemotherapy. So don't forget your surgical excision. Don't forget your mole surgery. The next is the basal cell carcinoma of the skin. This is the commonest malignant skin cancer. It is slow growing. If they ask you which cancer has a low tendency to metastasize, basal cell carcinoma will be correct. The gliomas of the brain too will be correct. Basal cell carcinoma is slow growing and locally destructive, but it has no metastatic potential. The biggest risk factor, just like the squamous cell, is what? Sun exposure. The lesion is very common in people that have fair skin and are exposed to sun, and sometimes it can be genetic. So somebody that develops basal cell carcinoma at a very young age without history of chronic sun exposure, you think about Golin syndrome, inherited basal cell nevus syndrome. So they have many basal cell carcinoma, plenty. They have some cranial problems. They can have ovarian fibroma. They can have hypertelorism. So many issues like that. You can check it up. Microencephaly, hypertelorism, medulloblastoma, ovarian fibroma, alongside with multiple basal cell carcinoma at a young age. That is Golin syndrome. It is an inherited form. What are the types? We have the nodular type, which is the commonest. We have the superficial type and the sclerosing type. The nodular type, the superficial type, and the sclerosing type. So the commonest one is the nodular type. What do you need to look out for in your exam? They will tell you, squamous cell, you are seeing ulcer in a nodule. For the basal cell, you are going to be seeing a pear-like. Pear. When I say pear, I mean this. I mean pearl, like P-E-R-L. Pearl, shiny lesion with telangiectasia. Once you see that, that is basal cell carcinoma. That is basal cell carcinoma. Very common with the nodular type. The superficial type, we just have maybe your plaques with central atrophic regions. The sclerosing type will just appear like what do you call it now? As if you have a lot of connective tissue being deposited. But the commonest one is your nodular, and that's what you need to remember because it makes up 80%. That's too significant to ignore. 80%. So don't waste your time palming the other ones. Just focus on the nodular subtype. Look at this. If we look at this lesion, we can see that this is shiny. This looks like a pear. This is basal cell carcinoma. This is the way it looks like. Very shiny. It's not disfiguring like that, like what you see in the squamous cell carcinoma. So they look pearly white, dome shape, which may ulcerate, may bleed, but there's going to be overlying telangiectasia, just like we can see here. You can never miss it. You can never miss it. Do your shave biopsy. Here, we are not going to be looking out for keratin pairs or atypical squamous cells. We are looking for nests of basophilic cells, basal cells, basophilic cells invading into the dermis. That is it. That is what you need. Basophilic cells invading into the dermis. That's what your biopsy is going to reveal. What do you need to do? If the lesion is present in the face, the extremities, do your more micrographic surgery. Otherwise, do your surgical excision, which can be achieved by curettage, by cautery, electrocautery, by cryotherapy. You can even apply superficial radiation, anyone you want to do. Take note of that. We remember the ABCD of melanoma. The A for asymmetric melanoma. If you divide it into 2 equal halves, you are going to get 2 unequal portions. If you want to divide it rather, you are going to have 2 unequal portions. The border is irregular, the color varies, diameter usually more than 6 cm. The changes in the color, in the shape, the diameter with time. I didn't put any question. Solve questions by the time we go out. Now, it is the commonest life-threatening dermatology. It's one of the common, or the most common rather, life-threatening dermatologic disease. Bad prognosis. The risk factors include fair skin, tendency to burn, increased sun exposure, just like the other ones. And people with some premalignant lesion like congenital melanocytic nevi have a high risk of developing melanoma, or people with increased nevi generally, or dysplastic nevi, high risk. Immunosuppression is under high risk, just like in basal cell, just like in squamous cell. There's a familial tendency, which you call the familial atypical mole and melanoma syndrome. So there's a family history of development of melanoma, and you have multiple mole being present in that individual. That's your familial atypical mole and melanoma. This is the example of the congenital melanocytic nevus. So you can see that the border is irregular. You can see that the color is constant. If I divide this into 2 equal halves, I can get. So this is not a melanoma. This is a congenital melanocytic nevus. You can see the hair growth. It shows that this is a congenital stuff. This probably at the back of the patient. What are the types of melanoma? This is non-basal cell, that is nodular, superficial, or sclerosing. This is also superficial spreading, nodular, acral lentiginous, lentigo maligna, or a melanocytic. You don't need to cram anything. Just know your ABCD, you are fine. The commonest form is the superficial spreading, as opposed to basal cell, that the commonest one is the nodular. This one is superficial spreading, so it spreads superficially across the skin surface. It makes up 60% of all melanomas, and the incidence increases with age. So you don't see it usually in the sun exposed area, you see it in the trunk and the legs. And a prolonged horizontal growth phase allows for early diagnosis when it's still confined to the dermis before it starts growing downwards. So you quickly want to biopsy and start treatment immediately. The nodular is the one that grows downwards into the skin. The acral lentiginous is the one that affects the limbs, like the palms, the sole. Very common in Asian and blacks. The lentigo maligna is the one that developed from a solar lentigo. So solar lentigo is just more like hyperproliferation of the melanocytes due to sun exposure. Then they can now transform into lentigo malignant form of the melanoma. So you see them more in sun exposed areas like face. Like the image D is showing the lentigo malignant form of melanoma. We can see this is a lesion, this is the entire lesion. We can see that the color is variable. Some are white, some are clear, some are black, some are brown. We cannot define the lesion. The border is irregular. Classic melanoma. And you can have a melanocytic melanoma in which it can develop from any of these. Any of these, but you will not see any dark pigment. They lack the melanin. That is a melanocytic type. So the malignant melanoma usually develop from the epidermal basal layer, where the melanocytes are formed. That is where you find them. And they can go to any part of the body, but usually they start from the head, so they can go to the brain, can go to the chest, the lungs, abdomen, the liver, and also to the fat. So don't forget your ABCDE criteria. Once you are seeing one or two being positive, you know it's likely to be melanoma. You can do your excisional biopsy, you find hyperproliferation of your melanocytes, and there's something you call the Oakley-Duckling sign. So sometimes you can have different moles or nevus, which are like benign form of a melanoma, and you just see a different lesion that is conspicuous and different from the surrounding moles. You have to biopsy to rule out melanoma in that kind of situation. I don't think I have an image of the ugly duckling sign. So let me show us what I mean. So the ugly duckling sign. So I don't have a very good image here, but sometimes you can just show a picture of flat lesions, moles, and you just see like a raised one somewhere that looks distinct from them. You have to biopsy that one to be sure you're not dealing with a melanoma already, which has transformed from the nervy, from the mole. So it's very, very important. It's a pity I don't have an image, but just have that at the back of your mind, a ugly duckling sign. That's a 90% sensitivity for melanoma. So you stage your melanoma by your breast lobe thickness, so depth of invasion downwards into the skin, as well as your TNM staging. Once the melanoma, it is a poor. How do you treat surgical excision? Surgical excision. You don't do the Mohs micrographic surgery here typically. You do more excision early. Do more excision. Your sentinel lymph node biopsy can be helpful with staging, but it does not improve survival. And sometimes if it's recurrent or if it's metastatic, you have to add chemotherapy, biologic therapy, or radiation. But don't forget, mainstay is still surgical excision. Surgical excision. So early melanoma, they have a very low risk for recurrence, but they can develop new melanomas. That's the problem. Why the advanced one, they can recur. That's the problem. Kaposi sarcoma is due to human herpes virus type 8. You just see violaceous, purple-colored lesions, macules, papules, nodules in the body. They can affect the lungs, they can affect the GI. The person can have hemolysis, can have hematemesis, different presentation. Very common in people with background HIV. What do? Start them on heart immediately. If heart doesn't work and the lesions are still there, recurrent, give your PID, which is what? Your widespread or internal disease treats with systemic chemotherapy, which is paclitaxel, interferon alpha, and the doxil. But start your heart first. Very important stuff. Don't forget, Bartonella isletoi and Bartonella quintana are causes of bacillary angiomatosis. They look exactly like Batonella incele, like Kaposi sarcoma. You might not see history of background HIV. Sometimes the lesions are not purple, they are not purple, they can be red. And by the time you do a biopsy, you will see neutrophilic infiltrate instead of lymphocytic infiltrate. To treat them, use erythromycin. To treat Kaposi, use your ART. If it's widespread or internal, give your PID, paclitaxel, interferon alpha, doxorubicin. Mycosis fungoides, that is what you call cutaneous T-cell lymphoma. You have abnormal lymphocytic proliferation of the T cells, and they have increased affinity for the epidermis. That's where they want to go to. It's chronic, very common in men. They have the lining faces, just like we are saying in people with leprosy. You can see it has 3 phases: the papular phase, the plaque phase, and the nodular phase. So you are going to be having these lesions developing. Some they start at papules, they progress to papules, to plaques, and they progress to nodules. And they can have lymphadenopathy. Sometimes the lymphadenopathy might be a reactive lymphadenopathy to the hyperproliferating lymphocytes. Not that the tumor has infiltrated them. So that's what we call dermatopathic lymphadenopathy. But later, the tumor will disseminate from the skin to the organs like the lymph node, the liver, and the spleen. So hepatosplenomegaly is not uncommon in people with mycosis fungoides. So they have these skin lesions, which is usually puritic with associated lymphadenopathy and liver and spleen enlargement. What is going to help you is what you call the cells that you are going to see, whether the lutein cells or the cells. So they are going to be showing cerebriform lymphocytes. So I'm going to show us a picture. And before we get there, aside all these things I've said, you can have a phase of this mycosis fungoides in which the lymphocytes will disseminate into the blood. You call that the Sézary syndrome. And this is called the leukemic phase of the mycosis fungoides, in which you see the Sézary cells in the peripheral blood. And there's going to be widespread erythroderma and lymphadenopathy. So, if you do a biopsy of the lesion, you are going to see partial microabscess, which are just like T cells which are arranged within the epidermis. And you're also going to see some particular T cells. That is what is going to give you your diagnosis. You call them the cerebriform lymphocytes. So the nucleus is going to look as if there's brain folding in the nucleus. So brain like, gyri. So let me show you the Sézary cells. So you're going to see them appearing like this. You can see like brain infolding. You can see this convolution. Yeah. So once you see this is it again. This is Sézary cell or the lutein cell. Classic for mycosis fungoides or your Sézary syndrome. Don't forget the rash. Don't forget the lymphadenopathy. Don't forget the hepatosplenomegaly that they can have. How do you treat? Phototherapy is a mainstay. PUVA. PUVA means you are giving ultraviolet radiation with psorialine. Psorialine is a chemical that you combine with the UVA in phototherapy. You can use that. You can expose them to total skin electron beam irradiation. And for more extensive advanced disease, is still radiation, that you can use to treat them. So sometimes you can use chemotherapy, steroid, blah, blah, blah. Don't worry yourself about that. Just remember your phototherapy and your irradiation. One of them will be seen in the option. I can assure you if they bring it out. Cherry hemangioma. So you need to know that this one is an hemangioma, abnormal proliferation of the capillaries in adults. It is the most common benign vascular tumor, and it increases, in appearance with age. It does not regress. So you might need to excise it for cosmetic purpose. That's it. That's cherry angioma. Don't forget, it doesn't. Once they tell you that it does not regress, know that it is cherry angioma that you are dealing with. Don't pick another thing, please. Now, moving on to the infantile hemangiomas. These, are also known as the strawberry hemangioma. So the first one is cherry for adults. The strawberry or the superficial or infantile hemangioma. That's the three name: superficial, infantile, strawberry hemangioma. You are seeing an infant usually within the first few weeks of life. They are benign and they usually regress spontaneously. They start regressing at about 9 months to 1 year, and by 5 to 9 years they are gone. So don't forget that. Sometimes you might need to be more active in your treatment by giving beta blockers because of what you call face syndrome. If somebody has infantile hemangioma, you might need to evaluate further, particularly in people with the face syndrome. The P standing for posterior fossa abnormalities, a problem with the cerebellum. The H standing for hemangioma of the cervical region, the face cervical region. The A stating arterial cerebrovascular anomalies, maybe stenosis of the cranial vessels, absence of some cerebral vessels and the likes. C for cardiac defect like aortic coarctation and interrupted aortic arch, BSD. High problems, glaucoma, cataract, and the likes. Face syndrome. So if you see anybody with hemangioma involving the cervical and facial region, evaluate for the face, check. Do your CT, do your MRI for the brain to see if there's a problem with the cerebrovascular structures. Do your echo for the heart to see if there's aortic coarctation or there's VSD. Evaluate for the eye lesions, just to rule out any associated problem. You might need to do some further evaluation in people with more than 5 cutaneous infantile hemangiomas. So if the question tells you there's more than 5, what's the best next step? The best next step is to do an abdominal ultrasound to look for the hemangiomas in the liver. There is a high chance of you forming this hemangioma in the liver with arteriovenous connection. If you see anybody with the facial hemangiomas, evaluate for the face, just like we have said, by doing your echo and your MRI. You also need to do laryngoscopy, particularly if it involves more of the cervical region, to rule out compression of the larynx. If there is lumbosacral involvement, you need to do a spinal ultrasound to see if the nerves or the spinal tissue is not affected. If there's any disfigurement, there's affectation of the face, affectation of the larynx, affectation of any part that is causing distress, you give propranolol, beta blockers, to shrink the hemangiomas. Very important stuff. Pyogenic granuloma. So this is a lobulated capillary hemangioma that you usually see in the fingers, the trunk, oral mucosa. Don't worry yourself about the location. But just know that if you see an hemangioma that bleeds easily, slight touch is already bleeding, think of pyogenic granuloma. And it's very common in people that suffer some trauma or pregnant people. Most commonly, the point scenario of an individual that is pregnant because of increased expression of vascular endothelial growth factor. What do? Do not forget topical silver nitrate to a very high yield. You can use topical silver nitrate, you can excise it surgically, or you can do your laser removal. If it's pregnant people, you might not need to do anything. Once they deliver, it will regress spontaneously. But otherwise, if the patient is not pregnant, do your surgical excision, laser therapy, or your silver nitrate application. This is an example of your pyogenic granuloma in the oral mucosa, in the trunk. The last is what we call necrobiosis lipoidica. This is very straightforward. You are just going to be seeing yellowish, reddish plaques, that has central atrophic centers. You can see some dilated vessels in some other types, and it's very common in people with DM. So once you see this, you want to do your HbA1c or your oral glucose tolerance test or your fasting blood sugar. Rule out diabetes immediately. Very important stuff. And you see it usually in the anterior aspect of the leg, the tibia, pretibial area, just like in erythema nodosum. Central epidermal atrophy, yellowish, reddish plaques. So, we come to the end of the dermatology.
Thank you, Dr. Babawale. Please, I don't know if you can take, you said face.
Yeah.
If you see
Face.
P-H-A-C-E. It's
face syndrome.
Yeah, face. Is it P-A-C-E or what? Face. Okay.
P-H-A-C-E.
Okay, so the P is what?
The P is posterior fossa anomalies, like issues with the content of posterior fossa, like cerebellum.
Okay.
The H is hemangioma, involving the cervical and the facial region. So once you see this, this is what you are going to see. Then you rule out the others. Do you understand?
Okay.
So A is arterial cerebrovascular anomalies, issues with the MCA, the ACA, PCA. C, cardiac defect. You do your echo to check for VSD, ASD, coarctation. Then I is eye anomalies, glaucoma, cataract, strabismus, and the likes. So anybody having hemangioma involving the face that's already causing, that has a very high tendency to cause facial eye problems, you have to give propranolol. Do you get the one affecting the larynx, compressing on the larynx? Maybe it's on the neck, compressing on the larynx. You need to give propranolol to shrink it so that the person does not die.
Okay.
So that is that. Any other question? Okay. I think we are all good. So I'm so sorry. I'll be able to do the recipe tomorrow. So I'm so sorry because of my so many engagements. The next time I'll be free would be on Thursday. I would need Wednesday to tidy up the recipe so that I can take us on Thursday.
Okay.
But Dr. Babarinde will get back to us on what he can take before that time. Hopefully. So.
Okay.
Thank you so much.
Thank you.
Bye bye, everybody. See you some other time.
Bye.
Bye.
Yeah, good night.